Yes, sir, we are live now.
Shall we start?
Yes, sir, you can start.
Okay. Good afternoon, everyone. First of all, I welcome you all in this mega event of RSSDI 2021. Again, we are meeting on the virtual platform, and this is all because of the huge efforts of Dr. Bansi Sabu and Dr. Sanjay Agarwal and all the team of RSSDI 2021. As we all are aware that this is one of those conferences of India which is having its mark at the international level, at the national level, at the regional level, and our speakers, our faculty, and at the same time, the topics we select for the RSSDA 2021, they are of such an important level that we shall be delivering talks, we shall be performing live streaming sessions from various dignitaries, and everybody in the field of diabetes in and around will be benefited a lot. To begin with, I invite Dr. Jazeet Singh Wazir, who is a renowned name in the field of diabetes and endocrinology, and he holds a decade of experience in the medical field. He is presently attached to the prestigious Medanta Medicity, Gurgaon, and Sadhu Vaswani Mission Medical Center, New Delhi. He is one of the prime faculty members at the Center for Advanced Diabetes Therapy and Technology. He is the pioneer in the weight management program at Medanta. He has a large number of publications and paper presentation to his credit. Dr. Wazir has an active involvement in clinical trials related to the field of diabetes and metabolic syndrome. Dr. Jasjeet, I welcome you to the platform. Kindly begin in the field of chronic diarrhea in a patient with diabetes, how to evaluate. Welcome, sir. Sir, unmute yourself, Dr. Jasjeet.
Thank you very much, Dr. Sodi, for the kind introduction. And I thank the organizers for pushing me up the line for my presentation. It's always a pleasure to be back on the scientific platform of RSSDI. So when Dr. Bansi discussed this topic with me, my first instant answer was, we all talk about technology, new drugs, new innovations in the field of diabetes. So when I came across this topic first, I went back to the OPD thinking about sitting there. And that's where I thought that this is the kind of topic I should take up. It required me to read a lot, brush up the knowledge, because this is an extremely common problem that we all treating diabetes face day in and day out. So on one hand, we have a lot of development in a lot of fields, therapeutics, technology. However, the chronicity of diabetes is related to a lot of these problems, which I feel at this point of time are not addressed to the level which they should be. So hence today in the next 15-20 minutes, I would be talking about chronic diarrhea in diabetes and using the acronym of DD of diabetic diarrhea. So our targets for therapy in diabetes are to prevent acute and chronic complications. And each one of these slides I have prepared as if a patient is sitting in front of me. It's not loaded with numbers or randomized controlled trials, but I felt that a patient is sitting in front of me when I was preparing these slides. So whatever we do in therapy of diabetes is primarily related to prevention of acute and chronic complications and to provide maximum quantity and quality of life. Now, the quality of life aspect is extremely important. Again, in the outpatient setting, see these three problems which are enumerated on the slide: GI disorders, peripheral neuropathy, and erectile dysfunction, to me as a clinician, contribute majorly and have a major impact on the quality of life. Hence, we need to understand them, appreciate them. When a patient comes up with these symptoms, think of the possible reasons and offer them solutions. And that's how we are not just adding quantity of life, but we would be majorly contributing to the patient's quality of life. So it's like a happy, healthy life if or with for a diabetic without complications. And that's how I looked at the topic when I was preparing the slides. So coming to some factual important things about diarrhea in diabetes. So this is a specific entity. It's primarily a diagnosis of exclusion. The prevalence of GI disorders in diabetes range to as much as high as 70%. Again, we must go back to our OPDs and see how commonly the patients talk about their GI symptoms, be it upper GI, mid GI, or low GI symptom, which I'll enumerate in the subsequent slides. The prevalence of GI disorders, including diabetic diarrhea, are somewhat more prevalent in females as compared to males. There is some data talking about the fact the level of the control and the duration of diabetes may be contributing to the occurrence of diarrhea in diabetes and other GI disorders. Presence of psychological comorbidities like depression and anxiety aggravate the presence of these symptoms, or the symptoms get aggravated in patients who have pre-existing psychological comorbidities. And there have been studies which have shown with the onset of depression, there is a 3 times greater onset of GI symptoms in patients with diabetes. And once these mood disorders are taken care of, there is a 2 times greater chance of resolution of GI symptoms. So just by this data which I've shared, automatically comes to our mind that there is something working with the neurological system. Would it be the brain, the peripheral nervous system, which is actually contributing to the occurrence and maybe a solution to GI related problems in diabetes, including diabetes diarrhea? Now, if we talk about longevity, there's not much data about GI related symptoms or diabetic diarrhea contributing to mortality. However, these symptoms have a major impact on the quality of life. And as I said in the beginning couple of slides, that the ideal treatment of diabetes is one which is contributing to both quantity and quality of life. Interesting data. We'll have a discussion and a lecture on gastroparesis. I won't go in the details of that, but so important is the impact of GI disorders in diabetes that gastroparesis is associated with a reduction in the annual income by about 30%. And on top of that, we've had a lot of sessions on new drugs, including the oldest and the king of diabetes treatment, metformin, and the newer drugs also to some extent are contributing to the GI symptoms being aggravated, like the GLP-1 RAs in our patients with diabetes. A very interesting study in newly diagnosed diabetics showed that patients who were started on metformin and had some level of metformin intolerance, there was a 40% reduced adherence or compliance in these patients. So this is how important or the impact of GI disturbances, including diarrhea and diabetes, is on the patient's life. And again, for the cost of the therapy, these symptoms are actually pretty resistant to treatment. A lot of times they are ignored, not addressed, hence contributing majorly to the outpatient or the inpatient cost borne by the patient. Of all the GI symptoms that we know of, diabetic diarrhea is possibly the most debilitating of the GI associations with diabetes. So this publication in Diabetes Care in 2018 actually, if you all could see, gives a kind of a percentage of symptoms and the type of diabetes. Now, I would request all of us seeing these slides to think about your average day in the OPD with the patients and see how many percentage of these patients come up with these complaints. And maybe in the next 10 patients, actively ask them about the question about maybe reflux, nausea, vomiting, bloating, early satiety, postprandial fullness, diarrhea. And interestingly, the topic for today being diabetic diarrhea, up to 35% of type 2 diabetics have diabetic or diarrhea, or maybe diabetic diarrhea, which will come to in their course of their illness. So it is a very, very prevalent problem in our patients with diabetes. And on top of that, a lot of these GI symptoms may also be related to the older or the newer drugs, which again we'll be briefly mentioning. So coming specific to diarrhea in diabetes, which is a specific diagnosis in diabetes. However, there is a lot of confusion about the correct definition of diarrhea itself. So I tried to search the literature, and the best I could find is defining chronic diarrhea in diabetes by using the diabetes bowel symptom questionnaire, which says that diarrhea in diabetes is a qualified statement when watery or loose stools are occurring more than 25% of the times. Some of the important clinical presentations which help in focusing on the diagnosis of diabetes in diarrhea are: it is a painless watery diarrhea, which is the duration of chronicity by this particular article was more than 6 weeks. These patients usually have long-standing diabetes with a mean duration of 8 years, associated poor glycemic control, and a lot of these patients have associated symptoms suggesting autonomic or peripheral neuropathy. Characteristically, if we were to call it diarrhea, chronic diarrhea of diabetes, the stools should be non-bloody, indicating a non-infectious reason. It's more prevalent in females, like we talked about, that the overall GI disorders are more prevalent in female diabetics. And very characteristically, the episodes of diarrhea are interspersed with times of normal bowel habits or constipation. Now, we need to go back to our OPD setting again and see how common this particular the symptomatology or possible diagnosis is in our patients. The two most characteristic features of diabetic diarrhea are nocturnal diarrhea and fecal incontinence. So with these two characteristic symptoms, we almost are sure of the diagnosis of diabetic diarrhea or chronic diarrhea in diabetes. However, we need to rule out a whole lot of other things. And so this becomes a diagnosis of exclusion. We'll touch about the various common and relevant diagnoses that we usually look at, investigate to come to a final diagnosis of chronic diarrhea because of diabetes. The pathophysiology of chronic diarrhea and diabetes is centered around neuropathy, whether it is autonomic or specific focal enteric neuropathy. It basically leads to changes in the motility of the small and the large intestine. The three main cells which have been studied as pathophysiological defects in diabetes diarrhea are the interstitial cells of Cajal, the enteric glial cells, and the smooth muscle cells. There are also documented changes in the ion transport and the intestinal absorption of liquid and electrolytes. Along with this, incipient changes in epithelial damage and changes or regression in the colonic stem cells. So this basically once we see this slide, it's all centered around a possible neural cause of the pathophysiology of diabetes, diarrhea. Well, as I said earlier, that it's a diagnosis of exclusion. So we need to look at the common drugs, offending drugs, which can cause diarrhea in our diabetics. Most common being metformin, which I'll talk about a little more, the GLP-1 RAs, the AGIs, and for the obese diabetics, use of orlistat. This would more or less take care of the commonly used drugs associated with diarrhea in patients with diabetes. Dietary factors, celiac disease, when we're talking about type 1 diabetes, the prevalence is pretty high. And at diagnosis or with the patient presenting with diarrhea in type 1 diabetes, we always look for a possibility of celiac disease. Pancreatic exocrine insufficiency, again, in type 2, we know diabetes in itself is a risk factor for chronic pancreatitis, and exocrine insufficiency may manifest as chronic diarrhea. Small intestinal bowel overgrowth. So it's basically what happens because of altered peristalsis, be it the small or the large intestine, leads to a whole lot of stasis of the intestine, leading to bacterial overgrowth, and this may in itself aggravate the diarrhea in diabetes. We have to look for irritable or inflammatory bowel syndrome, the diagnosis of which comes from the historical aspect, the quality of diarrhea, whether it's associated with constitutional symptoms. There's blood mixed diarrhea, differentiating it from chronic diarrhea of diabetes, where it is plain watery diarrhea. So presence of blood, mucus, or purulent stools should indicate or help us investigate in the lines of inflammatory bowel syndrome. Microscopic colitis is also another differential diagnosis, diagnosed on colonoscopy once we decide and rule out other things, taking multiple biopsy and forming the diagnosis. So this, in a very basic form or a easily accessible form, helps us know which possibility we're looking at. Coming back to our day-to-day practice, metformin is one of the most common offending agents for diarrhea in our diabetics, which we always consider, and we need to address in the right way to ensure this particular differential for chronic diarrhea and diabetes is taken care of. So going a little in the details of the pathophysiology, it's the leading reason for diarrhea and diabetes. There is reduction in the neuron numbers in the ileal myenteric plexus. The total ganglionic area is reduced. One important set of neurons, the nitrogen neurons, which basically produce nitrous oxide, which is basically an inhibitory to peristalsis. So once you reduce this, the overall peristalsis would increase, and increased peristalsis would increase or would be associated with diarrhea. There are two phases in this, in which initial there would be stunning of activity, and studies have shown usage of insulin and tight glycemic control can help to restore the neuronal activity. If left untreated or unaddressed for a long period of time with poor glycemic control, it would lead to apoptosis of these cells, which become irreversible. Also, there is an altered sympathetic and parasympathetic neuronal activity, along with increased coupling of the smooth muscle neuronal activity. Hence, in this, there is overall, for example, in the fasting state, reduced frequency and amplitude of the pressure generating activity, interspersed with bursts of motility generating activity. Hence, the diarrhea would not happen throughout the day. Intermittent diarrhea, and a very characteristic feature of diabetic diarrhea, it's nocturnal diarrhea, would happen because of these possible reasons. There are accelerated small and colonic intestine and colonic transits. The muscles of the colon exhibit altered contraction and relaxation, all of it presenting as diarrhea in a patient with long-standing diabetes. There's altered iron transport in the gut, which would lead to greater electrolyte and fluid accumulation inside the gut rather than its absorption, aggravating the diarrhea. And histopathological changes in the gut in patients with diabetic diarrhea include fewer crypts, longer villi, sclerosis of the lamina propria, reduction in the mesenteric plexus, loss of paracellular permeability, and very importantly, reduction in the colonic stem cells, which have a potential to regenerate into the protective gut cells. The most important differential diagnosis, as I said, would be drug-induced in our day-to-day practice. So if I were to go back in time and think about the last maybe 15, 20 years we've been treating diabetes, this seems to be the most common and the most important aspect whenever a patient with diarrhea presents to us in the outpatient. Metformin has been there over numerous decades. We have recently the GLP-1 RAs, both of them contributing to most of the drug-induced diarrhea in diabetes. And obviously, we have the AGIs also, which may have significant GI side effects. Very importantly and interestingly, though the drug has been there for so many decades, we are gaining more and more knowledge about its functionality, how it acts, and the possible reasons for the side effects or diarrhea associated with metformin. So as you can see in this slide, these are the various mechanisms by which metformin interacts in the gut, and some of these reasons may contribute to diarrhea. For example, metformin usage has been shown to cause increased accumulation of the bile acid pool, and it activates the bile acid receptors. Hence, the increase in the intraluminal bile may cause osmotic diarrhea. Very common side effect of metformin is a patient coming back to us saying that they have a very funny metallic taste in their mouth. And a possible mechanism is the secretion of metformin via the OCT3 receptors in the salivary gland, which may cause these altered sensations. We all know about the lactate generating capacity of metformin. This also happens in the gut, may or may not be contributing to the diarrhea associated. Very well documented effect of metformin is on directly increasing the levels of GLP-1. Hence, coming to back to the clinic, most of the patients who have a heightened GI side effects with metformin, possibly through the GLP-1 RAs, in my clinical practice, I have observed them to be super sensitive to GLP-1 RAs. So a possible common mechanistic way in which metformin contributes to chronic diarrhea. There's a whole lot of understanding about gut microbiota, and metformin in a positive way for better glycemic control, better health, contributes to change in the gut microbiota. However, these alterations may also promote occurrence of diarrhea. The oral bioavailability of metformin being about 40 to 60%, and it is mainly transporter dependent. So genetic variations in these transporters can lead to decreased absorption, systemic absorption of metformin. So for example, if we were to knock out these receptors, the side effects or the adverse GI side effects majorly get aggravated. So again, mechanistically understanding how and why metformin may be associated with diarrhea in our patients with diabetes. Metformin has a structural similarity to agonists of the 5-HT3 receptor, stimulation of which can cause nausea, vomiting, diarrhea. It may stimulate serotonin release, and inhibition of dopamine oxidase leads to increased levels of histamine, again, which may present with diarrhea, vomiting, flushing, and all those kind of symptoms. The important and interesting thing about metformin and diarrhea is it may not be entirely dose dependent. Reduction of the dose may lead to betterment or disappearance of the symptoms. If that does not happen, withdrawal before putting the patient through a colonoscopy, endoscopy, reduction in the doses, or stopping the metformin leads to the diagnosis or proving the diagnosis of metformin associated diarrhea. Number two, again, very interesting. It may not be related to the time the metformin is instituted. It may be a very late or a very late side effect of metformin. So even after 10 years of exposure to metformin, and this, what I'm saying, is primarily related to our practice over the last 2.5 decades, that even after long-term exposure to metformin, a patient presenting with diarrhea or such lower GI side effects, reduction of dose of metformin does help a lot in these patients. So we should not fix our minds that starting a drug, we need to have the side effect. Metformin is very peculiar in this way that even long-term exposure can lead to such lower GI side effects. So what I follow and what I discuss is the metformin rule of half, where half of the patients, about 50 to 75%, on metformin are intolerant at some point of time to some extent, which may or may not affect their quality of life. Of these, 50% or above have more pronounced intolerance requiring dose reduction. So I would first reduce the dose to half. And in this, 60 to 70% of the patients resolve. If not, then I would reduce the dose further or even decide to discontinue metformin. And of these 50%, they cannot tolerate metformin at all. And that would amount to about 2 to 5% patients in my practice. There is no published data on these percentages. So these are emanating more from my practice and the experience of my colleagues, mentors. So these are the other diagnoses which we need to look at: celiac disease, pancreatic exocrine insufficiency. So I've covered most of these. And once you've ruled out all of these reasons, then it is viable to go ahead with a colonoscopy or get the help of our colleagues in gastroenterology to give the patient a resolution of these symptoms. This is how the flow chart of assessing chronic diarrhea and diabetes would flow. First, from a history, as we talked about, certain vital characteristics of diabetes for making a diagnosis of chronic diarrhea of diabetes. Once we rule out the triggers, most common of them being metformin. We go to the next level of evaluation with laboratory workup. In case Titora is there, do a fecal elastase. We are suspecting an exocrine deficiency, watery diarrhea. Look for the celiac disease. And finally, if nothing works, then a colonoscopy, multiple biopsy, and help from our colleagues in gastroenterology. So the last slide basically talks about management. These are all the choices available. I'll stop here in summarizing my talk. The GI disorders in diabetes are very common, the major impact of them being on the quality of life. And one of the goals, which I always follow and will follow, would be to provide the largest quantity as well as quality of life, making these kind of patient-related complaints very important to be assessed and addressed to logically give them a better quality of life. And it's one of the diabetic diarrhea is one of the most debilitating GI complications. And it mainly is a diagnosis of exclusion, with the main contribution of long-standing, poorly controlled diabetes leading to neuronal dysfunction, which produces this watery diarrhea. And metformin should always be considered as the number one differential diagnosis for diarrhea, chronic diarrhea, and diabetes. I thank all of you for your kind listening.
Uh, Thank you very much, Dr. Jasjeet, for a very elaborative, evaluative, and very brief, up to the mark topic. I think we all are most delighted to listen to your this topic. You have covered most of the things, sir. Starting from the very beginning, going up to the end, the evaluation and the topic you described as the differentials. It is very, very hard learning to enjoy your talk. And thank you very much for being on the platform for the RSSDI. Thank you very much, sir. We shall be coming to the question answer sessions in the later on. And I request the organizing team for the next speaker. Are they available right now? Yes, to the organizing team. Dr. Parminder, sir, my favorite sir is there. Sir, good afternoon, sir.
Good afternoon. Good afternoon to everybody.
And welcome to RSSD platform, sir. We welcome you to the very favorite topic of yours. And Dr. Parminder is our epitome figure in not only the North India, but at the national level of faculty of RSSDI. He is our guide, our mentor, our teacher from the very beginning, professor and head department of endocrinology, DMC Ludhiana. Sir, I request you to start with the topic so that we all are enlightened with your knowledge and your presence on this platform. Welcome, sir.
Thank you, Dr. Sodi. And my thanks to the RSTA organizing team for inviting me to deliberate on the topic of, we don't discuss that much in clinical practice also. That's a diabetic gastroparesis. So what is a diabetic gastroparesis? Am I busy? My slides are visible?
Yes, sir, visible.
Okay. So what is diabetic gastroparesis? So gastroparesis is a syndrome characterized by delayed gastric emptying and upper GI symptoms that suggest but are not associated with gastric outlet obstruction. So what it means that diabetic gastroparesis is a delayed gastric emptying with no sign and symptom of gastric. There is no physically, gastric outlet obstruction. Generally, gastroparesis is a complication which occurs in long-standing diabetes, and generally it is thought to be part of a broad spectrum of autonomic neuropathy, which involve cardiovascular system and, of course, GIT and genitourinary system. And the more appropriate term will be, or you can put it that diabetic gastroparesis, in fact, is a part of a broader term that we call as a diabetic gastroenteropathy. So it is not only the stomach which is involved, it's the duodenum, it's the small intestine, it's the colon, which is also affected in diabetes. And it depends on the symptomatology. So if you have a symptoms dominating to the stomach, we call it diabetic gastroparesis. So I will be discussing it under following headings. That is first is introduction, then pathophysiology of diabetic gastroparesis, what is the clinical presentation, differential diagnosis, diagnostic approaches, management and treatment, and then conclusion slide. Let me first admit this point that currently there's no standardized method to diagnose diabetic gastroparesis. And majority of the Indian institutes don't have that much capability or instrumentation to diagnose diabetic gastroparesis. So in my clinical practice, I rely more on the clinical presentation rather than investigation. Although currently we have mortality studies available in our institute, that is the Anand Medical College and Hospital. But majority of the institute, they don't have that much instrumentation to for assessing the gastric mortality. And gastric mortality testing depends upon various factors also. So it is not a gold standard also, although this is the only way you can diagnose it, but it's not the only method. You have to have the symptoms also, and then investigation suggestive of diabetic gastroparesis. So as I said, that diabetic gastroparesis is generally a part of the broader term that is a diabetic gastroenteropathy. And gastroparesis means the gastric emptying is slowed down. So it's a complication of diabetes characterized by delayed gastric emptying without the mechanical obstruction. The symptoms include postprandial fullness, nausea, vomiting, bloating, and upper abdominal pain. And diabetic gastroparesis may result in dysglycemia. This is well documented that absorption is delayed if we have given insulin at the time of meal. So there will be mismatch because the contents, gastric content, are not released into the intestine and the duodenum to the intestine for absorption of the nutrients. So can get hypoglycemia. Frequent hospitalization because of this only, that sometimes you have a hypoglycemia, at other times hyperglycemia, and then of course the other symptoms like nausea, vomiting, which are there, and then poor quality of life. And it is said that physical quality of life and mental quality of life both are affected with the diabetic gastroparesis, and physical quality of life is as bad as the patient with rheumatoid arthritis, and mental quality is bad than the rheumatoid arthritis patient, active rheumatoid arthritis patient. So they have a poor quality of life apart from hospitalization, frequent hospitalization. In fact, if you take all the gastro problems, then diabetic gastroparesis takes about the maximum of the financial budget of the patient. Be it even perforation is less costly as compared to the diabetic gastroparesis. So relationship between gastric emptying and symptoms of gastroparesis remain weak, leading to wide variation in the prevalence of gastroparesis in diabetes, up to 60%. So there was one study which was done in Rochester epidemiology project, which has shown that overall age-adjusted prevalence of definite gastroparesis, that means the patient has presented with the complaints and he is investigated from that, per 1 lakh persons was approximately 4-fold high in women as compared to men. This was 37.8 in 1 lakh population as compared to 9.6 in men. Then 21 of 83 patients which they have investigated on the scintigraphy and all those procedures, but having definite symptoms also, and studies which were suggestive of gastroparesis. Then the cumulative incidence of symptoms and delayed gastroparesis over 10 years was found in that study was 5% in type 1 diabetes and 1% in type 2 diabetes. There is another study that's a Allstate County study, which was a community-based study. Again, it does not show any difference between the normal population as well as in the diabetic population. But one study from Australia has said that there is a significant gastric emptying delaying in diabetes as compared to the normal population, more so in type 1 diabetes. So there is a wide variation because the recent, we have studies which are available. Only recently we came to know about the true prevalence or incidence of the study. Still, many things are unsaid about the true prevalence, because there are two types of things. Because majority of the patient, they may be asymptomatic for diabetic gastroparesis. They don't seek the hospitalization, or they don't come to the doctor with the complaints. This study, what I'm quoting is, the patient has presented with the gastroparesis symptoms. So many patients, almost 50% of the patient with diabetic gastroparesis, that's mild to moderate intensity, they don't come to the doctor with the complaints, or their complaints are very minor, and one can confuse it with diabetic dyspepsia plain. So cross-sectional study reviewing medical records reported the prevalence of 4.6 in type 1 diabetes and 1.3% in type 2 diabetes. And the problem is that only 14% had testing and documentation done. Only 14%. So patient, those who have symptoms even, only 14% because of the availability of the investigation armamentarium, only 4% had testing. So thereby diabetic gastroparesis is commonly undetected, and the real prevalence remains unknown because a minority of the patient have gastric emptying measured, and even then diagnosis can be challenging because there is some overlap between the mild, moderate, or meal test is not that perfect and is not of that perfection. So what is the pathophysiology of diabetic gastroparesis? So this is a disorder in which there is a gastric emptying is not proper. So gastric emptying not proper means, see, there are three parts in the stomach. One is the body and the fundus of the stomach. Then we have antrum, then we have a pylorus. And we have a, antrum can be divided into proximal or distal antrum. And the three parts of the stomach had differentiated functions to them. The fundus and the body has the function of storage of food and exposing the food to the acid. That's the most important function of the fundus and the body. The second part is that's the antrum. Antrum is muscular, all right? And it churns the food and pushes it, making it only 2 mm particle, small particle, pushing it through the pylorus into the duodenum. So first part, fundus and body, has a function of what function? It is the mixing of the food with the acid. And antrum has the function of churning the food and making it small particle. And then pylorus is the valvular kind of thing, from where the fluid goes into duodenum. So normally 2 calories or 3 calories, one contraction is shifting the fluid from the antrum to the duodenum through the pylorus. Now, what can lead to stasis of gastroparesis? You can say what can lead to. Number one, it can be that antrum is not properly working. Antrum is not pushing the food. And secondly, the slow waves which come in the fundus, they are not that effective. So they are not pushing the food towards the antrum. So both ways, that the muscular layer is like that only, that circular layer of the muscle, they are very dominant, very prominent in antrum, and oblique muscles and the longitudinal muscles are more prominent in the fundus and the body. So control of these contractions in the fundus, antrum, as well as the pylorus relaxation is mediated through neural connections, which are of two types. One is extrinsic system, that is a parasympathetic, mediated by the vagal component. Another is sympathetic, right? Then the intrinsic system. Intrinsic system is very interesting. That we have, two types of plexus. One is submucosal plexus, another is submuscular plexus, orbat, and the another plexus, which maintain the submucosal plexus is important for the secretion and absorption throughout the gut, and the another plexus, which is present in the muscular layers, is responsible for the contraction. And over that, we have in that system we have a cells which we call as a interstitial cell of Kajal, that is a ICC, and these cells are very much important. There are almost 100 million neurons cells in the entire GIT, and these cells are very important because they are the pacemakers of the intestine, they are the pacemaker of the gut, and on that you have a neuronal control by vagal and sympathetic. So pacemaker sets the tone for contraction, and this tone may be different in different organs of the GIT. It may be different in the stomach, it may be different in the antrum, it may be different in the pylorus, it may be different, it will be different in duodenum as well as in the colon. So there are different factors over that. We have hormones also. There are various hormones like ghrelin, like motilin, like cholecystokinin, like VIP, and all those hormones are, we will be discussing later on when we will be discussing therapeutics. And what is said about the diabetic gastroparesis? Many studies have shown that probably it's a nervous system dysfunction. The vagal dysfunction is there. There are the studies which stated that there is a vagal dysfunction, but it's not truly proved that many patients, they have a normal VIP responses to vagal stimulation, but still there is a gastroparesis. So what else can be there? Probably it's the problem with the interstitial cell of Kajal network. What we have found in diabetic gastroparesis full biopsies, what we found is that cell number is decreased. Interstitial cells of Kajal, they are decreased in diabetic gastroparesis patients. That means generally 1 to 2 cells per field as compared to 5 to 8 cells per field, which occur in the normal population. So that means that we are losing the interstitial cells of Kajal, and if you lose those cells, then probably networking is not proper. So if networking is not proper, then probably you don't have a systematic contractions of the gut, especially of the stomach, and systematic relaxation of the pylorus, because when the antrum is contracting, you have to have the relaxation of the pylorus. Only then the chyme, which is the product by the mixing of all the things, will be thrown into the duodenum, will be pushed towards the duodenum. So definitely there is a reduction in the interstitial cells of Kajal in case of diabetic gastroparesis. Then there is a loss of nitric oxide synthase expression. Then of course oxidative stress acting through heme oxidase system. So many factors has been related to that, but nervous system dysfunction and of course interstitial cells of Kajal network disturbances, this occurs in long-standing diabetes. But mind you, acute hyperglycemia will also produce the gastroparesis. Although when I was going through the studies, that certainly studies were favoring that hyperglycemia, and clinically also we think that hyperglycemia does produce gastroparesis. Definitely ketogenesis produce gastroparesis, but studies are plus minus for the role of hyperglycemia. Acute hyperglycemia definitely, but does chronic hyperglycemia lead to gastroparesis? Still it's a plus minus kind of thing. So we have a different pathophysiology, but interesting is vagal dysfunction as well as the interstitial cells of Kajal network dysfunction. That is a very much important. What will be the clinical presentation of diabetic gastroparesis? As I said, those who are presenting, they are the tip of the iceberg kind of thing. Many patients, they have the diabetic gastroparesis, but still they don't have any symptoms or very mild symptoms. Certainly those who present to the doctor with the symptom, they have generally nausea and vomiting, then abdominal pain, which is a undefined kind of thing, maybe in the left upper abdomen, like early satiety and postprandial fullness or bloating. Then severe cases will have weight loss, and then of course hypoglycemia and postprandial hyperglycemia both can occur. Hypoglycemia occur in the early stage phase, right? In the early stage that you have given insulin, it will occur in the early stage because contents are not going, stomach contents are not going to the duodenum. Rather, they are going very late. Generally, liquids, they go to the stomach to the duodenum within 30 minutes, and solid food, they take their time. They take about 90 to 120 minutes. So this is how solid, they are not moving. So if you are given insulin over a period of time, within 2 hours, because food is not delivered or calories aren't delivered, so there is a chance of hypoglycemia, early hypoglycemia. So postprandial hypoglycemia is another kind of thing. Uh, then comes the quality of life. As I've already discussed, quality of life is quite bad in severe cases of gastroparesis. What is the differential diagnosis? Differential diagnosis, gastric outlet obstruction. Although this come into the when you diagnose a patient of gastroparesis, you have to rule out gastric outlet obstruction with endoscopy or imaging modalities. Then functional dyspepsia or indigestion, very difficult unless we do the studies of gastroparesis. Even functional dyspepsia, it is a 30-30 kind of thing. 30% of the patient with functional dyspepsia, they have gastric, they are slowing of the gastric emptying, not to the extent which is there in the diabetic gastroparesis. 30% are normal and 30% they have a increased gastric emptying. So this is the one of the diagnosis which is needs a exclusion by taking a good clinical history. Then gastroesophageal reflux disease. Contrary to the popular belief that diabetic gastroparesis will lead on to reflux, it's not so common. Gastroparesis does not lead on to reflux. And when there is a reflux, just think of gastroesophageal reflux there. Then we have psychiatric disease like anorexia and bulimia, the rumination syndrome. Rumination syndrome is one of the syndrome which occur in female commonly, and this is a effortless vomiting. That is a repeated effortless vomiting which occurs in young females, but more commonly in mentally disadvantaged children, and becoming more common in adolescent and adults presently. Then is cyclic vomiting syndrome. This is again, it's characterized by recurrent episode of intense nausea and vomiting lasting from 3 to 5 days and happens every 3 to 4 months. Cyclical vomiting syndrome may be associated with menstruation or diabetes. Triggers are many, like sleep deprivation, infection, food, motion sickness, and medications, of course. And again, diabetic gastroparesis, when I was telling you what is the prevalence and the incidence, it's a more common in females, and certainly rumination syndrome, psychiatric disease, they are more prevalent in anorexia, bulimia. It's more prevalent in the female population. Then another new thing is cannabinoid hyperemesis syndrome. This is they also experience episode of intense vomiting, but they present with this after prolonged excessive cannabis use, and there is a history of cannabis, and you stop it, the vomiting subsides automatically. Diagnostic approach for the diabetic gastroparesis, we have to rule out mechanical obstruction with the upper GI endoscopy series, a CT or MRI enterography. Then you have to get the gastric emptying test. That's best is gastric emptying scintigraphy studies. Then you have a gastric emptying breath test, then wireless motility capsule, and functional ultrasonography. And functional ultrasonography is the latest one. Motility capsule is being tried in the developed countries. We don't have that facility, but emptying scintigraphy and emptying breath test, they are available. So there are precautions to be taken before the test. The precaution includes that we have to stop all the motility altering medication like anticholinergic, opiates, or prokinetics should be withheld to ensure accurate results. And then certain therapies like GLP-1 receptor agonist and pramlintide, they are both the agents that decrease the motility of the stomach, so they have to be stopped. Then opiate analgesic, anticholinergic should be discontinued at least if the patient is taking at least 48 hours before the test. So this is how you do it. And with the egg white sandwich, low fat, as a test meal. At the end of 4 hours, more than 10% we call as delayed gastric emptying. Generally, it takes 2 hours. Generally, at 2 hours, there's no residual food into the stomach in a normal population. And 2 hours, almost 70% is pushed towards the through the pylorus to the duodenum. Mild we call when it's a 10 to 15%, and moderate gastric paresis we call when it is 16 to 35%, and severe when it's more than 35% residual food in the stomach, we call it as a severe gastroparesis. How you manage these patients? Managing is first is lifestyle recommendation, and the lifestyle recommendation that we have to properly hydrate these patients, modify their diet, and remove possible medication or substances that could make their symptoms worse. What are the food or food which are affecting the gastric mortality? What we have the studies have found that fatty, acidic, spicy, and roughage based foods, they exacerbate the symptoms, while bland, sweet, salty, and starchy foods are tolerated well. Then avoidances of carbonated beverages because they cause gastric distension, alcohol, and smoking because they both decrease the motility of the stomach. They should be avoided at all. And so taking small frequent meals and without these, what I've said is a spicy fatty meal, avoidance of these will improve the symptomatology. That's in the lifestyle modification. And nothing can be more true than the glycemic control. We know that glycemic control improves the so many things, but let me tell you that late glycemic control in the history of diabetes does not improve the gastroparesis symptomatology. Then we have a prokinetic and antiemetic medication, and FDA has approved metoclopramide as one of the agent. This is increase the peripheral cholinergic activity and centrally acts as a dopaminergic antagonist at the chemoreceptor trigger zone. This is a very good medication. We have been using it. The only problem with this medication is probably dystonia, Parkinson type or tardive dyskinesia, which occurs in 1% of the population, and more commonly in female population, tardive dyskinesia. And this is a black box warning on this molecule also. So it improves the symptoms, but generally what is said is after some time, the effect weans off. So drug holiday is a one thing which has been told about the to be done with the metoclopramide. Then we have dopamine, then we have domperidone, then cisapride, which is discontinued because of the association with the prolonged QT interval. Then another agents like mortellin receptor agonist, in which we have erythromycin and azithromycin. But again, they can be used for a short term. That means 2 weeks. Thereafter, the effect weans off. And then ondansetron and phenothiazine may be used to relieve the symptoms. Then we have investigational treatment like ghrelin receptor agonist. They have been tried because ghrelin is one which increases the motility of the stomach. They have been tried, but in fact, there are a number of compounds while studying. There are almost 5-6 compounds with the ghrelin agonist, but results are not so encouraging. Then we have a neurokinin receptor antagonist, and the compound is apripitant, which has been used. Again, the results are not that great. In the mild to moderate category, the results are good, but once you go to the severe gastroparesis, neurokinin receptor antagonist don't stand the test. And then prucalopride, there's one study which shows that it improves, but prucalopride is more of a increasing the motility of the colon, and it's more effective there. But one study has shown good result with the in gastroparesis also. Then Velocitrag and Motilite. Velocitrag is another 5-HT 4 receptor antagonist, and it increases the gastric emptying. Still, we have not got the good results with it. Then Motiloids, then surgical intervention like enterostomy, pyloroplasty, and gastrojejunostomy, and gastric electrical stimulation. And GPOM is a gastric peroral endoscopic myotomy, has been tried to cut the fibers of the pylorus to facilitate the content going into the duodenum. To conclude, gastroparesis is a prevalent and debilitating complication of diabetes with significant physical, emotional, and financial burden. Tight glycemic control can significantly reduce the risk of developing diabetic gastroparesis. Currently, it is underdiagnosed, and close attention to symptoms may suggest its presence. Diet modification and good glycemic control are fundamentals of therapy. Current medication have limited efficacy and have high risk of adverse events. Newer agents and procedures have shown some promise and need further studies. More research is required to establish safety and efficacy of therapy. Thank you. Thank you, the patient listening, and back to the, Dr. Sodi.
Thank you very much, sir, for very elaborative and nice talk. It is always a delight to listen to you, sir, whether we are on the virtual platform or on the physical platform. And to the organizing team, are we having our third speaker or not?
Dr. Sodi, I've been told that there is no third speaker, so I'm ready for that.
Okay. Shall we proceed with the discussion, or we shall go for the next lecture?
Any organizers, please?
To the RSSD organizing team, shall we proceed with the discussion for the diabetic gastroparesis, or we shall move forward to the further topics?
I think we should move to the further topics. I'm Dr. Preeti Ahuja, sir. So I've been told to proceed further after this session.
Okay. Dr. Pravinder, sir?
Yeah.
I have a question from the audience part.
Yes.
Because none of the organizing team members is present at this moment. Sir, as we are dealing with lot of fatty food meals, especially in our areas of Punjab, and we are just going to the diabetic capital of our region, especially Ludhiana and Moga. What is your drug of choice, sir, for the diabetic constipation, and at the same time when the patients are present with diabetic diarrhea, especially the midnight diarrhea?
I think Dr. Jasjeet is there. He has just given that lecture. Will you answer that, Dr. Basir, for the sake of the audience, because it will be involvement of all of us, right?
So, see, as I said, and Dr. Parminder sir also very rightly said that the drug therapies per se for treating the chronic GI associations of chronic diabetes are full of side effects, and they're not very beneficial as far as the control of symptoms are concerned. However, in clinical practice, you rightly said that it is a very common problem in our diabetic patients, be it upper GI or lower GI related. Now, if I were to summarize the last 15, 20 years of clinical experience, you would never be wrong in, first of all, thinking about metformin as the causative agent, reduce the dose, and possibly stop it. So out of 10 such last instances of diabetes-associated diarrhea, from 5 to 7 of them would respond very well in their symptoms getting controlled. The other part is using probiotics and a whole lot of other drugs, which I enumerated in the talk. But one thing which has stood the test of time is reducing the dose of metformin, or possibly stopping it first before going on to colonoscopies and biopsies and all those things. Dr. Parminder sir, your views on this would be very valuable.
Dr. Jasjeet, I appreciate what you have said is very much all right. In the past, past so many months, I've seen so many patients coming to me with diarrhea and have been investigated, unfortunately, by our dear gastroenterologist for all the, colonoscopy and upper GI endoscopy, for what I don't know, but colonoscopy definitely they are doing in such cases. But metformin is the one of the, always rule out metformin induced diarrhea. That's very common. In fact, don't miss it. Whenever patient of diarrhea comes, stop it and see to it. So this is, you have rightly said. Then of course you have other causes, like some of the patient may be having celiac disease related diarrhea, and then just ask the patient also, is he taking, laxative? That's another thing. That's a third thing. And then of course in a young, even 1.5 diabetes, you have pancreatic insufficiency induced diarrhea. Then most important, if the patient comes to you with waxing and winning type constipation and diarrhea alternating, think of, this is a classic case of diabetic autonomic neuropathy. That's the dan-am. So in this patient, treat with, as you have rightly said, treat with the antibiotics, and you may give, depending on the symptomatology, whether you want to give bulk forming agent or laxative, depending upon that. So it's a nicely, you have said that, I will go with you, whatever you said, that the metformin should be excluded as the cause of diarrhea. And as far as Dr. Sodi, your point is that, what about the food and other things? See, in our part, that's alcohol is there, and many of the patients, they take alcohol, and then heavy meal, fatty meal is there. This itself decreases the gastric emptying, we all know. But some or the other, because content is so high, and we are eating that much calories, so it's not, when you say that gastric emptying, glycemic control should have been better from that sense, because it is releasing the calories slowly over a period of time. As I said, 2 calories per minute is thrown, per peristalsis is thrown into the duodenum. So from that angle, taking from that, gastroparesis should benefit our patient eating all those things. But certainly it is not so, because the calorie content is so high of these foods that it mitigates whatever the benefits you have. Little bit of gastric delaying, emptying delaying is there. So that's mitigated by the calorie content of the diet, because the calorie content of the diet is very high.
Can I have one comment? Can I have Dr.
Yes, sir. Yes, sir.
Yeah.
Yes.
I think I have listening your Dr. Wazir's and Dr. Parminder Singh's comments are very, very valid regarding metformin. But in our situation, before, I mean, we have to reduce the metformin dose, but I think rifaximin is one of the drug we can try for diarrhea. And if rifaximin doesn't work, then I think everything is valid what you have told just now. This is my supplement comment.
So I'm Dr. Arvind. Thank you very much. I was holding back this thought.
Yeah.
So when I said out of 10 patients, 5 to 7 of them become all right with reduction of metformin, I left out 3 to 5 of them, which by giving them probiotics, reducing metformin, and giving that local gut antibiotic actually takes the number up to 9, or maybe all of them responding. So I'm very happy you completed the 100%.
Thank you. Thank you.
Thank you, Dr. Jasdeep sir and Dr. Parminder sir. And with this, we shall be moving to the next session. But thanks, sir, for always being there and giving such an elaborative talk, Dr. Parminder sir and Dr. Jasdeep sir. It is always a pleasure for all of us to listen to dignitaries, especially on the platform of RSSDI. And as in this area of Punjab, we are dealing with number of diabetes patients, especially the OPDs are full, and alcohol is our bread and butter, not as doctors, but as the patients also. And fatty meals, we take delight in, starting with the pranthas in the morning and ending up with the butters in the evening. And sir, I think one addition can be the well control of the diabetes, especially with all these kind of foods also. if the diabetes is getting controlled and the patients are counseled in a better way, that may add up something. But hoping for the best. Dr. Arvind sir, we shall be moving to the next session and to the RSSDI organizing team. And RSSDI organizing team.
Yes, sir.
Yeah. Can we move to the next session?
Yeah, we can
Hello,
start
Sanjay.
the next session.
Yeah. Next session chairpersons are there.
Yeah. I'm Dr. Preeti Ahuja. I'm presently the Secretary of Kanpur Diabetes Association. So I'm really humbled and honored to chair the session of Mixed Bag. And I'm grateful to the RSSDI team, Dr. Vanshi Sabu, President, Dr. C.H. Kumar, President-elect, and Dr. Sanjay Agarwal, the Secretary, and of course the RX events for organizing this virtual part so well. And the questions answers will be taken up at the end of the session. So I request all the participants to put up their questions in the chat box, and that will be taken at last. So moving on to the first talk of this session, that is pre-diabetes. Now we all know that this pre-diabetes is now recognized as a reversible condition, and there are recent evidences which suggest that prevention of progression of pre-diabetes to diabetes and conversion of pre-diabetes to normal glucose state is possible. So how the lifestyle intervention, pharmacological intervention, or surgery can prevent the development of diabetes from pre-diabetes. And that would be taken up by the learned speaker, Dr. Arvind Gupta, who is from Jaipur. So the topic is pre-diabetes, a window of opportunity. Few words about Dr. Arvind Gupta, that he is senior consultant physician in Mahavir Jaipuria Rajasthan Hospital in Jaipur, and he holds various fellowships: Fellowship of American College of Endocrinology, Fellowship Indian College of Physicians, Fellowship of Madras Science Foundation, Fellowship of Diabetes India, Fellowship of RSSDI, and Fellowship Royal College of Physician and Surgeon, Glasgow and Edinburgh. And regarding his awards and oration, RSSDI oration, gold medal in Hyderabad 2008, Professor Naresh Bahu oration, Raj RSSDI in Ajmer 2017, Dr. KG Nair oration, Indian Society of Hypertension 2017, New Delhi Outstanding Service Award by Diabetes India in 2019, and Dr. CD Srinivas oration, KRSSDI Tumkar in 2019. And he was organizing secretary in 31st Annual Conference RSSDI 2003, Jaipur Chairman Scientific Committee, Diabetic Foot Society of India, Jaipur 2013, Program Chair Diabetes India 2019 at Jaipur, Member Research Committee, National RSSDI Delhi Co-Scientific Chairman RSSDI Jaipur in 2019, and Member Project Review Committee, ICMR New Delhi, Regional Faculty Diabetes Course, PHFI India, and Associate Editor in International Journal of Diabetes in Developing Countries, IGDD3, presented many papers in various international conferences, and he has over 80 research papers published in national and international peer-reviewed journals. He has contributed several chapters in postgraduate medicine, API textbook of medicine, API Medicine Update 2010-15, and Clinician's Handbook of Diabetes. And he is also the member of various national and international bodies. Now with this, I request Dr. Arvind Gupta to take over the session. Sir.
Thank you. Can I share my slides? Hello?
Yes, sir, you can share.
Yeah. My slides are visible? Slides are visible?
No, sir, not yet.
In my, it is visible.
Yes, sir. Yes, sir.
Visible now?
Yeah.
Okay.
Yes, sir. Yes, sir.
Okay. Thank you very much. Thank you, Dr. Preeti. Thank you, all the chairpersons, for the kind introduction. And at the outset, I also thank Dr. Bansi Sabu, scientific team of the RSSDI, and probably one of the best scientific program I have seen of hybrid conference in recent years. Thank you, Dr. Bansi Sabu and the scientific team. Now, my topic is very, very pertinent. Dr. Preeti has just enumerated that pre-diabetes, I think it is a very important entity we have to think of. These are my disclosures, but nothing particular about this topic. Now, dear friends, pre-diabetes is not a disease. It is a pre-diagnosis of diabetes, and it is a warning sign. And what American Diabetic Association says, that pre-diabetes should not be viewed as a clinical entity in its own right, but rather as an increased risk of diabetes and cardiovascular disease. So what happens in the pre-diabetes, and we all know the pathophysiology and the natural history of diabetes, that around 50% of the beta cells is lost when the patient is already diagnosed as a pre-diabetes. What to talk of a free onset of the diabetes itself. So it is not an entity to be ignored. That is very, very important. So what is the diagnostic criteria? I don't need to elaborate here in front of this august audience, but of course it is a IGT, which is impaired glucose tolerance, and I think ADA is very, very pertinent, and we actually abide by with the ADA criteria. And ADA criteria says that this is 140 to 199 milligram percent is the impaired glucose tolerance. Impaired fasting glucose is between 100 to 125 milligram percent, and glycosylated hemoglobin should be around 5.7 to 6.4%. So I think ADA criteria is little stringent, but it is very, very important, and we take it in most of the research projects. So just think of prevalence of the pre-diabetes in India. If you see here in 2019, the pre-diabetic population was only 25.2%. It was very, very high. And it is projected in 2030, it is projected to increase by 32.2 million population suffering from pre-diabetes. And of course, in 2045, with the similar rate, then India will be having around 40% population with pre-diabetic. So please think of this situation is alarming situation for our country. Now, as far as conversion of pre-diabetes to diabetes is concerned, and one of the study by Dr. Mohan in the CURES study, which says that the people with normal glucose tolerance, 19.4% people NGT converts to diabetes, and around 25% to pre-diabetes. So giving overall conversion rate to around 45%. And among those with the pre-diabetic population, the conversion rate is around 58%, which is very, very high. So dear friends, what are the risk factors? We all know very well, if you have a family history of diabetes, if you have a personal history of gestational diabetes mellitus, if you have a polycystic ovary syndrome, if you are having non-alcoholic fatty liver disease, already having obesity with metabolic syndrome, with hypertension, and less physical activity or sedentary. These are the proper risk factors which actually can lead to pre-diabetic population. So what can be a pathophysiology around pre-diabetes? And it is associated with either with the visceral obesity, with hypertension, glucose intolerance, dyslipidemia, ultimately leads to endothelial dysfunction, and the core is the hyperinsulinemia. Not only these features, but few important clinical entities are already associated with pre-diabetes, and one of the important clinical entities is the dyslipidemia. And if I can say here, the dyslipidemia might diminish the compensatory insulin secretion to insulin resistance in subject with IFG and IGT. So it is always associated with the pre-diabetic population. And not only this, high LDL-C is also associated with the increased probability of the pre-diabetic population. And what I'm telling you is a published study. Similarly, hypertension, if this was also published in Hypertension, that was an original article in 2015, which says that diabetic mellitus and cardiovascular disease are actually correlated. And if you see here in diabetes, it is around, if a normal glucose tolerance, it is 4.7%, and impaired glucose tolerance, it is around 17%. And similarly, cardiovascular disease is already associated with the pre-diabetic population, like around 10%. So if you have a pre-diabetes, dyslipidemia is associated with, and hypertension is also associated with, which increases the risk of cardiovascular disease. So if I can summarize here with Huang et al. In BMJ 2016, which says that there are meta-analysis of the 53 prospective cohort studies, which says that if you have a pre-diabetes, you have 13% risk of cardiovascular disease, 10% of coronary artery disease, then 6% of stroke, and all-cause mortality increases by 13%. So pre-diabetes cannot be ignored, dear friends. Now, what is the core reason or pathophysiology behind pre-diabetes? If I can see here, the endothelial vasodilator dysfunction in pre-diabetes, it is already associated with increased free fatty acids, increased VAT, increased RAS, and increase, of course, hyperglycemia is one of the important regions. So what all these features relate to? They causes increased oxidative stress, increases the inflammation, ultimately leads to insulin resistance. And through the different mechanism like hyperglycemia can increase the PAI1 and ultimately lead to increase in endothelial dysfunction, also having fibrinolytic dysfunction, and which overall increases the risk of vascular events. If I can say here, if you see the vasculature in pre-diabetes, now in the first photo, it is pre-diabetes associated with the reduced microvascular flow due to impaired vascular reactivity. That is the first and foremost thing which leads to endothelial dysfunction. Second, pre-diabetes associated with the capillary rarefaction, and therefore decreased surface area for the exchange. Ultimately, the insulin movements from capillary lumen to interstitium is affected by the determinants of fluid fast transport through the vesicles or paravesical grafts, and actually this leads to overall endothelial dysfunction in cardiovascular disease. So dear friends, if you can early diagnose or screen the people with the pre-diabetes, dear friend, it is a window of opportunity, because we can prevent or delay something, and which people are actually, India is suffering and whole over the globe is suffering from the pandemic of diabetes. So early intervention is the key for management of pre-diabetes. So how to manage? I think from my perspective, non-pharmacological approach is the best approach to prevent the pre-diabetes population converting to diabetes population. Of course, people have tried pharmacological approach. I'll enumerate few of this just now. So lifestyle modification, I think from my point of view, attempts to lose 5 to 10% of body weight. I think this is the primary focus if you want to prevent the pre-diabetes. Participate in the physical activity. That is the core important thing. 6 to 8 hours of sleep. Recently, Nobel Prize winners have last 2 years back, they have clearly said that if you don't have the 6 to 8 hours of sleep, you will be having so many metabolic disorders because of the melatonin and all other features. Just 3 days back, I have seen one of the study, 88,000 patients study in the UK, which clearly said that the people who have deprived of the sleep have mostly developed diabetes and cardiovascular disease. Stress management, of course, particularly in the COVID era in the last 1.5 years and 2 years, and also with stress is associated with the present day situation. I think that is the most important thing. You can go with the exercise, you can go with yoga, you can go with the meditation. Then, of course, avoidance of alcohol and tobacco, which increases your stress, over sympathetic activity, ultimately leading to more beta cell apoptosis. Dear friends, very easy to say about the lifestyle modification, but it is very difficult to adhere with the lifestyle modification. So as a doctor, as a physician, we have moral duty towards the patients or the pre-diabetic population to have the good awareness, number one. Number two, we have to motivate our patients for adhering to the lifestyle modification. If you see here, this is one of the study which says that people do not adhere to lifestyle modification, especially I can say about the diet and exercise. Around 88% people do not adhere. Exercise, of course, people can do, but 25% also do not adhere. Food care, they are ignored. Blood sugar monitoring is also not done properly. People, I mean, it is very difficult to stop smoking. And of course, the betel chewing or the tobacco and all these things. Dear friends, after lifestyle modification, people have tried pharmacological management, and I have enumerated here in front of you the American Diabetic Association, which says that agents that lower the risk of diabetes in those with pre-diabetes is the metformin, alpha glucosidase inhibitors, acarbose has been tried in various clinical studies, liraglutide have been tried in leader studies and other studies. Thiazolidinediones also have been tried in the pre-diabetic population. And of course, even insulin has been tried in Origin study, which was done 10 years back, that insulin right at the pre-diabetic population can prevent diabetes or not. Unfortunately, insulin, in Origin study, insulin did not find any, result for prevention of pre-diabetic population. Of course, netiglidine also been tried, but it was unsuccessful. Let us talk about the metformin. We know that metformin is the drug of choice for diabetes, but it also has been used to prevent or at least delay in the onset of diabetes in patients to be high risk for diabetes. This was published as a letter in Drugs and Therapeutics in 2016. And again, there is one diabetes prevention program whereby 3,000 patients have been recruited from 27 clinics in US. And during this diabetes prevention program, participants randomized to metformin, experience to the average 2.1 kilogram weight loss. So what in the D-CLIP study, the stepwise approach was done for the prevention. And this is again a very, very important study. And the standard lifestyle advice was given to these patients, and a 6 months culturally tailored US diabetes prevention program based lifestyle curriculum plus stepwise addition to metformin. So this is a very, very important study. And this stepwise or D-CLIP study, in this study, most participants, around 72% participants required metformin in addition to lifestyle to prevent the diabetes. So a stepwise diabetes prevention program of metformin around 500 milligram twice daily reduces the 3-year diabetes risk by 32% in overweight or obese Asian. So this is one of the proof we can think of using metformin in these population. Of course, if I can say around the Indian scenario, these are the publications by Dr. Ramachandran, who has done a pioneer study in Indian diabetes prevention program. And dear friends, I want to inform you that as in the RSSDI, we have 6 or 7 people, including myself as principal investigator. We have already doing one study on diabetes prevention program in pre-diabetic population. We have randomized population with yoga, diet, and fenugreek seeds. And the results are underway. Probably in the next RSSDI, will be able to give you our own RSSDI diabetes prevention program. But meanwhile, just This is the Dr. Ramachandran's study of Indian diabetes prevention program, which says that metformin was effective to reduce the progression rate of IGT to diabetes in Asian population at a much smaller dose, around 500 milligrams per day. Of course, in this study, the lifestyle modification was even much stronger thing as compared to metformin for the prevention of diabetes. Of course, here the lifestyle modification was better as compared to metformin. Another diabetes prevention research program study which says that lifestyle intervention of metformin significantly reduces diabetes development. So if I can summarize here, Indian diabetes prevention program or Chinese studies and the Canadian studies, which everybody has done with the metformin, except the some of the Chinese study which they involved the acarbose as one of the agents to prevent pre-diabetes population with intensive lifestyle population. And everybody, right, if you can say all the studies, they say that you can prevent, you think of prevention of diabetes by 26 to 88%. So dear friends, follow-up counseling is very, very important. It is shown to be important to success. You have to monitor the weight loss. I told you 5 to 10% body weight loss can lead to miracle in your quality of life in reducing the pre-diabetes population converting to diabetes. Provide ongoing counseling. It is a repetitive counseling which is needed to patients to become adhere to lifestyle modification. Of course, in some people, you can think of pharmacological therapies, especially if they are very obese or type 2 diabetes or pre-diabetes population in some population, but it is not recommended at present. Please provide annual screening program for your pre-diabetic population to see whether they have converted from pre-diabetes to diabetes. So to conclude my talk, there is a considerable comorbid conditions associated with pre-diabetes, especially the cardiovascular disease, dyslipidemia, hypertension may often go unrecognized. It is of significant importance to screen and identify those at risk. This is very important. And priority should be given to pharmacological treatment in individuals at very, very high risk in those population only. And a broad evidence base of clinical trials and previous clinical experience support the efficacy and safety profile of metformin for diabetes prevention, but the further studies are needed to substantiate this particular evidence. Of course, at present, from my point of view, lifestyle modification is the key to prevent the pre-diabetes population going to diabetes population. And our own RSSDI prevention program, we have already done for last 4 years. Probably by next year, we'll give you the concrete results from our own Indian population. Thank you very much. So the sooner people will find out the pre-diabetes and take action, the better their chance of preventing type 2 diabetes. And Albright aptly said regarding the pre-diabetes. Thank you very much for patience listening.
Yeah, thank you so much, sir. Thank you. You have spoken so well and you have elaborated the thing so well that how the lifestyle intervention itself is helpful in preventing the development of diabetes from pre-diabetic state, and then the role of metformin. So moving on to the next talk of this session, we all know that one of the most challenging aspect of living with diabetes.
Dr. Preeti, just a minute. I'm actually moving. Actually, I'm going to airport for my flight. So I may be excused for my question and answers. And if you have question and answer, can I give just now or I'm leaving?
I think in the chat box, there are no questions, sir.
Okay. So I'll be leaving, and I'm very sorry about that. I'm leaving.
Sir, can I ask you one question? Sir, what about this role of surgery, bariatric surgery in pre-diabetic condition?
Yeah, you told in your initial introductory remarks. I think there are two things I actually omitted purposefully. Two things. One thing is around the bariatric surgery, and second thing about the low-calorie diet. which is known as very popularly known as keto diet. So I actually purposefully omitted these two things because bariatric surgery, we know that they have given the clue that the diabetes can be reversed. Previously, nobody could think of reversal of diabetes. So with the advent of bariatric surgery, now we can think of reversal of diabetes. But how many years the patient becomes, normal, we don't know. So that is the one thing. For the pre-diabetic population, I think if the patient is morbidly obese, BMI is 35 to 40, then we can think of bariatric surgery in those population, but not for that pre-diabetes population, but for other metabolic disorders. Second, the keto diet, which is very popular in some of the elite population, 800 calorie diet for 2 to 3 months, which is very difficult to follow. And people actually have been gain weight when they stop keto diet. So I think the nowadays I can give you a newer thing is intermittent fasting. So intermittent fasting is gaining, this concept is gaining all over the world, and there are different types of intermittent fasting. Means you can have 2 days in a week, you can have 3 days in a week, or you can have alternate day intermittent fasting with less calorie on that particular day, while the normal calories in other days. There are several studies which says that this can be used as a tool to prevent in the pre-diabetes, also in the diabetic population. So this is, I think, I can summarize these 3 points.
Yeah. So thank you, sir. So moving on to the next topic. That is the most challenging aspect of living with diabetes is polyphagia, that is excessive hunger, which affects the blood sugar. So it is not only the high blood sugar, but also the low blood sugar, that is hypoglycemia, which increases the craving for food. So it becomes a vicious cycle because the more the diabetic patient eats, the higher the blood sugar becomes and the more intense the craving for sugar becomes. So for this, that is what are the various methods to control appetite in patients with diabetes, a clinical perspective that will be talked by Dr. Nitin Kapoor from Vellore. A brief introduction about Dr. Nitin Kapoor. His present designation as a professor of endocrinology in Department of Endocrinology, Diabetes and Metabolism, Christian Medical College in Vellore. And regarding his major achievements, he completed his DM and postdoctoral fellowship endocrinology at CMC Vellore. He then completed his PhD research on clinical and genetic indicators of obesity from University of Melbourne, Australia. He has been conferred with the prestigious AR SATE Gold Medal by the Endocrine Society of India 2020, the Young Investigator Award by the Sri Lankan Endocrine Society in 2019, Melbourne Research Scholarship 2016 to 2020, Tamil Nadu Dr. MGR University Gold Medal in Endocrinology in 2015, A.V. Gandhi Award for Excellence in Endocrine Research 2014, the IJEM Award for Excellence in Endocrine Writing, and several other awards. And he has more than 140 index peer-reviewed publications in national and international journals. And his keen areas of interest are in the field of obesity and metabolic syndrome, pituitary disorders, and metabolic bone disease. He has spearheaded the write-up and is editor of the current and the previous edition of the book, A Practical Guide to Diabetes Mellitus, released in April 2018. Dr. Nitin is also an elected member of the Executive Committee of the Indian Society of Bone and Mineral Research and the Endocrine Society of Tamil Nadu and Puducherry for the year 21-22. Now, with these words, I request Dr. Nitin Kapoor to start his talk.
Thank you so much, Dr. Preeti, for that very kind introduction. And at the same time, I'd also like to thank the organizers of RSSDI 2021 for having me here today. And over the next, say, 20 minutes or so, I shall take you through this topic of how to curb appetite in people with diabetes. And as rightly mentioned by Dr. Preeti, this is often a very important clinical challenge, but I would say it's a very important player in the management of the dietary management of diabetes in our country. I think all of us in the audience are well aware, and we know that diabetes has reached pandemic proportions globally, especially in the South Asian region, where we do have a lot of diabetes. We lead along with China with the world's largest number of people with diabetes in the world. But with diabetes, what we also get sometimes is obesity. It's often a dual pandemic. We say it's a dual package. And though in India, we've been talking about undernutrition for a long time, for many years before, I think obesity has also taken up in a big way. We recently looked at our data from the National Family Health Survey, looking at over 600,000 patients and people, and we found that about 35 to 40% of our Indian population, adult Indian population, suffers from obesity. So when we try and understand the pathogenesis of diabetes and obesity together, what we learn is that one of the major things that stand out is the energy imbalance that happens. The energy imbalance in the form that there is much less energy expenditure and a much higher energy intake. Now, over the years, what we've learned is that this is no longer considered as just a matter of willpower of the individual. This is more biologically determined. Today, when we talk of this energy imbalance or we talk of appetite, we know that there are certain hormones in the hypothalamus that decrease our appetite. Hormones like leptin, the activation of the MC4R receptor or the POMC neurons. So all of this would decrease appetite, would cause satiety. But at the same time, there would be certain hunger hormones like ghrelin, like agouti-related peptide or NPY. And these hormones, when are high, which could be genetically determined, can cause increased appetite. So often there could be an imbalance here. Well, this is also regulated both by the adipose tissue and by the gut. And this is also further stipulated or downregulated by environmental, behavioral, and metabolic cues. So what we see in this slide is, yes, definitely appetite is controlled, is really complex, but it's just not a simple question of willpower of the individual. Cutting a long story short, what this all amounts to in our clinical practices, we often have a patient sitting in front of in the OPD, wherein we are trying to counsel the patient, look, you have to reduce your calories, you have to reduce your food. But the patient is like, doctor, I am hungry all the time. Doctor, bhook lagti hai har waqt, kya karna hai? So how to manage that appetite? I think that's the important question that I will try and address in this setting. And there are broadly 5 domains which can be used in clinical practice to address appetite. Yes, dietary modifications stand first. Also, we look at the literature which is available with respect to the timing of exercise, the quantum of exercise, and how do you place it along with meal, and how does that impact the appetite. We'll talk about the medications that we use for management of diabetes and how they behave with respect to appetite control. The previous lecture, we just mentioned about bariatric surgery, but that also has some impact on appetite control. And we'll also touch upon certain newer therapies which are emerging, which can target genes, which can change the appetite. So let's get started with the dietary modifications. And I think there are several guidelines which are available in clinical practice when you talk of dietary modifications in patients with diabetes. Recently, we published the South Asian Consensus along with the colleagues in Sri Lanka, Nepal, and other countries in the South Asian region. And if there was one important point that I had to bring out from this consensus paper with respect to appetite was that all of us in the South Asian region need to have adequate amount of protein. Even in India, no matter we look at North, South, West, or East Indian diets, we wouldn't be consuming the amount of protein that we should. And therefore, it becomes really, really important to advise our patients regarding that. We recently looked at our own data. This is data from the Vellore Obesity Clinic, wherein people are consuming maybe up to 150 times the calories that they have to. But even after consuming so many calories, we don't make up to the protein intake. Now, this becomes really important because it's not only that we are talking of very high protein. We're just talking about the normal recommended amount of protein, maybe 1 gram per kg that we recommend to our patients. And just improving that small amount of quantum of protein has been shown time and again to improve satiety in patients with type 2 diabetes. A couple of years ago, this was, I think, over 15 years ago, we did this study wherein we just gave exactly the same calories to patients with diabetes who are on metformin. and we just change the carbohydrate to protein ratio in their meals, and we see what is the difference. So it's not only for the appetite, but even you look at the peak of glycemic control, it is much different in people who have adequate amount of protein. So it's not only about the protein that is taken throughout the day, but even in every meal. Well, which protein is good is the next question that we need to address. And there are different types of proteins, especially if you go to the market. Yes, there are natural sources of protein, there are artificial sources of protein. But when you're talking of plant versus animal derived proteins, if we look at literature which is available, I think more and more literature is supporting plant-based proteins as to be more promising for better satiety and better appetite control. This was a paper that we looked at for dietary changes in type 1 diabetes. Believe me, there are a lot of options even in the Indian diet. Even if our patients are vegetarian, there are options of low carb, high protein snacks that can be offered to our patients. So apart from protein, is there anything else? Does the fat really matter? And then we look at this paper which talks about the high fat diets and what is its role with respect to appetite control. If you're talking of unsaturated fatty acids, I know unsaturated fatty acids by conventional teaching is definitely better than saturated fatty acids. But what has been shown in this study, again, the amount of ghrelin suppression, ghrelin is the hunger hormone that I showed before, and using high fat diets, especially polyunsaturated fatty acids, have been shown to have a higher ghrelin suppression. Probably this is one of the reasons why keto diets suppress appetite so well. And I'm not a big fan of these diets per se because these aren't really long-term sustainable, but this is probably the mechanism how these diets actually suppress appetite. It's not only the ketogenic diet, even intermittent fasting has been shown to reduce the ghrelin levels, the hunger hormones, and thereby increase the tendency of fullness in our patients. So ultimately, cutting a long story short, when we talk of dietary changes in patients with diabetes, where we want to control appetite, I think the most important message that stands out is to improve the protein content not only throughout the day, but through each meal, to make sure that we are able to provide more vegetarian-based protein that is probably better. And if you're looking at fat, probably polyunsaturated fatty acid has a better control. Both intermittent fasting and keto diets work by reducing ghrelin and reducing appetite. Let's talk of exercise. And that's the next important thing that we often talk to our patients in our practice when we are managing patients with diabetes. So what does the literature tell us with respect to exercise and appetite control? So early morning timing. So early morning walks are probably the better timing to reduce appetite. What about in relation to meal? This was another interesting study where they looked at whether exercising 180 minutes before meal or exercising 60 minutes before meal would provide you more fullness and satiety. And what has been shown is that it should be done maybe just within an hour of meal. A 30-minute exercise is probably better to produce satiety rather than walking 180 minutes before, and then you would be so hungry at the end of it that you'd probably end up eating much. So again, both the timing and important relationship with respect to the meal timing is important. So early morning and immediately before meals may be a better timing rather than a long gap between exercise and meal. What about medications? And we are all aware that there's so many medicines for managing diabetes. Our knowledge of diabetes medications have improved from a traditional triad to Omnius Octate, and there are umpteen number of medicines. But if there was one category that I would pick up, and that would be obviously GLP-1 RAs. In this slide, in this paper, we published the importance of not only the A1C reduction, but also the weight reduction that happens with each of these GLP-1 RAs. And when we look at the drug, I think the one that really stands out with respect to both weight reduction and A1C reduction, it would be semaglutide. It's been the talk of the town. We look at the impact of oral semaglutide on appetite. In the study, it's very clearly shown us that it does have a major impact on appetite, and it reduces the calorie intake significantly, both in the lunchtime as well as in the evening meals in patients with diabetes. So yes, and that's probably the reason why It has about 15% weight loss, as was shown in this classic NEJM paper at 68 weeks. So yes, both oral and subcutaneous semaglutide tend to help us with appetite. Obviously, the subcutaneous one is far more potent with respect to the appetite reduction and obesity management. Well, the future of anti-diabetes and anti-obesity medication is again very friendly with respect to appetite. Both drugs like tirzepatide and cagrilintide seem to have very good appetite reduction. Cagrilintide, the amount of weight loss that we see in the phase 2 trials today, is almost equal to bariatric surgery. So if this drug really comes through the market, I think it would be a game changer again in our clinical practice. There are several other medicines, and for interest of time, I will move on. So yes, we've talked about dietary modifications. We've talked of exercise with respect to its timing in relation to the meal, timing in relation to the day when we have to do it. We've talked about medications that help to control appetite. What about bariatric surgery? I would say that's the king of obesity management in patients with diabetes. Yes, there are specific indications in this paper. This entire edition, which was published in March 2020, it's dedicated to surgery and appetite control. I think we all are well aware that after bariatric surgery, the appetite comes down significantly. It's because of high fat cravings, the sweet cravings, everything comes down. And that's definitely because of all these hunger hormones like ghrelin, which comes down and that reduces appetite. So I think there's no doubt about it. Enough and more evidence is available, both with respect to the cravings for energy-dense foods, as well as the preference for these foods. What about intragastric balloon? And this is something that we've been doing in Vellore now for over a year or so. We've had good results. Again, this is shown to reduce appetite, but this doesn't reduce appetite, but reducing the hormone. So in these two studies where they've looked at intragastric balloon and the impact on appetite hormones, ghrelin, it doesn't really change much. So probably in intragastric balloon, it's more of the physical position or the fullness of the stomach, which is more important. It's not really a central mechanism, unlike where in bariatric surgery, the ghrelin comes down significantly. And my last part of the talk is the newer avenues with respect to targeting genes. And I think I did speak about the different genes that are helpful in regulating appetite, whether it's the POMC, leptin, or MC4R pathways which are affected. But why is it important for us, especially as South Asians? We see that, in our, especially in Tamil Nadu and Andhra Pradesh, there is still significant amount of consanguinity that we get to see in our country. And when there is consanguinity, there are more genetic problems. In this paper, when we looked at the utility of genetic testing in people with morbid obesity, we found that a significant proportion has it. But why am I talking so much about it today is because today we have drugs. We have drugs which can target these genes in those patients and can produce remarkable weight loss to the scale of 30 to 40 kgs if you have a patient who's got one of these mutations. In our study that we did here in Vellore, we find that about 16% of people with young onset obesity have these mutations. And so again, we need to be opened up to doing these kind of testing. Similar data available from other centers. This paper from Pakistan, as high as 30% of children with young onset obesity have these kind of mutations. So when do we ask for these genetic tests? When we have a patient who is having obesity, which is less than 10 years of age, with morbid obesity, consanguinity, and associated with other associations of young onset obesity. So I think with this, I come to an end. And to conclude, what I would say is that there are several factors that impact appetite regulation. Yes, dietary factors are important. We talked about altering protein. We talked about altering fat. We talked of the role of both intermittent fasting and keto diets, how it affects the appetite. Exercise is important, both in terms of the timing of exercise in the day as well as the meal exercise gap. We talked about the newer drugs which are available or likely to be available shortly and how they can curb appetite very well. We talked about both bariatric surgery and intragastric devices. Both work totally differently, but are helpful for weight loss in people with diabetes. And last but not least, the emerging role of genetic testing, especially now because there are specific therapies which are becoming available for treatment of these disorders. So I'd like to thank and stop here and be happy to take any questions. I'd like to acknowledge the obesity clinic team here at CMC Vellore. Thank you.
Okay, thanks, sir, for the wonderful presentation. So moving on to the third topic of this session, that is the non-compliant patient. How can we help? We all know that the patient non-compliance is a serious healthcare concern which poses a great challenge to the successful delivery of healthcare. And patient non-compliance is not only limited to the failure to take medications, but also the failure to make lifestyle changes, undergo tests, and keep appointments with the physicians. So how can we help these non-compliant diabetic patients? That would be taken up by Dr. Arun Raghavan. A brief introduction about Dr. Arun Raghavan. He is a director, consultant diabetologist, and intensivist of Dr. A. Ramachandran's Diabetes Hospital. He underwent training for research at the prestigious Yale University, USA. He underwent training for diabetes at Christian Medical College, Vellore, and obtained diploma in diabetes from Cardiff University, UK. He also underwent critical care training at Madras Medical College and at Apollo Hospital, Chennai, where he obtained a fellowship in critical care medicine. He completed clinical epidemiology program at the Tamil Nadu Dr. MGR Medical University and training for healthcare management at Indian Institute of Management, Ahmedabad. He was conferred fellowship by International Medical Science Academy and also was awarded membership from Royal College of Physicians, Glasgow. Dr. Arun is a member of several diabetes and medical societies and has been an organizing member of many international conferences and has several international publications and presentations to his credit, and is a co-investigator in many drug trials and is also on the advisory board of various committee. The Tamil Nadu Health Minister presented the Rising Star Award to Dr. Arun at the Times Healthcare Achievers organized by the Times of India and Ernst & Young. He was honored with the COVID Warrior Award in December 2020 by Union Minister and was also acknowledged as the Diabetes Care Personality of the Year. He received the Excellence in Diabetes Care Award from the Union Minister, Government of India in March 2021, and he received the Global Healthcare Young Professional Award of the Year 2021 organized by EEF Global Awards. So he has been awarded so many awards. So over to you, Dr. Arun.
Thank you, Dr. Preeti. Thank you very much for your elaborate introduction as well as your kind introduction of the topic. So far, I had a wonderful time listening to the previous speaker, including Dr. Nitin Kapoor's talk. I'm hoping to keep the same momentum on. I'm hoping my slides are visible.
Yeah, visible.
All right. Thank you for also introducing the topic. And I would also like to take the opportunity to thank Dr. Banshi Sabu, the president, as well as the other organizing committee members for inviting me to this prestigious event. It is indeed my privilege and honor to be part of the RSSDI 2021. So the purpose and the preamble of my talk is to decode the behavior of a non-compliant patient and to see what is in store for non-compliant patients and how can we help such patients. Non-compliance itself, as you rightly pointed out, is one of the biggest challenges that we are currently facing. We are grappled with non-compliance, and this is perhaps one of the largest gaps that we are seeing in the current healthcare practice, both in communicable diseases as well as in non-communicable diseases. More particularly in NCDs, considering the chronic nature of the disease and patients kind of neglect care. They're not adherent to lifestyle, not adherent to medicines because of the majority of patients are asymptomatic. They kind of neglect, and this kind of tantamounts to complications. That's the real crux of the problem that we are facing. And today we are going to focus on chronic care non-compliance. And when we deal with chronic care, it's not just necessary, it's only about drug adherence. It's also to do with lifestyle modification and so on and so forth. But the core essence or the fulcrum is always pertaining or revolving around a drug adherence. I would like to start off with that. And although we have a plethora of drugs in the current era to combat diabetes, unlike a couple of decades ago, we had only few classes of medicines. Even then, we are tremendously falling short of achieving glycemic control or achieving goals in about half the number of diabetic patients that we are treating. And one of the most contributing factors to this is poor medication adherence. And this is a real place where we have to put in a lot of effort. WHO, in fact, has emphasized that efforts in improving drug adherence can actually have a profound impact on the health of the people at large than improving any specific treatment itself. That's how important adherence to drugs itself. So what is non-adherence to drugs? It's simply, adherence itself means simply a patient's medication taking behavior, but obviously it has to coincide with the prescription that is rendered to the patients, as well as the advice that you give to the patients. And compliance obviously is going to determine the therapeutic outcome. Prescription is to us is what procedures to surgeons. So prescription is that important to us. So it has to be a very shared decision-making process rather than having a very authoritative approach where we write and just get away done with it. So that's not the way that we need to approach patients. To improve the adherence, it has to be more a collaborative approach. That is what is going to have improved adherence and thereby translating into improved patient outcomes. Non-compliance has impact not just on patients, but also on the healthcare infrastructure, costs, so on and so forth. There are more number of ER visits, more number of hospitalizations, leading to morbidity, mortality, increased hospitalization costs, so on and so forth. So this kind of this slide gives you the story in a nutshell. Patients who are adherent to drugs, to visits, they seem to have a much better quality of life and they have lower expense in the future. Whereas patients who are non-adherent seem to spending much more in the future and also have a poor quality of life with more hospitalization risk, so on and so forth. The WHO as well as the CDC have been deliberating over the years how to sensitize patients with chronic care disease, particularly about how important it is to be adherent to a lifestyle, adherent to medicines in the journey of every chronic care disease. And this is also the buck doesn't stop only with the WHO CDC. It's also a responsibility of clinicians, doctors, where we should have a public-private partnership to spread the message further and sensitize the patients at large. In the United States, about 5 to 8% of the entire healthcare budget seems to be considered as a wasteful resource because 100 to 300 billions of dollars per year is considered as resulting only from non-adherence to medicines. So what are the barriers to adherence? Barriers to adherence can be multifactorial. As shown, there could be patient factors, there could be provider factors, as well as external factors, starting even from age. Patients who are elderly may not have the same alertness as somebody who are younger. They may have lower hearing capacity, reduced vision, which could be impeding factors for adherence. Gender could also play a role. Women seem to be taking care more of their family members than themselves. Education, absolutely, because improving the health literacy kind of gives you an understanding, fair understanding about the nature of the disease, about the adverse effects of the medicines, and you may be able to dispel myths surrounding the disease, drugs, so on and so forth. As I already mentioned, in the provider's factors perspective, communication is key, and producing a conducive environment in the clinic and the support system should also come to the party in making the patient comfortable. All these would perhaps increase or help to overcome poor adherence. Other external factors such as multiple comorbidities, the duration of the disease, as well as the cost to treatment, access to care can also be factors which can contribute to non-adherence. So this pie chart gives you a fair representation about which of the factors are contributing significantly. Patients do not feel the requirement of medicines, cost and adverse effects seems to be the most common factors which are contributing to non-adherence. This also pretty much echoes the similar findings that we saw from the previous slide. The socio-economic factors seem to be the most commonest reason for non-adherence. So non-adherence could also be divided into primary as well as secondary causes. The primary itself means the prescription itself is not dispensed. Secondary could also be further subdivided into intentional, where patients do not have any intent in taking medicines, either because they do not believe that the disease requires medicines, or they believe that the medicines have some adverse effects, so on and so forth. Unintentional is the real challenge. The patients, although they would like to take medicines, but somehow they are probably forgetful or not giving that much of due importance or time to taking medicines, and other socioeconomic related, such as cost as well as beliefs about treatment. So this is a study which studied the impact of treatment non-compliance on mortality in patients with type 2 diabetes, looked at both patients who are non-attenders to clinics as well as non-compliance to medication. Similar characteristics, if you look at both the groups, there were patients who had higher HbA1c, who had more morbidity, as well as there were smokers. And if you look at this data, patients who were not adherent to visiting clinic regularly actually had a higher mortality. And if you look at data, patients who did not visit regularly as well as not adherent to medicines also had a statistically higher rate of mortality. It is almost as much as patients who have hypertension or are smoking. So that's the amount of impact non-adherence can have on mortality itself. So there's another study to look at patients adherent to oral hypoglycemic agents as well as antihypertensives and statins. And if you look at the summary measure and you also look at the PDC cutoff, patients who have been taking less than 50% of the medicines seems to have twice the risk of mortality and hospitalization compared to patients who are actually adherent to medicines over 90%. So the mortality, in fact, increases twice. And coming to the OADs, DPP-4 inhibitors, patients seem to be more adherent compared to sulfonylurea acids, perhaps because we know that hypoglycemia itself could be a deterrent factor. It could derail the patient's confidence. And as we can see today, we are blessed with the agents such as incretin-based therapies, metformin, and perhaps even SGLT2 inhibitors where we do not have hypoglycemia. Hypoglycemia has been another challenge. Insulin itself has been a challenge in terms of even initiation, but continuation with insulin, the patients have had other challenges such as injection site reactions, fear of hypoglycemia, forgetfulness, and again, myths, beliefs, so on and so forth. There have been a number of factors which have also contributed to poor adherence with insulin. Now, moving on to the other set, apart from the drugs, looking at the dietary recommendation. So patients have found following diet very difficult because they are either very expensive or it is very difficult to spend time to actually either focus or cook the specific diet required for the specific disease. Similarly, the physical activity non-adherence is also because of lack of time and also lack of intent. These two factors seem to be the most important reasons contributing to non-adherence. So how do we approach patients with non-adherence? Obviously, one size does not fit all. We need to understand the root cause of non-adherence. And there are two main pillars of approaching patients. One is monitoring the patient and understanding what is the reason and getting the data, and then using appropriate intervention suitable for that particular patient. So it has to be tailor-made, and that's pretty much important. And as I mentioned, adherence, non-adherence itself could be extremely complex. It could be very different from patient to patient. There could be direct methods as well as indirect methods. Direct methods is as simple as checking blood sugars, including, we now have even we're blessed with the CGMS. We have also the average HbA1cs. We may be able to document whether to an extent, whether we could correlate with the therapy that the patient is taking, and looking at the history, we would be able to understand whether patient has been compliant or not. And there are other indirect methods where simple, practical, pragmatic ways of just looking at the pill counts or looking at the prescription refills, and even electronic medical containers can sometimes help, although they are much more expensive, and they can also be fudged with need be. But these are very expensive tracking systems. Other indirect measures would be simple questionnaires. They always kind of help. and also using the support system in having open-ended questions with the patients, because patients are not going to be quite honest at face value. They're not going to come and be explicit about their non-adherence. They're going to possibly hide. So we have to have open-ended questions, kind of lure them into the conversation rather than being condescending with them. And that's perhaps how we may be able to get more and more information. Use of technology can really help applications with interactive questionnaires. And we could also have novel algorithms built to track patients' behavior. We have the likes of Google and Apple Health Fitbills, which are tracking behavior. So the world is moving in a direction where we are going to get more insights into patients' behavior. The other future next generation delivery systems, as well as the smart instrument pens in the pipeline, are embedded with the Bluetooth sensors, wherein we know whether the patient has been routinely taking or even adherent to the correct dose. So those are the ways we may be able to get further insights. So there have been a number of interventions over the many years. There's a couple of years back, the Kunti had done a meta-analysis of a number of interventions. There were many pharmacist-led interventions which had a tremendous amount of success, and also studies with the skilled ancillary support staff, wherein leveraging the trust, the bond, the rapport formed with patients has been quite helpful in improving adherence. So this is where we have to bring in or build an environment, conducive environment where nursing staff, paramedical staff can also engage more often with the patient, build their trust, and as well as make sure that they are adherent. This has been shown in multiple studies. Education, counseling can really play a huge role. Digital intervention obviously has made great strides. We know that we are in the cusp of a digital transformation of healthcare. And digital intervention perhaps is going to be the future. And the studies have also shown constant alerts and notifications have also helped patients to be more adherent. And this is going to be the future as we move forward. So a multidisciplinary team is always pretty useful. Apart from the doctor, it's not just the clinician. It has to be the educator. It could be the nutritionist. It could be the pharmacist. And it could be anybody in the value chain. Each in India, it's pretty our care model is pretty different from the Western world. So we may, some of us may have our physician assistants, some of us may have our nurses. So it depends upon what protocols we set, but we do have to bring in the support system to the party so that more engagement is there with the patients. And we also understand patients' lifestyle, patients' behavior, and try to give a medicine which could suit the patient's lifestyle, and also educate the patient what are the possible adverse effects with each drug, so that patient is empowered, patient is quite confident, and all these efforts could actually improve the adherence. And moving on to the technology, as I mentioned, we are at the cusp of not just digital intervention, but actually a transformation of healthcare in a digital way. So this obviously, and we've also witnessed how much the paradigm has changed with the use of CGMS as well as the newer generation glucometers. And we know that today we have the Apple Health apps, we have the Android apps, the APIs, the application programming interface of each of these apps seems to integrate with hardwares of Fitbit and other healthcare apps, where so much of data is collected of one particular individual. There is so much of insights and there is so much of holistic data now available. I think then in the future, there will be more algorithms built to track these patients, and there would be the use of machine learning, where with the use of machine learning as an adoption of artificial intelligence, we would be able to optimize and also have customized intervention for patients, which would in turn improve the adherence. Thank you so much. I hope I've adhered to the time. Hello?
Yes, sir. Hello.
Yes.
Yes, sir.
Yeah. So I finished my talk.
Okay, sir. Thank you.
So can we go to the question and answer session?
सर अभी मंगेश सर का एक बाकी है टर्न, तो उसका खत्म करके हम जा सकते हैं यार.
Sorry, I didn't follow you.
Hello.
Yeah.
Sir, Mangesh sir's turn is pending, so can we go further or?
Yeah, absolutely. So anybody is there to navigate this? Is
Yes,
chairperson
sir.
there?
Okay.
Please take it forward. Yeah.
Okay, sir.
Good evening, friends. Thank you, sir, for those kind words of introduction. And I'll be speaking to you today about role of vaccines in the diabetic population. Now, before I start my deliberation, I would like to express my gratitudes and a huge thanks to the entire RSSDI team, especially Dr. Bansi Sabu, Dr. Sanjay Agrawal, Dr. Vasant Kumar sir, and the main educational partners for this session, Abbott. Thank you very much for choosing me to be delivering this talk. And my agenda for today is vaccines in diabetes. Especially, I'll be focusing on the influenza vaccine. And then finally, there will be some carry home messages that I'll try to give. Now, friends, as we all know, that vaccine by definition is a substance which is used to stimulate the production of antibodies. And either it stimulates the production of antibodies with the aim to protect from the causative disease, or it provides a long-term immunity to fight the disease well. And it is generally prepared from a causative agent of a disease or its products or a synthetic substitute treated to act as an antigen without inducing the disease. Now, this is very important to understand that the vaccine cannot induce an active disease in a person. Now, we do have got nationally a very well established pediatric or the children immunization program. But unfortunately, the adult vaccination program is not well established. And there are three important reasons that adults also require to get vaccinated. Number one is this, that as children are, adults are also at the equal risk of developing the very serious diseases, and those are mostly possibly prevented by the vaccines. So there are preventable diseases by vaccines, which adults are at the risk of. And also we need to understand that once you are in adulthood, you cannot afford to become sick. Forget about the morbidities or mortality sometimes, but most importantly, the cost of the illness, the burden on the healthcare system, and the expenditure, and the quality of life, and the work time which is lost, the work hours lost are significant, and it has got an impact as far as the outcomes are concerned. And of course, the benefits are usually basically that it also helps you in protecting the health, not only of yourself, but your surroundings, your near ones, your dear ones. So vaccines are one such kind of, I would say, therapeutic media where it can impact the outcomes not only in you, but your near ones or your dear ones. So what are the vaccine preventable diseases commonly seen in India? There are around 5 or 6 vaccine preventable diseases. Pneumococcal diseases, influenza, hepatitis, zoster, tetanus, typhoid. We all are aware about it. But most importantly, remember that whenever it comes to associated comorbid conditions, sometimes these diseases can cause menace. The myriad of challenge that these diseases can pose really can ultimately end up into sometimes a very unfortunate mortality. And as far as Indian healthcare system is concerned, we all are aware that India is a hub for the non-communicable diseases, and especially diabetes, stroke, heart diseases, hypertension, malignancies, dyslipidemia. We all are trapped. Let's talk a bit about diabetes today. We all are aware about the burden of diabetes. One in every 11th Indian adult is diabetic. And not only that, even though our Prime Minister, our Honorable Prime Minister, is very proud to say that our young nation is progressing fast. But remember that this young population, which is currently young, is also going to age probably a decade and a half down. Now, we all are aware that all these elderly people will surely require adequate protection from not only the comorbidities, but the factors or the diseases which can impact the outcomes in the comorbidities. And the commonest diseases which can impact the outcome of comorbidities are usually influenza and pneumococcal disease. But unfortunately, adult immunization has some barriers. What are those barriers? Is that there is no uniform universal immunization program for adults as we have got for children. There is always a vaccine hesitancy, and we all have witnessed this hesitancy in the COVID times, where the adults, they keep on asking many questions, not only as the patients, but also whenever it comes to the opportunities. Unfortunately, the cost is the big barrier, and then there is a lack of awareness in the general population. Unfortunately, healthcare providers are also not well trained to even counsel the patients about the importance of the adult vaccinations. And there is a lack of drive among the policymakers to promote the adult vaccination. So this is high time now. And this is what exactly Association of Physicians of India, along with the many other societies like Indian Society of Nephrology or IMA or even Geriatric Society of India, or now with RSSDI, Association of Physicians of India, has taken a step ahead in improving and probably disseminating the awareness about not only the importance of the adult vaccination, but its ease of use. And recently, under the leadership of Professor Dr. K.K. Parikh and Dr. Arul Raj, I had an opportunity to be as an editor of an adult vaccination publication, which we recently did, where we recommended vaccines to the adults, especially for those vaccine preventable diseases where there is an comorbidity associated. We have adequately insisted that in the developing countries like India, infectious diseases are still the reasons for the mortality. And if at all we need to think about reducing the mortality because of these infectious diseases, we need to improve the adult vaccination program. Me, along with Dr. Shashank Joshi and Dr. Agam Vora and team, also have written the guidelines for the vaccination during the COVID pandemic. And there we have recommended that apart from pneumococcal and influenza, the diseases like varicella or human papilloma or the zoster or even MMR should be also considered as an adult vaccination advocacy. And this is what a handout which is there as a suggestion for the adult immunization paradigm for the patients, those who are interested. But to simplify it, there are 5 primarily vaccine preventable diseases which will genuinely require everybody's attention, and they are very easily addressed. Now, being an Abbott session today, probably I will be speaking more about influenza. Now, if you look at the global impact of influenza, we are all aware about this disease very well. Every one of us have, have got exposed to this influenza virus sometime or the other in our lifetimes. And you know that there are nearly 5 to 10% of adults which are exposed to influenza every season. And the number is mind-boggling. Around 3 to 5 million people annually get affected. But what is most disturbing and probably where you can work is the mortality associated. Look at that. Nearly 300,000 to 600,000 people lose their lives annually to this disease. And influenza not only does that, but also increases the risks of hospitalization in the patients of diabetes, in the patients of not only diabetes, but it makes people too vulnerable to develop a myocardial issue or a myocardial challenge or a stroke. And especially if it happens in a COPD patient, the mortality increases to nearly 30%. So influenza always, you must remember that it increases the risk of hospitalization, the long-term exacerbations of the conditions, usually which are chronic metabolic challenges. We all are aware that diabetes is another immunocompromised, I would say, disease or a state where the people are vulnerable to catch respiratory infections. 6 times more likely you are to develop or to catch influenza if you have diabetes. You are likely to die 3 times more than a common people, those who do not have diabetes, because of influenza. And also very important, the mortality increases to 15% during the flu epidemic. 15% may not strike you here, but what if I say that 1 in every 5 or 6 patients are vulnerable for the menace of influenza related mortality? Remember that. While you need to understand that these are preventable diseases, and that is the place where influenza vaccine plays a pivotal role. There are multiple scientific data publications which are published. Now look at this on your slide, which is a retrospective cohort study using a primary and a secondary care data from the clinical practice research data link from the United Kingdom. And they looked at nearly 7 years cohort, and the number of patients or the people, those who are vaccinated, were around say 130,000 people. And in comparison to the unvaccinated patients, there was 30% lower risk of hospitalization because of stroke. There was 22% lower risk of heart failure, 15% lower risk of pneumonia, and 24% lower risk of death from any cause. There are multiple studies which have come from India also, and we talked about all the different types of benefits that influenza vaccine provides, especially related to the NCD outcomes or non-communicable disease outcomes. Look at this. If you have diabetes, if you have heart disease, if you have stroke, you have got a pulmonary disease, influenza vaccine can prevent infection, can protect you against NCDs like heart attack and stroke, and also can protect you against development of complications in the existing NCDs. And that is the reason why global guidelines, along with Association of Physicians of India and RSSDI, has come out with a recommendation that in the patients of diabetes, and especially with the associated cardiovascular diseases, these patients must be annually vaccinated with influenza. And especially in those patients, those who have got a history of diabetes of 6 months and more, should receive annual flu shot every year. Now, there are different types of influenza vaccines which were developed. The currently used influenza vaccine is a subunit vaccine, which is a 3rd generation vaccine, where we use the particular virus subunits to trigger the immunogenicity. So subunit vaccines are found to be immunoequivalent to the split virion vaccine or a whole virion vaccine across all the age groups. Why? Because remember that subunit vaccine is not only efficacious, but elicit the much less local injection reactions comparative to the split virion vaccine or the whole virion vaccine. And not only that, it significantly lowers the local and the systemic reactions. And most of the times, the patients, they tolerate it extremely well even after inoculation. What is the best time to administer? The best time to administer is usually decided depending on which part of the earth you stay, which hemisphere you stay. So that is the reason why there is a global influenza surveillance and response system developed. Even in India, we have got 3 centers. We have got the centers in Mumbai, Pune, and Kasauli. And they look at the incidence and probably the epidemic of influenza happening in particularly, especially in India. And WHO has come out with a guidance saying that it is usually recommended that all the patients, especially with diabetes, should be annually injected with an influenza vaccine. Now the question is usually asked, why annually? We need to understand that influenza virus undergoes a mutation very, very regularly. So it changes its composition each and every year. And secondly, the vaccine induced immunity does not last longer than usually 1 year. After usually 1 year's period, usually the immunity level starts going down. So the memory of the immunity of the previous episodes is not as effective as for any other disease. And that is the reason why the influenza vaccine is annually administered, and usually the timing is 2 weeks before the beginning of the season of the influenza. This is the best time to administer. And especially when it comes to the recommendation from WHO, they have said that, independent of the hemisphere you stay or a country you stay, you must take influenza vaccine at least 2 weeks before the start of the season. Now, which vaccine to give? We have already discussed this. If you really look at the global recommendation which has come and the incidence, you can clearly see that the commonest virus usually causing flu is usually influenza A H1N1, and we all are in India are aware about this. Then the second commonest is influenza A H3, and then of course we do have what influenza B epidemics as well. So in northern hemisphere and southern hemisphere, usually the best time in the southern hemisphere, that is in the place where India is, September is the ideal time for administering. And usually this time frame is basically decided depending on the time which is required for production and approving of the vaccines. And that is the reason why around 6 to 8 months are usually necessary for the fresh batch of influenza vaccines to come. Remember that we need to, administer influenza vaccine to each and everyone. Influenza strains keep on changing, and this is an evidence. Look at the southern hemisphere different strains. Now you will see here that, if you can see here in NH or northern hemisphere NH1920, this is what A Brisbane 02 2018 H1N1. What do you understand by this? Now I'll just explain you how this influenza nomenclature goes. A is usually the type of the influenza. B is from where the strain is isolated. C is actually the month what we talks about, and then it is the date, and then of course the H1N1 is the type or the pattern of the antigens that it has got. So that is how the whole nomenclature goes around. And the most important thing is this, that irrespective of that, you need to understand that the composition of the influenza virus vaccine changes every year. So a fresh lot must be injected to most of the patients, those who have diabetes or the associated comorbidities. You can clearly see from the slide that this year 2021-22, you can see that there is a new strain, which is a Cambodia strain, especially in the southern hemisphere, which is emerging, and that is the reason why the new strain viruses vaccines are available. API also recommends the annual dose of this quadrivalent or tetravalent influenza vaccine to all the adults above 65 years, all the healthcare providers and pregnant women, and less than 65 years with the people, those who have got comorbidities like diabetes, hypertension, malignancies or immunocompromised state, organ transplant, etc., etc. There is a 0.5 ml injection of the inactivated tetravalent influenza vaccine, which is given, usually injected on the deltoid region. And the best time to inject, especially in India, is usually between September to December. That is the time we should promote the influenza vaccination. So what is the scope of this influenza vaccine in your OPD? For the routine assessment of the vaccination status and the caregiver, always remember to assess, recommend, administer, and document the vaccines to all the elderly, those who are coming to your clinic, and especially with the chronic health conditions, and to the patients, those who love traveling or going to pilgrimages, or the countries where there are vaccine specific guidances are there. You need to have the vaccine documentation and records very, very clearly preserved. So to summarize, we all have to understand that all the population globally as well as in India are aging slowly, and they are all vulnerable for the diseases which can be easily preventable from the vaccination programs. So adult vaccination is equally important. Why? Because the burden of the vaccine preventable disease is very high. The impact of the vaccination, if at all you achieve, is going to be very high. Vaccines are cheap ways of treating these diseases, because remember that prevention of the disease is always cheaper and the safest option than the cure of the disease. Vaccines are widely available. They can be easily, made available, and they do not require any specialized training to your healthcare system. So easily remember that there are necessary steps to improve the adult vaccination coverage by building the awareness and education. That's what exactly even RSSDI now is doing. And of course, the integration of the vaccination program in your day-to-day routine clinical practice. So keep your antennas open and always believe that vaccines are not only for kids. Adults also do need vaccination. Thank you very much for giving me this opportunity. I once again thank the entire organizing team for giving me this opportunity. Thank you. Stay safe, stay happy. Bye-bye.
Thank you, Dr. Mangesh sir, for enlightening us diabetes and vaccination regarding that. And just would like to ask you a brief question, one only. From your side, in brief, practical tips for the patient to convince the vaccination, because here it's a biggest problem that we need to convey to that patient. Sorry. So we shall go ahead for the next session. And next session, we do have Dr. Chandalia, sir. Dr. H.B. Chandalia. He is going to speak on Score the Goal, an expert approach for improving glycemic control in pandemic era. I welcome you, sir, for the session. Dr. Chandalia, sir, is a director of endocrinology, diabetes and metabolism at Justlock Hospital, Mumbai. Also director of Diabetes Endocrine Nutrition Management and Research Center, past president and patron of RSSDI. He has been at a various faculty position at the University of Alabama Medical Center, Birmingham, USA, faculty of Grant Medical College, Mumbai. He has on his name various publications, approximately 75 articles, original and reviews in various journals, 20 authorships, editorship, and various contribution to the books and editors of International Journal of Diabetes in Developing Countries, editor of Diabetes Today since 1991, and editor-in-chief RSSDA Textbook of Diabetes, 3rd edition, 2015. I welcome you, sir, for this session.
Thank you. Thank you, Dr. Panjal. And nice to be here on the RSSDI platform. So I will be speaking on the topic of COVID-19 pandemic and management of hyperglycemia. So I can share my slides. Can I share my slides? Or
yes,
can
sir.
you
Yes, sir.
project? Yeah.
Yes, sir, you can share your slides.
Yeah, wait, I'm not able to see. Share thing, 1 minute. I don't see the.
Parth, you can make sir host.
I don't see the green thing I can click, There is
Yes,
something here
from RX event, can we make the sir host?
Pardon me? Shall I enter again? Go back up because some advertisement has come on my screen. Hell with it. This is a problem,
Parth?
Yes, sir. Can you send me to your slides so I can share from my side, or else you can minimize all these things and.
I have sent you already. I have sent you already.
Okay, just a second.
This must be with you, I sent in advance all the slides. Okay, I can share now. Let me try. I got it. Okay, can you see my screen now?
Yes, sir. Yes.
Yes, sir.
Make it on full screen.
I think I have to make it full screen. Okay, let me see. Oh gosh, I keep getting advertisements of this Zoom. Advertisement is such a nuisance.
Yes, sir. And the right hand side, there is a force button.
I know, but I don't know how the ads keep popping up, in between. Can you please, do you have my slides?
Yes, sir. I'm just getting, sir.
Yeah, please. Because there is some problem here.
But sir, you have to press.
But I should
F5.
get out again.
No,
I should get
no,
out
no,
again.
No, sir. Just press F5.
Press the
Press F5.
F5. A5.
F5.
F5. Okay, wait. F5 together, yeah. It's funny. Really. Every time something funny happens with all this.
Sir, just give me your remote access. I'm sending you the request to remote access. I can.
Yeah, approved. Okay. All right. I think we are on the second slide, which is fine.
Sir, now you can changing from your side, sir.
I can change. Okay, great.
Yes.
Okay, I think
you
we go
change.
quickly down. All right. We
Yes,
lost
sir.
2 minutes. Sorry about that. Okay. This
You can
is
start, sir.
sponsored by MSD. So you see the usual disclaimer. So we discussed this problem of pandemic and management of hyperglycemia. I think this has been much talked about topic and very much in the media as well, and a lot of our meetings. But I'll summarize some of these aspects quickly with some of the experiences which I have had controlling hyperglycemia in my patients during this 1.5 or 2 years of time. So one thing is doctors are not easily approachable, lack of connection with physicians. And then many patients don't accept teleconsultation, which can be one way of treating this hyperglycemia. Quite a few of my patients are waiting until we started in-person clinic. So there's some who cannot handle this, something like I could not share the screen now, something like that happens to them all the time. And of course, you see exercise is not regular. Food, early on, I found sugars were dropping in during COVID really, because food availability was really scarce. But later on, as things improved, food supply improved, yeah, I find that hyperglycemia started increasing in all my patients. And overall, I've done teleconsultations about close to 4,500 during COVID period. And each day 6 to 8 and 6 hours a day, by the way. See, not 2 hours finish some 6 or 8 patients or 10 patients. And we have done that. And we realized that slowly they started gaining weight and the food availability getting better. Economic challenges were there. People lost their earnings. They could not adhere to the program. And there was non-availability of strips, especially I've seen. The medications were available. The strips availability was bad. And therefore, people could not monitor. See, now, how does uncontrolled diabetes impact COVID-19? And of course, COVID-19 infection increases insulin resistance. Insulin resistance obviously causes poor insulin response and overall leads to relative insulin deficiency. So on the left side, you see all those, and from there ensues all the effects of hyperglycemia, which I don't want to describe for you. But I want to emphasize is that even a type 2 diabetic can be in the DKA, in diabetic ketoacidosis, in a situation like this, infection or stress. Remember that we always sometimes say that diabetic DKA occurs only in type 1 diabetics. A type 2 diabetic with relative insulin deficiency in states like this can go into ketoacidosis. So it's better to remember that this is possible. And many of them, those are elderly who suffered more with COVID infection, they will go into a hyperosmolar state. And when being admitted to COVID ward, the sugars were high. At that time, there one major problem was communication. Communication with the COVID team. Like in Jaslok Hospital, we had a good COVID ward, and our COVID team was trying to do a great job. However, early part, when we were not involved, even online, you see, we found that patients being discharged with 600 to 700 blood sugar, most of them. And even mild to moderate COVID being discharged, the sugars, especially if steroids were given, will be 600 to 700, especially in moderate one. You see where steroids were given for some reason, for a valid reason. And hyperosmolar state would occur. And then we had to handle that online and combat that hyperosmolar state. So these are the possibilities. You see, hypoglycemia, interestingly, also can impact the outcomes. And therefore, use of hypoglycemic agents will have to be extremely cautious in these emergencies. And although remember that insulin is the mainstay of treatment, and therefore you'll have to use it extremely cautiously. And hypo both can impair the immune system and thereby, thereby increase the severity of the COVID infection and the poorer outcomes. But hypoglycemia impacting, you see, immunity and impacting outcomes, sometimes we don't realize. So you have to be extremely cautious in not producing a bad episode of hypoglycemia in these people. So between bad hypoglycemia, maybe and bad hyperglycemia, we have to steer the course, which we do in most emergency situations. And this is one of those. And I think those who handle emergencies, we will very quickly, they could get a handle over this situation. Then very importantly, what kind of blood glucose you should target. And you know that we have gone through an era where those very famous studies of Vandenberg, etc., were there, which were advocating a much stricter control in the intensive care unit as well as people with the other emergencies. But this nice sugar study, which appeared in NEJM, you see, about I think 15 years ago, see, nice sugar study showed that instead of having the blood glucose values try to target and bring down to something like 80 to 120 or something like that, it is really more injurious and it causes bad outcomes. Frankly, what you should aim at is something like 140 to 180, 140 to 180. See, and maybe even 120, but don't try to go below 120 because hypoglycemia is real risk. And remember that 70 is hypoglycemia itself. Many of us don't realize, we only think of 40 as hypoglycemia. 68 exactly is where the counter-regulatory responses start. So you should not go there. So when you talk of 80 by 80, 120, you're really endangering patient's life. Now, teleconsultations were very much appreciated during that period. And many of us have done that. And I'm sure many of you have done even larger numbers, volumes, and you see, and one, of course, you talk on the phone, and secondly, face-to-face, you can see on the video. So what is really important is diabetes self-management, and there already, if you had educated your patients, those are already taking insulin, you educated them, there's less problem. But many of them you have to educate online, self-management, and new ones which we had to start insulin on some new ones, we had to really take a course to a nice video showing how to inject insulin. And frankly, most of them were able to do it. Really, nobody had to go at home because there were not many people available to go at home and demonstrate. And then they learned from that video and they started insulin successfully. They started measuring glucoses for the first time. We started them by again showing the demonstration online or just sending a video of again how to do that. So I think we should have those with us, so very quickly you can send those to the patient and they can learn from that, you see. And of course, you see, you of course use the proper anti-diabetic agents that we discuss as we go along. So face-to-face also is sometimes important, because you may like to see some signs. It is really possible to see some very important signs. The most important is in general saying whether the patient is very sick, because sometimes while talking to the patient, you don't realize whether this patient really needs hospitalization. Sometimes the relatives can transfer that anxiety and you understand, you immediately start perceiving that this is a bad problem. I must take this patient to the hospital, or advise that I will not treat you on outpatient basis, you see. And this is important. And of course, the oxygen saturation, you keep asking them all the time. This is very important. It becomes very important to monitor that. And then when you see a patient, sometimes on the video, you can appreciate that the patient really appears very ill and maybe dehydrated and really sunken low, and therefore has to go into the hospital and get hydrated and maybe properly treated. So this is important. So So of course, a lot of education is possible through this. As a matter of fact, education has become actually better during the COVID period between we physicians also, between all experts, between all technical people. I hope between politicians also education has spread because of telemedicine, also because of teleconsultation with each other. So I think we can really teach patients quite well on this, and I think this is very important to look at all their comorbidities, teach them about basic skills of either insulin injection, the blood sugar testing, and hypoglycemia has to be taught if you are prescribing insulin first time on them. And even earlier they have not faced this problem. You must talk about hypoglycemia and sick day routine. You should be extremely familiar. Some of us who have 2 to 3 educators, sometimes 4 educators employed in the clinic, you see all the time, most of our old patients were fully trained on all these aspects. In fact, these aspects are not only taught to the patient, but there is a clear record maintained, a signature of the educator who has conducted this basic survival skill to the patient. And that is, therefore, we found them very easy to handle these patients during COVID. But newer ones, we have to do the education part itself and take it further from there. And of course, we were still quite successful in controlling their diabetes very well. And those who were discharged from the hospitals with bad hyperglycemia, also we were able to control. But the idea was to really, be in close touch with them and communicate mainly on the emails and on the phones. And a clear period of 6 or 8 hours where we will sit down and answer all these calls and help our patients. So this is why face-to-face is necessary in order to elicit some science, some more science and look at the general aspect, which I told you. I won't go into details of these slides, but remember that, you see, you can easily see edema, seeing the face, you sometimes realize, what is happening to the patient. You can see a goiter, you can see leg with edema. In diabetic foot, you can see on a video, lots of things that, I've treated some very bad diabetic foot infections during COVID period and very successful. In fact, most of them ended not beyond a amputation of a toe, frankly. And as a matter of fact, below knee, we don't remember for last 1 decade we have done any below knee in our Jaslok hospital because we are able to vascularize people and most of them are due to neuropathic ulcers. So remember that you can do a lot in the diabetic foot and follow them very nicely with your teleconsultation and treat them with antibiotics and of course a good control of diabetes. History taking, I would not like to go into details of that. This is something very basic we learned. However, I must say that those who are oriented to good history taking can do very successful teleconsultation. Those are very much trained to elicit a lot of science and very, very exotic science with 3 different techniques. They are quite absurd, they cannot apply telemedicine very well, And those overall all trained in USA they are very good history takers and overall trained somewhere else, there are some blind spots and history taking is not as good. The most important thing missing there is the review of systems where you inquire questions, 3 to 4 questions about each vital system, whether the patient has those symptoms. Like for example, cardiovascular system, when you review, you'll ask whether you have dyspnea or exhaustion, whether you have edema, whether you have cough, are you breathless at rest. So these direct questions, what is called in UK, textbooks, system review is lacking. And I think that if you introduce, you can do very successful teleconsultation because you more or less have diagnosed everything by talking to the patient. And then you really can see a few signs on the video and you can go ahead and do a good job. So this is very important. So telemedicine examination, what do? You see? And for the foot especially is very helpful in the diabetic. And of course, you can see patient's anxiety, patient's expressions. That also tells you what is happening to that person as a human being, which is also very important for you to take some decisions, you see. And I think you can elicit some signs, you see. Now, drugs and insulin, sometimes you can remove the errors, you'll see on video. For example, you can tell the patient to show the drug and sometimes you realize the different strength. You see, for somebody taking thyroxine, the chemistry pass on a different strength or wrong. So all that can be done, you see.
Sorry to interrupt you, sir. Hello, sorry to interrupt you, sir.
Pardon me?
Maybe, sir, your screen is zoom in. So your PPT is
Oh, mine is moving.
Yes, yes,
Screen
yes.
is moving. I don't know.
नहीं स्क्रीन इज मूविंग,
I
बट
really
आपकी
don't know how
स्क्रीन
to.
जो है ना वो जूम हो गई है सर, तो आपका कंटेंट है ना कट रहा है सर साइड से। तो एक बार आप स्टॉप स्क्रीन करके रीशेयर करेंगे सर, यही सही, या तो स्टॉप स्क्रीन करके।
I can see the screen quite well. I find it quite stable.
ओके सर, ओके कंटिन्यू।
I find it quite stable on screen. Is it moving? Screen is
Sir,
moving?
it's moving.
Sir, you can just stop share once and share it again.
Okay. Stop and share. Okay, I'll do that.
You stop sharing once and share again. That will
Share again.
resolve.
Okay. I can do that. All right. Okay, I can go fast then.
Yes.
Enlarge it. Yeah.
Yes. Slideshow.
Screen. Full screen.
It's downwards. You can also press that slideshow button near to zoom.
It's a fourth button. Yes.
Yeah,
yes.
that one.
So just click on that.
Yeah. Is it okay now?
No, sir. You have to zoom out first of all. Your PPT is zoom in, so you have to zoom out your PPT.
Oh, I have to zoom out completely.
Yes.
Okay. Leave. Okay, leave. I left me.
Dear friends, thank you for being with us. We are waiting for Dr. Chandalia to join again the session. It was a nice session going on regarding how we can improve glycemic control during this pandemic and what are the practical tips and strategies Sir was guiding us regarding glycemic control during this COVID era. We are just waiting for him to join again. Yes, Sir is with us now.
Yeah. Can you show my slides quickly?
Parth, can we run the slides from our side, from
Yes.
RX?
Yeah. Because I've lost from my minimized thing is gone.
Sir, can you
Came
send
out.
sir, can you send me the slides?
Oh God, I sent you already. So badly organized. I sent it yesterday.
Okay, just a minute.
And then that I wrote that keep ready from your side.
हेलो
Yeah.
हाँ सर आपकी स्लाइड हम शेयर करें क्या अभी
Yes, yes, we have to share.
ठीक है सर 2 मिनट दीजिए
Yeah, please. Sir, it was a fantastic approach by making it hybrid type during this COVID era, which you enlightened.
Are you able to test my slides?
Yes, sir. We are trying and they will present.
सर अनम्यूट योरसेल्फ सर अनम्यूट योरसेल्फ सर Yes, sir.
Okay. Yeah. You want me to operate?
Yes, sir.
Slides?
I am giving the right, sir.
You will do it?
No,
Yes,
I am
sir.
giving you right, sir.
Okay.
Yes, sir. You can now change from your side, sir.
Okay. So we go fast. Telemedicine. It's not changing. Huh? Okay. All right. Yeah. We were somewhere here. Okay. See, medications, I see diet, exercise, we talked about, and I think patients are already educated, have no problem. You see, medications, frequency of monitoring all varies. In those who are very sick, badly hyperglycemic, we advise them to monitor about 3 times a day, not 6. Frankly, we have a strategy of covering 6 samples in either 2 days or 3 days or even 6 days. So 1 sample a day, 2 a day, 3 a day, 4 a day, like that. And I think that works very well because this 6 times a day in some very mild patients may be unnecessary. See, and of course, patients should know about hypoglycemia very well. You see, in India, what happened is, you see, pre-existing poor glycemic control, because at the moment we achieve A1C goals only about 25 to 40%. In best clinics is 40%. In average clinics is 25% of people controlled. So majority of these patients undergoing COVID are already pre-existing. They have a bad hyperglycemia, and therefore outcomes can be quite bad. And And I think you have to look at the medication. Here, the most important thing I wanted to see at the bottom, the two boxes. And there you see that main important, most thing is in mild and patients who are ambulatory, you can almost use any drug. You see that you like cautiously, the way whatever your algorithm shows. But hospitalized, moderate disease and severe disease, you see at the bottom, the drugs that to be used extremely cautiously and not to be used as far as possible are TZDs, because they can cause edema, very severe water accumulation, and SGLT2 inhibitors, which can cause sodium depletion and can cause problems, and can cause also very mild non hyperglycemic ketosis or ketoacidosis, normoglycemic ketoacidosis. So that is possible in all emergencies. Sulfonylureas and T also, again, very cautiously, because often you are using insulin, and then to use a sulfonylurea, two hypoglycemic agents, you can get bad hypoglycemia. So I think this is otherwise, frankly, all the drugs can be used cautiously, but moderately severe and severe patients, you have to be very careful about some of these drugs that we talked about. See, in some pregnant people during COVID also, you have to treat pregnant women. And again, of course, the principles of treatment are same. I don't think I had delivered anybody during the COVID period. Maybe the delivery boom probably came after COVID. See, and hyperglycemia at admission is very important. Now, you see, any person getting in, now this is a newer aspect of hyperglycemia in COVID. Any person, for that matter, in any emergency patient gets admitted, which includes COVID, sometimes is not a known diabetic, but blood sugar should be done. It is considered routine now. If blood sugar is done and it is found to be high, you see, hyperglycemia at admission with known diabetic, unknown diabetic, both are very important. And you see, unknown one, you have to be very careful, because first time you are diagnosing hyperglycemia can be very bad. And younger ones can be in DKA. As a matter of fact, mode of presentation of type 1 often is DKA, you see, and there the mortality is very high, you see. So I think newly discovered diabetic also, and hyperglycemia of any region there, known or unknown diabetic, I think the prognosis is altered, prognosis changes. So some of the papers that we have are along these lines during the COVID period, showing the importance of hyperglycemia in general there. And these are some of these people have what we call stress hyperglycemia. Subsequently, they are all right, but they are hyperglycemic with COVID, which also is important. And to the extent that sometimes it will require treatment. A1C assay will give you some clue whether a person was diabetic previously or just has the hyperglycemic spike because of some problem, because of the bad infection and whatever other changes to take place with the infection, insulin resistance, etc. So A1C may give you a clue that is already a pre-existing diabetic for a while, but undiagnosed, which you know that for every diagnosed diabetic, one undiagnosed diabetic in most part of the world, and certainly in India. See, hyperglycemia during a hospital stay, of course, you can manage very well, and there are different steps. You see, with simpler management to the very complicated management. Government of India issued some nice guidelines for this, and I think they may be interesting to see. There is step-by escalation of what kind of treatment you give for hyperglycemia, from simple monitoring and simple insulin doses subcutaneously to starting, you see, multiple dose basal bolus therapy, and of course, insulin by infusion. In bad emergencies, very serious patients, by infusion is excellent way. Only two practical points there. Infusion, what you use, you see, first 5 ml, you should really flush out the whole system, then only starts working immediately. Other it takes about 1 or 2 hours to even start working. You see, that is very important. And of course, you have to have frequent testing and changing the rate. Very, very important. You see, so I think you escalate your treatment as it is required. And when sugar is high, obviously, you will institute insulin therapy. In this situation, I don't think you will take recourse to any other drug. Only if you see at the oral agent, the safest one in this situation is not even metformin, you're slightly worried, especially if they are dehydrated, slightly low blood pressure. There is anoxia, mild to moderate severe anoxia, then metformin is a dangerous drug as well. So frankly, it's amazing that the safest drug, it appears in this situation, and in many emergencies we do, is using a DPP4 inhibitor. So side effects wise, their profile is one of the most favorable profile of any oral drugs that we use in diabetology. So I think this is very important point to make. And of course, the sitagliptin has been used in many such situations without any problem, you see. So I think undiagnosed diabetes or stress, hyperglycemia, stress, hyperglycemia also, frankly, the glycated hemoglobin will be slightly high as well, you see. And low risk individual, high risk individuals will treat differently. See, monitoring is less frequently in low risk individual, very close monitoring in others. So I think the drug that you use, contraindication mainly is SGLT2 inhibitor and even metformin in many situations. These are the ACE drugs in diabetes in ambulatory patients. And these are exactly the drugs to be almost stopped in any seriously ill patients, which includes a patient with COVID infection. So most of the time, except very mild emergency, you can continue small dose of metformin or SGLT2 inhibitor, no, because this is overall contraindicated. So this is very important. The rest is, I think, simple. Except only you're worried about hypoglycemia, pyrethroid, about edema. So frankly, you narrow down very much to a DPP4 inhibitor. This is very important, no, and insulin. This might be the safest combination in these people. See, and of course, again, use of anti-diabetic agents. I don't want to go into details. I've given you basic principles of what we use and why we use. How you use insulin, I think, we can't take because we already lost 5-7 minutes in some technical problems. But you start with a low dose. Insulin, somebody who has never received insulin is very cautious with the first dose. Don't ever give a big slug because response is very brisk to insulin because there is no antibodies. After a couple of days, there are some mild antibodies, even with the best analogs that you use, and therefore they buffer and you don't get bad hypo. But initially, don't use a large bolus of dose because sugar is very high. So give a big slug and you get very bad hypoglycemia. So be very careful in insulin naive patients. See, and also what dosage you start and all, Steroids, when do you use this? This is not the platform to say that. But if they are used, your job becomes difficult and you will have to really institute in the basal bolus insulin therapy with probably a DPP4 inhibitor and or a insulin infusion. See, new onset diabetes, another focus. Somebody not known, as I told you, undiagnosed. So there you are not prepared. So the person is diagnosed very late that there is a problem of sugar as well. So it's very unfortunate situation to discover diabetes because you have to start the whole treatment then. And obviously they can be in ketoacidosis, even type 2 can be in ketoacidosis, as I told you right to begin with. You see, so new onset hyperglycemia, why does it occur during COVID? Of course, it can occur in any infection. There is always a family background of type 2 diabetes, though in many of these people, if you take the history carefully, and of course, there is a stress, and there are cytokines, and there is corticosteroid treatment going on. All that, they all lead towards bad hyperglycemia, as I told you, and that all COVID units where sometimes the diabetologist is not visiting personally should really be online connected diabetology morning and evening and take instructions. That's the only way to control. In fact, we made that in Just Look, and thereafter the diabetes was beautifully controlled in our COVID wards. Initially, they thought that it's difficult to do these calls and difficult to connect, but then we made it possible, and then things happen. You see, and of course, COVID aggravates hyperglycemia. Hyperglycemia aggravates COVID infection. So there is a very unholy relationship between these two, and this has been shown in a couple of papers. Is unholy relationship, and how you see in diabetes, you see our ACE inhibitor, ACE2 receptor is very, very important for us for the RAS system, and COVID virus is very intimately, is connected with this receptor and is the entry point. However, in spite of this biochemical knowledge, there has been no adverse effect shown of the DPP4 inhibitors used in the COVID infection. This is very important. That clinically there is absolutely no correlation. And as a matter of fact, it is also surmised in some papers that it will be beneficial to have this going. Or ACE inhibitors also can be continued. Patients who are well stabilized on them, you should not discontinue. So these two drugs are under, they were questioned at one point, but it's clear now that they can continue to be used. You see, I think newly diagnosed diabetes may have higher mortality because they're diagnosed late. They may come in a very perilous state and therefore very high mortality. So this is a very big subject, the newly discovered diabetes in these emergencies, and they have to be handled extremely carefully. And diagnosis has to be made. As a matter of fact, as we said, once some of our colleagues have shown that doing a blood glucose is the fifth vital sign, we say, besides pulse, blood pressure, etc. So this is very important. If you do that, you won't miss diabetes. In children, you can miss easily. Unconscious children, very, very regrettably, there's some places when we were called to see later on, diabetes was diagnosed after CSF, sugar was very high, which is very deplorable, which doesn't happen now. You see, but this has happened earlier. We have seen being diagnosed with a very wrong way of diagnosis. You see, so I think overall, I think management I'll skip some of this, was all routine. So thank you very much. I'm sorry to overspend about 5-10 minutes because of some problems. Thank you very much for your patience.
Thank you, sir, and really enlightening us. And that was, I was talking to you that it was really nice that you have combined it in a hybrid way and suggested a really novel approach during this COVID care to take care of hyperglycemia, combining both face-to-face as well as telemedicine, and how we can go hands in hand. One question just on how to come off it, would like to ask it. Particular tendency of giving steroid, because many institute the steroid initiation and the protocol is really some different, that they are giving Dexona 8 hourly, and that has given really vast glycemic variability. So how you come across it and how you tackle this? Just if you can enlighten it.
I think good guidelines given that dexamethasone dose has to be about 6 milligram, 6 to 8 milligram a day, and not very heavy dose, and only in people where there is an oxygen drop, and the CT COVID score of pneumonia is at least more than half, more than midway out of 25 is 12, 14, 15 and above, and there is mild anoxia. These are the ones they should receive steroids. And early in the phase of COVID, steroids are risky, it's dangerous. It's little later in the phase, immune mechanisms kick in. That is the time. So very beginning, somebody gives steroid is very, very dangerous in these infections. It is really later on when the immune mechanisms come, and then you require steroids. See, I think we should take some questions to our other speakers in the 5 minutes. I feel very guilty that, we lost time, you see. So if there are any questions to our previous speakers, please take that first. Because
Yes, we are looking in chat box. There is no question right
please
in
do
chat
that,
box.
because
we are not having any further questions in the chat box. Let us have any question if there is any on social media.
Okay, there's no questions. I think then maybe it's a happy ending.
Just yes, that's fine. One more question that was coming out of my mind regarding this glycemia care during pandemic only, that evaluating the role of GLP-1 agonist during this COVID care, and whether it's feasible and how it can be useful or not.
I think if the patient is already on it, then you may continue in mild COVID. But you see, these drugs cause poor food intake. You see, after some adjustment in initial period, many people are able to tolerate them well. But initiating it during COVID infection is out of question, to my mind. So they work by making the person sick initially. So I'm sorry to say in such strong words, but it's just to drive the point home. I'm saying such words, not really to downgrade the drug and its importance, But somebody the initial 2 weeks or 4 weeks, you use a lower dose, you see, and of course the real effect also kicks in much later. So I don't think these are the drugs to initiate, But somebody's on it, I think mild COVID, I'll continue. The other, I won't continue. In a way, they're catabolic drugs, they're catabolic drugs. You see, they decrease the food intake and catabolism ensues, starvation. Person is already eating poorly. Sometimes diarrhea is there, vomiting there. The GI upset can be very bad. The taste is gone, which disturbs them tremendously. You see, it's amazing, but they can't taste, they can't eat properly. You see, this is very important. So I think in that situation to give these drugs, I am very doubtful, really. It is just adventurism. One can show in the study that we gave that things were all right, but this is adventure study, It's not for cowards like me to do that, to studies.
Thank you, sir. It was a really fantastic talk and enlightening the path for glycemic control during this roller coaster ride of COVID era. Thank you, sir, for being with us. Also would like to thank our other speakers for being with us and sharing their knowledge with us. And also would like to thank our chairperson. And it's a time to move forward for the next session on preventive symposia. To chair the next session, would like to invite our chairpersons, Dr. Mithili and Dr. Girish Khurana. Would like to welcome you, Dr. Mithili and Dr. Girish Khurana. And I'm handing over the session to you. Thank you.
Yeah. Good evening. I'm Dr. Maithili from Visakhapatnam. Am I audible?
Yeah, you are audible, madam.
Yeah.
Yes, ma'am. Yes, ma'am.
Yeah. Thank you for the kind invitation. So we move on to a very important session on the prevention symposium. And we hope to have a very good learning experience in this session. We have 3 topics in this session, and our first topic is prediction and prevention of type 1 diabetes. And the speaker is Dr. Bharat Panigrahi from Bhubaneswar. May we have his CV slide?
I think, madam, first speaker is from Bhubaneswar, Dr. Bharat Pani.
Yeah, Dr. Bharat Panigrahi from Bhubaneswar is going to speak on prediction and prevention of type 1 diabetes. So if we have his CV slide, yes, we can present. Otherwise, we will request Dr. Bharat to carry on his first presentation.
Yes, ma'am. Bharat sir can share the slides.
Okay, thank you. Am I audible?
Yes, yes.
Okay.
Yes, sir.
Sorry. Okay. So my slides are visible?
Yes, they're visible.
Okay. So thank you, Dr. Bansi, Dr. Basant Kumar, and Dr. Agrawal for giving me this opportunity to participate in this great conference. So friends, for the next few minutes, we'll be discussing about the prediction and prevention of type 1 diabetes. So all of us know that type 1 diabetes is again a devastating problem. Starts from the very childhood. Of course, many cases can be started in the adulthood also. But coming to the prevalence, it is almost 1 lakh children in India are living with type 1 diabetes. And India is listed among the top 10 countries for number of people under 20 years old with type 1 diabetes according to IDF. And along with 10 other countries that constitutes of the South Asia region, among which India is the and the biggest country that has prevalent this southeastern region that has prevalence of type 1 diabetes almost 1,11,500 in children. So again, coming to type 1 diabetes, all of us know this is an autoimmune destruction of the insulin producing beta cells in the islets of Langerhans. So this process starts from the very childhood, this autoimmunity. And this process occurs in genetically susceptible subjects. Is probably triggered by one or more environmental agents and usually progresses over many months or years, during which the subject is asymptomatic and glycemic. So this occurs only genetically susceptible persons, but there are environmental factors. We do not know what is the real environmental factor, what is the real causes, but there are many predictions. And like any other autoimmune disease, the viruses are they are given the first that yes, there are many viruses which can trigger this process, because all of us know that is a terminology called the molecular mimicry, because once a virus infection occurs, that some antigenic part of that virus again that simulates the beta cells, and later on this autoimmune process occurs. That is what they called theory of molecular mimicry. So coming to now, risk of type 1 diabetes progression is conferred by specific HLA genes. So because there are certain genetic susceptibilities, and people in the relatives of diabetes patient, type 1 diabetes patient who carry this HLA gene, they have the mostly chances of having this type 1 diabetes. And this is the HLA gene, as all of us know, the human leukocytic antigen genes. There is the HLA DR-DQ alleles, and that is the mostly the DRB1, 03 DQB1, and 0201, that is DR3, or DRB1, 04 DQB1, 0302. So this allele, this is present most in the 90% of cases of type 1 diabetes. This allele of HLA gene is present. That's why this is having a genetic susceptibility, and this is a protective allele. What allele means, this is a variant of gene. I'll coming to the what is that HLA gene. So this DQB1 0602, this is a protective allele of this HLA. Now this is the HLA gene. Just to recapitulate, this is the chromosome 6. This is the short arm of chromosome 6. What happens? Here each is the HLA gene. The HLA gene, MHC, these are the two terminologies, that the major histocompatibility complex and HLA gene. This is almost similar, same in case of humans. But this is something different in case of mammals. But in human beings, this is almost same. So when we come to this HLA gene, and this complex, you see, this is the biggest gene of the human beings. It contains almost 200 genes. And you see, they are the class 1, class 2, class 3 complexes. So the class 1, as you know, the HLA, HLA, HLA-B, HLA-C, and the class 2 that contains the HLA-DP, DQ-DR. But HLA-DP and DQ-DR. But class 3, it is less important. We are not going to discuss the things, but we are concerned with this HLA, mostly HLA2. Now I will come, class 2 genes, this is the HLA, DP, DQ, DR. And you see what happens. This is the gene, even if it contains 200 genes, this complex, the number of alleles, almost every gene has got almost alleles, starting from, you see, there are 4,000 alleles. There 4 alleles means there are 4,000 variants. That gene has got almost 4,000 variants. So also HLB has got around 5,000 variants. So here you see DPDQ, DQR, there is a number of variants. So these are called the alleles. And when these alleles, certain alleles are present in a person, they are more susceptible for suffering from this type 1 diabetes. Coming to the immunogenicity, just to refresh your knowledge regarding this, you see what happens whenever these are the antigen presenting cells that are present. So this is the innate immunity, the TL cells, they take part in the innate immunity. So CD4 T cells, CD8 T cells, they are the active partners. So whenever the antigen, that means what are the antigen? Here we call the beta cell antigen. So this antigen presenting cell, they carry this MHC class 2 molecule. You see, what I have seen MHC class 1, class 2, 3. So the class 2 genes are being carried out by the antigen presenting cells. But in the all other cells, every nucleated cells, they carry the MSC1 gene. So here, once the autoimmunity starts, so the antigen presenting cells, they carry the antigen with them. That means there is the expression of the MSC class 2 receptors on the surface, and they carry the antigen in this groove, and they are present to the T cells. The T cells, they have got the T cell receptors. And you see, I just want to point out this is CD3. So you just remember the CD3, because I'll be coming in the later slide about the importance of the CD3. So this CD3, this is a co-receptor. So during the activation, there is a antigen presentation. That means what happens? Then these are the naive cells, naive T cells, but once that antigen is presented, then the T cells become activated. Whether it's CD4 or CD8, they get activated. But that the signaling process, once this reaction occurs, the CD3 complex, this is a complex that carries the signal into the cell, and that is called the transduction of the signaling, and that carries to the nucleus. So that is why the CD3 is very important, that acts as a co-receptor. This is one more thing. You see, this is a post-stimulated protein CD28 carried by CD4, and this is the CD88, CD86, that is our B7. What you see, this is carried by the antigen presenting cell. So only this will not do. So with this, the co-stimulatory molecules must also be activated. That unless the second signal goes, the CD4 cells will not be very active. So all these things will activate the CD4, CD8 cells, and that the inflammatory process occurs, and there is the beta cell destruction. Now, coming to the natural history of type 1 diabetes, you see what happens. During the process, once the autoimmune process occurs, you see, this is the variable genetics, environment, and sorry, keep somewhere, it's not. Can I keep it away? Yeah, can you help me? Hello. RxEvents people, can you tell how to keep it away? Am I audible?
Yeah, you are audible. Please proceed.
Because this blocks.
No, you are audible. Please proceed. Dr. Bharat, you are audible.
I think he is not able to shift his slides. Hello, Dr. Bharat, you are not audible.
I am audible now?
Yeah.
Yeah, you are audible.
So this process, what happens? So there, of course, the autoimmunity, and these are the various stages that the person has to pass. Because the stage 1, what happens? The autoimmunity is there, but it is a normoglycemia and it is a pre-symptomatic. Then comes the stage 2, the beta cell autoimmunity is there, but there is a dysglycemia, but still is a pre-symptomatic. But again, in stage 3, there is the beta cell autoimmunity, there is a dysglycemia, and their patient becomes symptomatic. So by this time, almost 90% of the beta cells are being damaged. So friends, so now you see this process takes a long time. So this is the window period where we can intervene. If you can predict, if you can prevent, And this during this period, then that will at least we can do something for this devastating process so that we can prevent this type 1 diabetes. That is the whole thing what I want to discuss today. So how to predict? What are the biomarkers? All of us know we predict a disease only with the biomarkers. So what are the biomarkers being used to predict type 1 diabetes? These are the things. You see, the risk of developing type 1 diabetes is about 0.4% among the general population. Whereas in relatives of type 1 diabetes, it is almost 50 to 20 times. So the susceptibility is as below. I see no family history, it's only 0.4%. But if the offspring on affected mother is there, that it increases up to 1 to 4%. If the offspring of an affected father is there also, so there is 3 to 8%. But if both parents are affected, then reported as high as 30%. This is susceptibility. And non-twin sibling of affected patient, 3 to 6% by age 20 years. If there is a dizygotic twin, it is 8%. If it's a monozygotic twin, then 30% within 10 years and almost 60% by 60 years. So this slide shows the relatives of type 1 diabetes. This risk is much higher than the general population. And the importance of, again, these markers in Am I audible? Hello?
You are audible? Yes, yes.
Okay. So you see, no relative with this. If the genetic marker is DQB0302 by 0201, then if in the case of there is no relative with type 1 diabetes, that means this susceptibility is 1 in 25. But if the first degree relative with type 1 diabetes there, with this genetic marker, the susceptibility is 1 in 4. So this is the highest susceptibility gene. Then comes DQB0302, 0302. If the no relative is 1 in 60, but in the first degree relative it is 1 in 10. So these are in this genetic marker, it's not known. But here again, in DQB0302 and other gene, here 1 in 60, this is 1 in 10. So what the point of showing this slide is, these are the genes. If these are the genes are present in the first relatives of type 1 diabetes, the susceptibility of having type 1 diabetes is much more higher. That's why we can predict, yes, this child can have diabetes in the near future. So for 90% of patients with type 1 diabetes carry this DR4 DQB0302 and or DR3 DQB0201. So this data suggests that HLA genotyping at birth may identify individuals at very high risk of developing type 1 diabetes before the occurrence of clear signs of islet autoimmunity and type 1 diabetes onset. So we have to see, we can genotype at birth the children who are the first relatives of a type 1 diabetes patient. So immunology markers, yes, there are several clinical useful serum autoantibodies that can detect the preclinical phase of type 1 diabetes. These are the autoimmune markers. These are the antibodies. This is the insulin autoantibodies. This is the GAD antibodies. This is the IA2 antibodies, insulin antigen antibodies. These are the GIC transporter antibodies, and these are the islet cell antibodies. So these are the antibodies which are markers, and we see if you find more than one marker, if you find more than 2 markers, so the more markers, more antibodies means there is more susceptibility. So in a prospective cohort study of 1,353 offspring of parents with type 1 diabetes, autoantibodies began to appear by 9 months and frequently persisted. And its urgency in this islet, this is the insulin autoantibodies were almost always the first to appear. And with other antibodies, the IC antibody, GAD antibody, and IA2 antibody, they appear later. So the risk of diabetes was highest in those with multiple autoantibodies, that is 40% within 5 years versus 3% in those with single autoantibody. That means if the number of autoantibodies is more, there is much more chances of appearing the diabetes earlier. So progression to multiple islet antibodies was fastest in children who developed their first antibody by age 2 years. So friends, children with the earliest evidence of autoimmunity are at greatest risk for and progress more quickly to the development type 1 diabetes. So periodic testing for islet autoantibodies appears to help assess the risk type of diabetes in children or parents with type 1 diabetes. So in the children who are related in the first relatives of a type 1 diabetes, in those we can assess their genetic structure from the very beginning at birth, their at least the HLA typing, and also in the periodically we can see about their autoantibody status, so that we can predict when and at least in the near future this child will develop type 1 diabetes. Now, this is the latest recommendation by ADA. You see, in just this June 2021, taking this ADA 2021, they revised their recommendation, and they have come to this recommendation that screening for type 1 diabetes risk with GAD antibody is currently recommended in the setting of a research trial, or can be considered an option in first degree family members of a proband with type 1 diabetes. That is the type B, that is the grade B evidence. So friends, now taking the evidences till date, gradually the international bodies are coming to recommend for screening the type 1 diabetes at the earliest, so that we can predict the type 1 diabetes in the near future. There are metabolic markers. Yes, glucose tolerance test is the definitely that is commonly being used. But beyond this glucose tolerance test, what we do, the most useful and widely performed test is now the acute first phase insulin response to glucose during an intravenous glucose tolerance test, that is the FPIR. So the rise in serum insulin above baseline is measured during the first 10 minutes after the intravenous glucose challenge, and the response correlates with the functioning of the beta cell mass. So the fasting relatives of patients with type 1 diabetes and FPIR below the first percentile of normal is a strong predictor of type 1 diabetes. So these are the predictors. One is the HL alleles, one is the autoantibodies, one is the glucose tolerance test or the FPIR. So these are the predictors of type 1 diabetes. If you can do this and follow up these children who are the first relatives of the type 1 diabetes, we can predict at least, yes, in the near future, these children will have, will suffer from, that is the type 1 diabetes. Now coming to the prevention part, you see, yes, still we are wondering whether there can be any prevention, but definitely there is no definite recommendation or guideline from the prevention, but still we are in the era where we can do something, at least we can hope. So let us see what we can hope in view of the long natural history and complex pathogenesis of type 1 diabetes. Many strategies may be proposed for primary and secondary prevention. As I have already shown, there is a long window period from the childhood to the development of type 1 diabetes. So during this long period, stage 1, stage 2, and before the autoimmunity, if at any stage, if we can intervene, if there is some method, that we can intervene, then at least we can prevent. Now, strategy of primary prevention is to prevent the onset of, so primary prevention means to prevent the autoimmunity itself before the autoimmunity starts. If you can do, then you can definitely save the beta cells. But there is also can be secondary prevention, means after the process of autoimmunity, if then also if you can intervene, at least we can salvage some beta cells, so that we can at least delay the process or if you at all the patient develop type diabetes, you can have a less of insulin need. Now, primary prevention, there are many studies also, but till date, there is definitely no definite positive outcome. People thought of cow's milk, some cow's milk protein peptides, they are responsible for the triggering the process, but that didn't find any positive result. Oral insulin was also used in the 3-point study. Here, the whole aim is to stimulate the immune tolerance because this antigen is being given in the oral route and in the oral mucosa. So gradually in the long run, the patient will develop immune tolerance so that the autoimmunity can be prevented. So in this pilot study of children at high risk for type 1 diabetes, daily oral administration of 67.5 milligram of insulin compared to placebo resulted in an immune response without hypoglycemia. But friend, this was a very small study. So the phase 3 study is being still awaited and it is ongoing. We don't know what will be the outcome. So this is one latest, that is a secondary prevention. This is the review in endocrine and metabolic disorders, March 2021. You see, they have seen diabetes type 1. Can it be treated as an autoimmune disorder? Yes. What are the key points they have found? Type 1 diabetes is characterized by progressive autoimmune mediated destruction of beta cells. And immunotherapy may preserve beta cells and decrease insulin dependence. However, in their current state, immunotherapeutic approach cannot yet replace standard insulin therapy in existing type 1 diabetes. But currently, there is only one molecule that is called teplizumab has been demonstrated to delay the onset of type 1 diabetes at stage 2. A broader application of this approach represents it too. So we will be discussing about this molecule in next 3-4 slides. So you see, what is that teplizumab? Teplizumab is a Fc receptor non-binding anti-CD3 monoclonal antibody. What I showed you about the CD3, what is the function of CD3 in this immune reaction. So this is the Fc receptor non-binding anti-CD3 monoclonal antibody that modifies the CD8 T lymphocytes, which are thought to be the important effector cells that kills the beta cells. So this is teplizumab, and this anti-CD3 antibody in relatives at risk for type 1 diabetes were tried in the phase 2 trial published in NEJM. And this phase 2 trial, here a single course of teplizumab was given for 14 days in different doses. For 14 days, in up-titrating doses, for 14 days, this teplizumab was given in high-risk non-diabetic relatives of patients with type 1 diabetes who had at least 2 autoantibodies and abnormal results of an oral glucose tolerance. That means the patients were in the stage 2 in the natural history of type 1 diabetes. These patients were in the stage 2. So there, what this phase 2 trial outcome was, the median delay in the diagnosis of diabetes was 2 years. That means at the conclusion of the trial, the percentage of diabetes-free persons in the teplizumab group, that is 57%, was double that that means at the age of 2 years, 57% of the teplizumab group were diabetes-free in comparison to placebo group were 28%. And the safety, yes, safety one is revealed. There is almost the adverse events were almost same in both the groups. So this raised at least some hope. Can teplizumab be a right drug? So friends, this is the teplizumab prevention study. In this teplizumab prevention study, now teplizumab improves and stabilizes beta cell function in antibody positive high risk individuals. This is published in Science Translational Medicine in March 2021. What happens? In this study, this is an extended follow of the previous study. That this study almost followed up for 3 years. That means the total duration was almost 5 years. What they found, that median time to diagnosis of type 1 diabetes was almost 5 years, and that means 59% cases. 59 months, that is the 5 years, and 27 months for teplizumab and placebo-treated participants respectively. That means here the median time to diagnose diabetes in the teplizumab group was almost continued for 5 years. For 5 years, almost 50% of the patients were not found to be diabetes. So 50% of teplizumab treated patients remain diabetes free at the end of 5 years. In comparison to only 22% of the placebo treated patients, they remain diabetes free. So this gave a lot of hope that yes, this molecule can be of help in this group of patients. So a single course of, but again, a single course of teplizumab was only used. So can you use, again, increase the dose of the teplizumab, the course of the teplizumab, again another course can be given? So these are the many questions.
Dr. Bharat, can you please finish your presentation?
Sure. So FDA issues CRL for teplizumab investigational candidate to delay the onset of type 1 diabetes. So they when they presented to the FDA, so the FDA presented the complete response letter. That means they told neither yes nor no. Then that means they need some more evidence. That the PK study. So this is the PROTECT study, ongoing study. This is the phase 3 randomized control trial. We hope by May 2023 result. So this will give the real study what will happen. Maybe in 2023 we'll have get the result. So friends, the various immunomodulators they tried but without indefinite outcome. These are the two again ongoing studies on hydroxychloroquine and abatacept. So to summarize, various data suggest that HLA genotyping at birth may identify individuals at very high risk of developing type 1 diabetes before the occurrence of clear signs of islet autoimmunity and type 1 diabetes onset. Periodic testing for islet autoantibodies appear to help assess the risk of diabetes in children or parents with type 1 diabetes. So screening for type 1 diabetes risk with a guard antibody is currently recommended in the setting of a research trial or can be considered an option in first degree family members of proband with type 1 diabetes. In first degree relatives of patients with type 1 diabetes, the FPIR below the first percentile of normal is a strong predictor of type 1 diabetes, and currently only teplizumab has been demonstrated to delay the onset of type 1 diabetes at stage 2. So although a cure for type 1 diabetes is being actively sought for preventing or delaying it in those known to be at risk or in those already diagnosed, slowing down the autoimmune destruction of beta cells and protecting those cells that are still active are likely to be more achievable goals in the foreseeable future. Thank you. So when the world says give up, hope whispers, try it more time. Thank you.
Thank you, Dr. Bharat, for an overview of prevention of type 1 diabetes. The prevention of type 1 diabetes is a dream for all of us. And as you mentioned, in all the clinical trials, it is very challenging. But however, the message, the take-home message from your presentation is that you can screen high-risk individuals like siblings and then get their antibody assessment and pick them up early diagnosis, and thereby you can preserve beta cells to a certain extent. Thank you once again. I think I request Dr. Girish to take over for the second session.
Thank you, madam. And now, after an excellent talk by Dr. Panigiri about type 1 diabetes prevention and prediction, now let us move to the second part, which is primary prevention of type 2 diabetes. And I would like to invite Dr. Rao, Dr. DC Rao from to come and give his presentation. Dr. Rao is from Hyderabad. He is senior consultant physician and diabetologist and professor of medicine at PIMS, Karimnagar, Telangana. And his expertise in metabolic disorders, obesity, and endocrine disorder. And he's a principal investigator in various clinical trials, and he has many articles in print and electronic media. Now, may I request Dr. Rao to please give your presentation.
Next.
Dr. Rao, you are not audible.
Yeah, am I audible to you?
Yeah, now you are audible.
My slides are visible?
Yes, they are visible. You can start.
Let us start from the beginning. Very good evening to all of you. Good evening to chairpersons. Thank you very much for kind words of introduction. So at the outset, I would like to express my gratitude and thanks to the scientific committee. Today's my topic is primary prevention of type 2 diabetes mellitus. Now onwards, I'll just mention it as a diabetes. So, am I audible, sir? Shall I proceed?
Yeah, you can proceed. You are audible, very much audible.
Today's my overview is that one, introduction, goals of primary prevention of diabetes, identification of high-risk groups, levels of intervention, approaches, role of governmental and non-governmental agencies. So, as you all know, diabetes is a global pandemic. According to IDF estimates, there are about 463 million diabetics in the whole world, and India is about 80 millions. And unfortunately, in India, diabetes occur a decade earlier. That means more exposure to hyperglycemia and chances of more long-term complications. And also unfortunate that the optimal blood sugar control is very poor in India. The average national HbA1c is about 9 grams. That's why the chances of dreaded complications are more. India is spending about 154 billion Indian rupees in taking care of this diabetes and its complications, mostly complications. So that's why it's a high time that our healthcare professionals and government should take active role in making India as a diabetes-free complications India. And the next step will be diabetes-free India. It may look impracticable, but the following studies have shown that it is possible. The following studies like Diabetes Prevention Program, DPP, Indian Diabetes Prevention Program, Talking Diabetes Prevention Study, Finnish Diabetes Prevention Study, and Jen Sharon Study of Prevention of Lifestyle Diseases. Of all these, the Diabetes Prevention Program is very landmark study in which the study, the subjects were almost 3,000 subjects were there, and according to their study, with active lifestyle interventions, healthy nutrition, physical exercise, diabetes reduction can be done by about 58%. Then they went on to add metformin. With metformin, they were able to reduce 31%. So it is possible to prevent the diabetes primary aspect. So what are the goals of primary prevention of diabetes? Our goals are to prevent or delay the onset of diabetes. By that, we'll be able to preserve the beta cell function and preventing the delaying the micro and macrovascular complications and reduction of the cause and diabetic care on society. Now, to prevent the diabetes, first attempt is to identify the high-risk groups where we have to intervene actively. These are following are the high-risk groups like pre-diabetes, obesity, gestational diabetes, family members of diabetic patients, sedentary lifestyle, hypertension, dyslipidemias, history of cardiovascular disease, PCOD, and childhood obesity, children born to GDM patients. Of all these, pre-diabetes, obesity, gestational diabetes, family members of diabetes are high-risk groups where we can intervene actively by lifestyle interventions and will be able to prevent the diabetes. What are the levels of interventions? Actually, it should start from the fetus. We should do healthy environment, healthy fetal environment to the fetus, because the overnutrition or undernutrition can result in various problems. For example, overnutrition of the mother will result in overweight of the patient, mother, and gestational diabetes mellitus, leading to large weight babies, and they like to have diabetes in the future. And undernutrition also can lead to low birth weights, insulin resistance, and insulin impaired insulin secretions. They're coming to primordial prevention, the prevention of risk factors only, identifying the risk factors, and we have to prevent those risk factors like obesity, physical inactivity. Whereas it comes to primary prevention, we have to focus on high-risk people, as already enumerated: pre-diabetes, obesity, and gestational diabetes patients, and family members of diabetic patients. We have to focus on these high-risk groups. So these are the various levels of intervention. Unfortunately, in India, clinical inertia is always there. So what are the various methods? So in order to identify the high-risk groups, we have got various screening methods. One is very important, is universal, opportunistic. Then following up of the GDM patients, follow up to the children born to GDM patients, antenatal checkup, dental checkup, and overweight children and adolescents, and family members of all diabetes should be screened. Of this universal screening, usually it should be done by governmental agencies, because individually it's not that possible. Government should take active part, and aggressive screening at community level should be done. It can be done from door-to-door survey. Telangana government is already doing this door-to-door survey to identify the high-risk patients and to prevent non-communicable diseases. So opportunistic, this universal screening also can be done at various highly gatherings, get-togethers, like bus stations, railway stations, and temples, malls, and big corporate hospitals, and vegetable markets. In fact, your APA Karimnagar take active part in conducting the screening camps on days like World Diabetes Day, World Hypertension Day, all these days. So opportunistic screening means by individual doctors at their clinics. All the specialist doctors, all the group of doctors should do random blood sugar tests for their patients who come to them for another illness, irrelevant things also, because it should be as a one of the vital signs. Because now what are the vital signs? Temperature, pulse rate, BP. Fourth one is oxygen saturation. Now fifth one is random blood sugar. So all the patients who are coming to our clinics can be screened with random blood sugars. Now follow-up of GDM patients. This is also very important, because GDM patients, gestational diabetes patients, they are high likely to have full-blown diabetes in their future life. That's why these GDM patients should be followed, and annual checkup should be done to see whether they are developing into overt diabetes. And active intervention by way of lifestyle, healthy nutrition, and physical exercise. Those who are obese patients. And the children who are born to GDM patients also should be screened, because they are usually prone for type 2 diabetes. Here in our town, we have got very good coordination between the gynecologists and our physicians. The gynecologist will inform us all the GDM patients to us, and we will make them into groups, WhatsApp groups, and we will follow them regularly and screen them every year, so to find out whether they are going into overt diabetes. Like antenatal checkup, dental checkups, overweight children and adolescents, and family members of all diabetic patients are also very important, because diabetes runs in families. That's why whenever a diabetic patient comes to your clinic, we have to follow the family members. We should request all the family members above 25 years. We should ask them to come and get this random blood sugar should be done. So as a gesture of this thing, we offer at our clinics that free random blood sugar will be done for all the family members of diabetic patients. This is the various methodology of screening. Now, what are the approaches? Now, we have identified the high-risk groups by various methodology of screenings. Now, how do you go ahead with the approach? First and foremost thing is that education, health education plays very important role. All our population should be aware of this, the gravity of the diabetes and the long-term complications. Those should be made aware. So the comprehensive lifestyle management means healthy nutrition, physical activity, behavior modification, stress management, cessation of smoking and moderation of alcohol, sleep hygiene, high quality sleep for 6 to 8 hours, and bariatric surgery in overweight patients. Now let us look at few high-risk groups like prediabetes and obesity and GDM. As you know, prediabetes is a forerunner of the diabetes. All diabetic patients are preceded at the pre-diabetic stage. They are diagnosed when the patient's blood sugar, fasting blood sugar is between 100 to 125, and post-lunch blood sugar is between 140 to 199, and HbA1c is 5.7 to 6.4. So these pre-diabetic patients, according to IDF estimates, there are about 373 million pre-diabetics. In India, there are about 60 to 70 million pre-diabetics are there. Their etiopathogens also is beta cell function deterioration, and they are prone for all sorts of long-term complications. And if necessary, that's why they should be aggressively monitored, aggressively treated with lifestyle intervention, and if necessary, pharmaceutical interventions. That's why there are so many arguments that pre-diabetes also should be treated as diabetes and aggressively managed in order to prevent long-term complications. So what are the lifestyle modifications? Attempts to lose 5 to 10% of the body weight and participate in physical activity 150 minutes per week, at least. In overweight patients, 1 hour daily it should be there, and 6 to 8 hours sleep daily. And the healthy lifestyle measures, including diet and physical activity, are equally important of non-obese patients with pre-diabetes also. So next is medical nutrition therapy. Carbohydrates content should be limited to 50%, less than 50% of the total calories. Complex carbohydrates should be preferred over refined products. Low glycemic index and low glycemic load foods should be preferred. When it's come to protein intake should be maintained at about 15 to 20% of the total calorie intake. Of course, in renal diseases, dysfunctions, they should be less. And non-vegetarian foods are very good source of high-quality proteins, but high-quality proteins are also available from the plant source. You can prefer plant source also. And at the same time, the intake of red meat should be avoided. When it comes to fats, fat intake should be limited to less than 30% of the total calorie. Oils with high monounsaturated fatty acids and polyunsaturated fatty acids should be used. Use of 2 or more vegetables oils are recommended in rotation. Saturated fatty acids intake should be less than 10% of the total. These are the food groups and patterns. Diet rich in fruits, leafy vegetables, nuts, fibers, whole grain, and unsaturated fats preferred. Food plates should include pulses, legumes, unprocessed vegetables, and low-fat dairy. Extreme dairy diets include low-carbohydrate, ketogenic diet, gluten-free, can be tried in obese patients. And alcohol should be moderated, smoking should be stopped. Artificial sweeteners in moderate amounts only, not more than 2 to 3 grams per day, advised. So this chart again shows the same thing. Physical activity list, this is very important. Minimum of 150 minutes moderate to severe intensity aerobic exercise. It includes resistance exercise also. And minimize uninterrupted sedentary life. This is also very important. Most of our diabetic patients, they spend a lot of time watching TVs, sitting in a particular place. So for more than hours together, this should be discouraged, because studies have shown that even normal people also, this sit at a place for more than 1 hour, they are prone for development of diabetes. So sitting at a place more than 1 hour is itself is a risk factor for developing diabetes. And now latest concept is that instead of doing continuous 40 minutes walk, our patients, we can advise them to take low intensity, short 10 minutes walk after every meal. This is shown to decrease the postprandial hyperglycemia also. So this particular chart has clearly shown that those who do regular physical exercise have got lower incidence of diabetes, whereas the patients who have sedentary people with TV viewing, they have got increased incidence of diabetes. So even pre-exercise assessment also can be done, because many patients may have neuropathy, retinopathy, coronary artery disease, and peripheral artery diseases. So these are all types of exercise they have described. Of course, everyone knows about it. So already I mentioned about diabetes prevention program. This they have used about 3,000 subjects, used healthy exercise, healthy food and exercise things, and they were able to reduce incidence of diabetes by 58% by lifestyle, only 31% by metformin. So that's why it shows the importance of lifestyle modifications, interventions. Even the ADA 2021 also has recommendations on primary prevention. At least annual monitoring of type 2 diabetes for development of type 2 diabetes of all pre-diabetics suggested. At least once in a year, all the pre-diabetics should be monitored. So these pre-diabetic patients should be referred to an intensive lifestyle behavior change program modeled on the diabetes prevention program. And variety of eating patterns also advised by the, as already enumerated. So the DPP disease trial, intensive lifestyle intervention could reduce the risk of incidence of type 2 diabetes by 58% over 3 years. Again, according to this ADA recommendations, even pharmacological interventions also advised, particularly in the patients whose BMI is more than 35 kg/m and aged less than 60 years, and the women with prior GDM. Metformin is a strongest evidence-based and demonstrated long-term safety as a pharmacological therapy for diabetes prevention. Now, another risk factor is obesity. Obesity is on the rise even in the developed countries like India. The main causes, of course, high consumption of calories, red and processed meat, refined grains, white rice, sugar, sweetened beverages, lower consumption of fruits, vegetables, whole grains and nuts, and eating more of unhealthy foods, and lower physical activity and high physical inactivity. This also, as enumerated, high physical inactivity is very important cause for the development of obesity. How are you going to manage? Of course, weight reduction is at most important. For the weight reduction, high protein diet, high fat, and low carbohydrate is ideal. And total calorie restriction up to 850 kilocalories per day for 3 to 5 months. That's keto diet or whatever it is there. So active physical exercise is very, very important. At least 1 hour per day, 5 days in a week is advised to reduce the weight. Drugs like Orlistat, SGLT2 inhibitors, GLP-1 receptor agonists like liraglutide and semaglutide, they play. And of course, finally, bariatric surgery. So now, another important thing is that GDM, gestational diabetes mellitus, as you know, the incidence of GDM is increasing. Right now, it's about 7 to 10% of all pregnancies are likely to have GDM. So, and these most of these diabetic patients can become normal after the delivery, but
Dr. Rao, can I interrupt you? You can skip this part. This part, Dr. Rajput will take over.
Yeah, I know. Yeah.
And we are already running short of time.
Yeah. So they should be monitored annually and they should be taken care of. Now, most important role of governmental agencies and non-governmental NGOs. as recently we have seen, NGOs have taken a very important role in doing 1 million tests in a single day by RSSDI, and Rotary Club has taken active part like that. And when it comes to governmental agencies, this is very important because mass community level screening should be done by the governmental agencies, and mass media campaign also education, community level education should be done, these things. So national prevention, it is a high time that national prevention of program for diabetes should be established by the government. And here the healthcare providers and as well as association like API and RSSDI, they should take active part in convincing educating the leaders, political leaders, and sensitizing them about the importance of the primary prevention of diabetes. For that, we have to see the modification to the built environment for physical activity to improve pedestrian and bicycle transport system. Establishment of infrastructure like parks, recreation facilities, walking tracks, bike paths, and pavements. When we see in USA or European countries, there is a walk culture and bicycle culture is very much prevalent because they are provide a separate bike paths on the roads so that all the population they use cycles before reaching the metro and one day holiday for the all four wheels there in India. So that on that particular day our population should use bicycles and walk. Subsidized public transport system should be there. And our schools should have playground, and government should not give any permission to the schools, those who don't have playgrounds. And this health education of diabetes should be incorporated in the school curriculum, both primary, middle, and high school students. And at residential level also, all gated communities should have facilities to encourage physical activity. Open air gyms.
Can you sum up it fast?
Yeah, I'm coming. Open air gyms, which are accessible to the poor people, and population level approach to prevent the food modifications. That's important. And taxation on unhealthy foods like red meat and junk foods, and subsidies on healthy foods like fruits and vegetables. And finally, role of digital technology also we should take into consideration, like telemedicine, social media like WhatsApp, Facebook, Instagram, smartphone apps, sending SMS and WhatsApp messages to the various people in the health education should be done. Now, coming to summary, diabetes, type 2 diabetes mellitus is a global pandemic, and mortality is more. Indian populations are more prone for high incidence of long-term complication. Our government is spending, and we are spending most of the times, huge money. It is a huge burden, economic burden. That's why the time has come for all of us, including government, to take active part to make India a diabetic complication-free India. And finally, of course, diabetes-free India, if we take active part, it's possible. Thank you very much for patiently listening. Thank you very much.
Thank you, Dr. Rao, for an excellent presentation. So we'll get for a few more inputs from our listeners once the symposium is over. So I would like to invite our next speaker, Dr. Rajesh Rajput, a senior professor at Medical College, Rohtak. And he's a very good speaker, and we love to listen to him, a dear friend. And his topic is prevention of GDM possible? So as I told, Dr. Rajesh Rajput is a senior professor and head department of endocrinology at PGIMS Rohtak. He has number of publications, number of awards, and a well-known and very good speaker. And I would like to invite straight because we are already running short of time. Dr. Rajesh, please start your presentation.
Thank you, Dr. Grish, for kind words. Can you allow me to share my screen?
Yeah.
Right.
Yeah, you are audible. You can start.
So the slides are visible, Grish?
Yes, you start.
Yeah, slides are visible and I am audible.
Now it's visible. Okay.
Right. Okay. So thank you, Dr. Grish, for kind words of introduction. So this is my latest CV. I do not know, that is 5-year-old CV. So the publications from 110 are now 170. So
that's great.
so anyhow, thank you RSSDI team for inviting me for this lecture, and the topic allotted to me is prevention of GDM. Is it possible? Now this is in brief about the agenda, which I am going to cover over next 18 minutes or 19 minutes. Now the definition of GDM has changed over last few years. Initially, we used to diagnose GDM by definition, any degree of glucose tolerance with onset or first diagnosis during pregnancy. But this has got caveats. Based on that, in 2015, GDM is now defined as diabetes diagnosed in second or third trimester of pregnancy, and that was not clearly overt diabetes. It means two important things. Diabetes diagnosed in first trimester is not GDM, it is diabetes. Similarly, if your FPG is more than 126 and postprandial is more than 200, it will be labeled as diabetes and not GDM. So there is a distinction between diabetes and GDM, which we need to understand. There is a huge prevalence of glucose intolerance in pregnancy, but what is important to understand that out of that, 90% of the glucose tolerance in pregnancy is because of GDM. Now we have done some of our own study from Haryana. Now this is a study where we have tried to find out the prevalence of gestational diabetes, which we found to be around 7%, and number of risk factors. Now why I'm showing you, because whenever we talk of prevention, first we have to understand the risk factors, only then we can talk of prevention. And in this study, we have shown that advanced maternal age, higher educational status, lower socioeconomic status, pre-pregnancy, body weight, BMI, weight gain, acanthosis nigricans, this we have shown for the first time in literature, that acanthosis nigricans, just a physical examination give you a clue that this lady is going to have GDM, family history of diabetes and hypertension, and past history of GDM. Then we have also assessed prevalence in rural Haryana. Again, there is a very few studies regarding prevalence in rural population. So this is a hardcore rural population study where again we identified that the prevalence of diabetes from different criteria varies from 9% to 14%. So definitely there is a huge burden of GDM in our population. But then why we are concerned if this is not diabetes, this is a pre-diabetic state. The reason is there are maternal and there are neonatal consequences. What are the maternal concerns? They have been highlighted here, which include right from preeclampsia to increased UTI, increased need for cesarean sections, polyhydramnios, and postpartum uterine atony. Not only that, these GDM mothers are actually at increased risk of future development of overt diabetes. The conversion rate is overall 4% per year. Around more than 50% of these women are going to become diabetes after 10 years. They're also at increased risk for developing cardiovascular complication. If we look for concerns to the baby, this include macrosomia, which means increased risk of birth injuries, which are highlighted here, fetal hypoglycemia, fetal hyperbilirubinemia, fetal hypocalcemia, and increased perinatal mortality. Apart from these birth issues, these children were born to a GDM mother. They have increased chances of childhood obesity. They are at increased risk of development of future diabetes and neuropsychological outcome. And based on all these information which is available to us, in St. Vincent Declaration, it has been said that outcome of diabetic pregnancies should be similar to non-diabetic pregnancy. However, unfortunately, we are still miles away from reaching this goal, and we have to do lot of things in terms of prevention and management of GDM. And I am going to discuss only about prevention of GDM. So why prevention of GDM? So what are the potential benefits? If we reduce GDM, we are going to reduce immediate maternal and fetal adverse outcome, which I have discussed with you. It is going to have a marked improvement in risk of long-term sequelae, which again I have discussed with you. And not only that, if we do this, it will result in reduction of economic burden to healthcare system. Now it has been identified that for care of GDM, the cost of pregnancy delivery, if we consider in vis-a-vis non-GDM, it is 3 times higher. So it is a huge burden on healthcare system. Now these are number of risk factors which I have again told we have identified in our own study, right from advanced age, obesity, short stature, family history of diabetes, and so on. But then there is another way to look at risk factors when we are talking of prevention. We have to understand there are some factors which are non-modifiable and there are some factors which are modifiable. The non-modifiable risk factors include our ethnicity, underlying history of polycystic ovary syndrome, previous pregnancy with GDM, family history of type 2 diabetes, and advanced maternal age. And as you see, we cannot change any of these risk factors. On the other hand, the modifiable risk factors include pre-pregnancy body weight, means overweight and obese females. Dietary factors, what type of diet an individual is consuming. Physical activity, the level of physical activity. So basically, these are the three important modifiable risk factors which might be going to change the way increasing prevalence of GDM is seen in our society. So when it comes to prevention of diabetes, there are three important aspects. Lifestyle interventions, which include diet, exercise, or combined diet and exercise. Dietary supplements, which are given over the counter by so many doctors, and pharmacological therapy. Now, what I am going to discuss over next few minutes with you is regarding studies in brief, and this is how you should learn from those studies. That, as you see, green with tick, clear evidence of benefit, red with cross, clear evidence of harm, and so on. So this is a strength of evidence which I have tried to enumerate it against the number of studies. Now, if we look at dietary interventions, these are two important studies which are published in 2017, where standard versus intense dietary advice is compared in understanding the decreasing prevalence of GDM. As you see clearly, the number of participants are low, and the quality of evidence, which is graded as either low or very low. And if you see the relative risk, it varies from 0.6 in first study to 0.91. But if we conclude the dietary interventions, unknown benefit or harm of dietary advice versus standard care on risk of GDM in these two studies. If we see the risk of benefit of exercise interventions alone, and again, this study is published in 2012, and in this study, again, it has been shown that the relative risk crosses the level of 1, and the quality of evidence is low. So we can summarize, again, there is not much benefit of exercise alone vis-a-vis standard antenatal care in reducing the risk of GDM. The third way to do it, combined diet and exercise. Now, this again has been studied and has been published in Diabetes Systemic Reviews in 2017, where both diet and exercise are given in comparison to the standard of care. And for the first time, when diet and exercise both are combined, it has been shown that there is possibly a benefit of combined diet and exercise on reducing the prevalence of GDM with relative risk of 0.85, and the quality of evidence is moderate. So if we summarize these 5 important studies, as I have told you, isolated dietary advice, use of low glycemic index, the effect on GDM is controversial. Use of exercise alone, the effect on GDM is controversial. Not only that, the quality of these studies are grading as very low. In contrast, the study which is published in 2017 and in Cochrane meta-analysis, it has been seen that it is a combined diet and exercise intervention which has got some benefit on reducing the prevalence of GDM with grade of evidence moderate. Now, coming to an important study which is known as radial study. What is radial study? Gestational diabetes mellitus by lifestyle intervention. Lifestyle intervention include diet and exercise, and this is a Finnish gestational diabetes prevention study. This is like DPP study which is done for type 2 diabetes. In this study, 540 women were enrolled. They were given OGTT, and based on diagnosis of GDM, they were allocated to intervention or to a control group. In the intervention arm, ultimately 144 women were available for analysis, and in the control arm, these are 125 women. What this study has shown? This study has shown that in intervention group, the prevalence of GDM is 13.9% vis-a-vis 21.6% in control group, with a significant p-value, which means the radial study has concluded that a moderate individualized, remember it is individualized, lifestyle intervention reduced the incidence of GDM by 39% in high risk pregnant women. Now, if we see the meta-analysis, which is including 29 randomized controlled trial involving more than 11,400 patients, as you see this forest plot graph, clearly it shows that lifestyle intervention are beneficial with a relative risk of 0.82, which means they reduces the incidence of GDM by around 18%. So definitely in women who are at high risk for GDM, if lifestyle intervention is given, it is going to prevent development of GDM during pregnancy. But then an important question comes, when should we initiate the lifestyle intervention? Should early in the pregnancy, that is during the first or second trimester, or late in the pregnancy? Now, if you see the meta-analysis again, it has been clearly shown that if you start lifestyle intervention before 15th week of gestation, it will result in 22% reduction of incidence of gestational diabetes. In contrast, if it is started after 16th week of gestation, then it will result only in a non-significant 3% reduction. So the message from all these trials is that those women who are at risk for GDM, they should be subjected to appropriate individualized lifestyle intervention, and it has to be initiated right at the time of conception. We have not to wait more than 16 weeks when the benefit is not seen even with lifestyle intervention. So the lifestyle modification during pregnancy, especially if initiated before 15th week of gestation, can reduce the risk of GDM. Now the next important part is dietary supplement intervention. Now there are a number of studies involving various supplements like omega-3 fatty acids, myo-inositol, probiotics, vitamin D alone, vitamin D plus calcium, vitamin D plus calcium plus other vitamins or minerals. And as you see, again, I have tried to summarize in one slide with quality of evidence. And again, I will try to summarize for you so as not to confuse you. If we see omega-3 fatty acid, the study have shown clearly no evidence. And the relative risk is 1.02, and it is not found to have any effect on reducing the incidence of GDM. If we see myo-inositol supplementation, which is a type of B complex again, possible benefit, myo-inositol actually reduces insulin resistance. It is a drug again used in women with polycystic ovary syndrome. It has been shown that relative risk is around 0.43 with upper bound confidence interval 0.64, which means possible benefit when it is used in high risk women who are going to be pregnant. It has shown that reduction in incidence of GDM. If we see vitamin D supplementation, we have done in our own study. Again, I am not showing here because of shortage of time. In vitamin D study, we have shown that it is only severe vitamin D deficiency which is associated with increased prevalence of GDM, not vitamin D insufficiency or mild deficiency. And in this study, they have shown that it is possible vitamin D supplementation in those whose vitamin D levels are less than 50 nanomoles per liter. Possibly there is a role in reducing the incidence of GDM. Not only GDM, it has shown beneficial effect on reducing the incidence of preeclampsia during pregnancy. Coming lastly to probiotics with the dietary intervention, again unknown harm or benefit. So again, not of proven benefit. So out of dietary supplements, it is myo-inositol and to some extent vitamin D, which has been found to be beneficial. And again, as I have told you, these are the grade of evidence in different colors with query plus or equal marks. As you see clearly, it is myo-inositol and vitamin D, which has been shown to be of some use in reducing the incidence. Lastly, coming to therapeutic intervention and focusing on a single drug, which is metformin. Now, metformin is commonly used in early pregnancy and even in PCOS women. And it has been used in second and third trimester for treatment of GDM. However, current evidences do not support metformin as a preventive option for GDM. Now, this is an EMPOWER study. This is a randomized study involving 449 obese women who were given metformin in a dose of 2,500 milligrams per day. And then Empower study did not find any difference in GDM prevalence, maternal weight gain, or maternal lipid metabolism. In fact, even the birth weight is comparable between the two groups, and metformin use was associated with more diarrhea, 42% vis-a-vis placebo, that is 19%. Two another studies with metformin where it has been shown that the results are not supportive. In fact, they are equivocal, and it has been shown that in only those women who are obese, whose BMI is more than 35, when we have used metformin in such type of women, there is some chance of reducing maternal weight gain. And this weight gain is reduced by around 1.7 kg, which might have resulted in some better outcomes. However, the GDM incidence again was not different. Lastly, we are in an era where overweight and even obese individuals are now undergoing bariatric surgery. It has been shown that for marked obesity, when these individuals have undergone bariatric surgery, because of marked loss of body weight following bariatric surgery, it has shown reduced GDM prevalence, lower rate of large for gestational age infants, and reduced prevalence of pregnancy hypertension. But then there are many disadvantages. An increase in impaired fetal growth reflected by higher rates for short for gestational age infants, higher incidence of preterm deliveries, and surgical treatments which have caused malabsorption and are followed by greater reduction. So definitely we have to be cautious if we are subjecting young unmarried girls and asking them to undergo bariatric surgery, because in future they are going to be married and they are going to have childs. So these are some of the issues. Now, before I conclude, when we talk of prevention, it has been told to us in our community medicine classes during MBBS lectures, there are three levels of prevention: primordial prevention, primary prevention, and secondary prevention. Now, when we talk of prevention of GDM, it is primordial prevention, that is lifestyle intervention started in pre-puberty and pubertal phase, or primary prevention when they are started in preconception stage. What actually has been done worldwide is that most of the time focus is on secondary prevention when women become pregnant and they are at high risk for developing GDM. And probably that is a reason, as I have told you, that large number of studies, whether it is exercise, diet, dietary interventions, or metformin, have failed to bring about significant change in incidence of GDM. So we have to change our approach. We have to go directly to primordial and primary prevention, because whenever we talk of prevention, it is primordial and primary prevention which is more important rather than secondary prevention. Before I conclude, when we talk of prevention of GDM, we have to think a life cycle approach. Life cycle approach means at which stage of the life we are seeing the individual and what are our health resources. In life cycle approach, in pre-pregnancy, if we are seeing all females, children, adolescent girls, and those unmarried girls who are less than 30 years of age, they come under pre-pregnancy phase. And in all these individuals, there is a need to initiate community awareness, assessment of risk for GDM, initiate early therapeutic lifestyle changes, and then only we can change or decrease the incidence of GDM in our society. In contrast, if we see women in pregnancy phase, as has been commonly done in routine clinical practice, we have to universally screen all pregnant women, identify them at the earliest, initiate medical nutrition therapy. But remember, in pregnancy, you have not to wait more than 2 weeks. If after 2 weeks of therapeutic lifestyle change, the glucose level remains more than 120 milligram per deciliter, we have to initiate therapeutic drugs. Lastly, postpartum phase is not important. This is a time when the woman is most receptive because she has already suffered an episode of GDM. She should be given advice about therapeutic lifestyle, not only to her, but even to her baby, that how your baby in future might be at a risk if he is or she is not given proper lifestyle changes as that young baby is going to grow up. So friends, whenever we talk, I have told lifestyle approach in terms of GDM, but I believe when we talk even about diabetes in general, in type 2 diabetes, we have to understand life cycle approach whenever we talk of prevention of GDM. To conclude with, GDM prevalence is increasing in India as well as globally. For prevention of diabetes, GDM, we have to identify high-risk women. Lifestyle interventions are useful. There is not much role for drugs. For dietary supplement, there is some role for myo-inositol and metformin, although more evidence is needed for lifestyle, dietary supplement, and pharmacological measures. Thank you very much.
Thank you, Dr. Rajput, for an excellent presentation. Now, before we open it for discussion, one question I would like to ask you. These days, pregnant women, they are doing a lot of yogas. So are you doing any study of yoga in pregnancy itself? Because type 2 diabetes, we are doing yoga and we are prescribing few asanas. But in pregnancy, is there anything special would you like to recommend?
Right, Dr.
Before
Girish,
I
you are
hand
right.
over the mic
Actually,
to Dr. Mathili.
Very recently, we have finished our work on effect on yoga on pre-diabetes individuals. And one of that paper has already been published in International Journal, Metabolic Syndrome Research and Reviews. Second paper is under publication. But in pregnancy, we have not still studied the effect of yoga, but this can be studied, because yoga has been found to contain an aspect of exercise as well as changing the way the SNS is stimulating our body. It is found to be beneficial. But again, as I have told you, we have not to focus on those women who are diagnosed with GDM. In fact, yoga, lifestyle, or diet has to be advocated right from school stage to all the young ladies, so that they can adopt a healthy dietary and lifestyle measure that only can result in change in prevalence of or incidence of GDM. Otherwise, once they become pregnant, they are diagnosed with GDM, whether you do yoga, whether you do lifestyle, as I've shown you the studies, and whether it is going to be useful, it's controversial. So it's a good idea. We will plan a study and we will inform you once.
In fact, RSSDI Delhi chapter, we have written so many letters to school, NCRT and CBSE, to have a look at the school canteens and their sport curriculum, because that is the point where we can stop prevention, we can do prevention. Most of the schools, they are doing.
Dr. Girish, you are right. But in our country, we do lots of meeting and write lots of letters, and that make no difference. And see, we have to understand our socio-economic society. Cost of purchasing a samosa or a burger, even in a canteen, is much less as compared to cost of purchasing fruits or healthy foods. Now in canteens, they used to provide food which is easy, cheap. Parents are giving 10 rupees or 20 rupees. I'm not talking of big corporate school where children carry 1,000 rupees in their pocket. Usual small schools, their children carries 20 rupees, 25 rupees. So there are many issues, as highlighted in the previous lecture. Government has to give incentive on healthy food, give disincentive on unhealthy food. But all these things are political issues which are beyond your and mine control.
Now, Dr. Mathili, would you like to conclude?
Thank you, Dr. Girish. Hi. So thanks. I thank all the speakers for the wonderful presentation. I think, as far as prevention of gestational diabetes is concerned, gestational diabetes is pre-diabetes. The speaker told us. This definition has changed. It is pre-diabetes. The same risk factors operate. I think the most important risk factor in a young woman now is obesity. So unless we prevent obesity in a child, in a girl child, prevent obesity in an adolescent girl, and then a young woman, I think prevention of gestational diabetes becomes very difficult. And then the previous talk was prevention of type 2 diabetes. Again, a very nice talk. I think most important message for prevention of type 2 diabetes is weight reduction. A 15 kg weight loss now has been shown to, ameliorate type 2 diabetes. I think that is the take-home message. And for the first presentation by Dr. Bharat, yes, I think early diagnosis and beta cell preservation maybe is what is the message for prevention of type 1 diabetes. I think with this, we will conclude this session and hand over to the organizers.
Thank you very much.
Thank you.
Thank you. Thank you.
Bye.
Good evening. I'm Dr. Suranjit Badua, one of the chairperson. Can I have connect to my co-chair, Professor G.C. Reddy? He's unmuted, I think. Professor J.C. Reddy, please. Please unmute yourself.
So you have to unmute.
Hello. Yes, now audible. You can go ahead, sir, for the first speaker.
I will go ahead with the first speaker.
Yes.
Next, you can go ahead with the other speaker.
Okay.
So, the first speaker, the almost national, internationally renowned speaker, Dr. V. Sheshaya, I introduce him. So, he is speaking on all life course. Events are programmed in the womb. That is the Chanakya's, the visionary. That is the topic he is going to deal with. So he is a renowned figure, and he the first established Department of Diabetes in Madras Medical College in 1976, patron of RxSDI in India, and patron of DIPSI, and founder member of Diabetes in India, and the expert committee member of the International Association of Diabetes, that is DIPSI, and he is a recipient of BC Roy Award for his excellent national development of diabetes as a specialty in India. Like finally, he is given the lifetime achievement by International Diabetes Federation in 2017. I request Dr. Vishesha to go ahead, sir.
Respected chairpersons, I'm very happy to address this elite audience. And before I start, I'd love to thank Dr. Banji Sabu, Dr. Vasant Kumar, Dr. Sanjay Agarwal, and all other friends here and the RSA members. And thank you all for inviting me to give the guest lecture. So as G.C. Reddy, I know him also for quite some time, and he has come here. And I'm also happy to be talking in the same session with Professor Ashok Kumar Das, A.K. Das. So my topic will be on this topic. This is quite a little look out of the way, but I want to speak on that. So friends, now we have forgotten our own ancestors. And it's let me now remind you that our country has got lots of science, but very rarely is what you call taken consideration. That's why I thought this one, all life course events are programmed in the womb. Thus spoke Chanakya, the visionary. So with this introduction, I am going to speak here estimation and projection of the diabetes in the world 2079. It will be from 463 2019 to about 700, 700 in 2045. So now the problem is here, you will see this slide here, 2019 463, it has gone within 2 years, 60% increase. So your projection was supposed for 54, my projection is going to be 10%. That is going to be the problem which you are going to face. Now, and here, the pre-diabetes approximately 318 million, which is likely to increase to about 481 million by 2040. And finally, now we are all thinking diabetes is an epidemic of unprecedented magnitude, but lately IDF has come out with the idea saying that diabetes is a pandemic. So we are slowly to become a disease like going to prevent like COVID pandemic disease, and I don't know. And as Rajaput was talking, probably it can become universal also. So with this difficult problem they are going to face in this world, is there a hope to reverse this trend? How can you do the room to focus? So that is why I told here, I take this acronym from that of Chanakya. He said about 2000 years ago that when a life gets seeded in a mother's womb, its age, deeds, wealth, education, death all determine right. So he said everything starts from the womb. So this Acharya Chanakya was a philosopher, economist, teacher, jurist, and royal advisor. He has compiled 2 books, Arthashastra and Chanakya. So I take this particular slogan from his book saying that when this is what everything starts in the womb. So how that having taken that particular point 2000 years ago, now see what happened this century. After 2000 years, in India nothing has happened. People are working here and there. Now this Dr. David Barker from UK suggested the body's susceptibility to lifestyle diseases was programmed interrupt. It is similar to what Chanakya told. But this concept was almost sleeping. Suddenly after 2000 it has come back to the life. Now he said like Chanakya whom programmed intrauterine. So what a beautiful statement he has made. Now you will see here in vitro fertilization, the ovum is well supplied to the mitochondria. That is very important message. But the sperm contains a few, even those few do not persist in the offspring. That shows ovum is very important, mother is very important here. At fertilization, it is only the nucleus of this protozoan that enters the ovum, and thus all the cytoplasm, mitochondria, and mitochondrial DNA are exclusively maternally inherited. So this again this concept 2000 years ago, how the Chanakya made that statement, everything from the womb. So maternally inherited. And further, instead of programming here, gestational programming is a process whereby stimuli, hyperglycemia, are stresses that occur at critical sensitive periods of fetal development. Once anything changes here, you examine hyperglycemia, permanently change the structure, physiology, and metabolism, which predispose individuals to disease in adult life. That's over. Your future is sealed here. When the intrauterine life you go to hyperglycemia, mother, that child is going to get all the problem with the world, and the NCD, as I Dr. Rajput was talking, fetal origin of other diseases. From Chanakya, I have come to now David Barker. Now what he said was maternal inheritance. It's attributed to the mutation in the gene present on mitochondrial DNA and is transmitted neurally by an affected mother to her progeny. That means the father is not taken into consideration at all. See, from Chanakya and David Barker, everybody, it is from mother only to her progeny. So you have to be very careful, think mostly about the woman who is going to bear the child. In this, the unique feature of mitochondrial DNA is maternal inheritance. That means this both our Chanakya and David Barker has completely telling everything from the womb. So having dealt with this, I will see here a small discussion here. Diabetes mellitus. Is it inherited destiny or going to get inherited from parents, genetics, or intrauterine, which is more vital compared to both of these, inherited destiny and intrauterine. This is a very beautiful slide here. Increasing prevalence of diabetes in children. It's an extremely nice statement made, the observation. The offspring of Pima Indians who were hetero, when their mother had diabetes, have a greater risk of diabetes than earlier siblings. So, born before the mother developed diabetes. That means anybody born before will develop diabetes. Whereas an increase in the frequency of exposure to diabetes in utero appears an important feature of the diabetes epidemic. That clearly shows, again, uterus plays a vital role, and the child developing the uterus is going to develop diabetes when the mother happens diabetes. And not only here, it is proved also by people, by experimental animals. Here, what they want to know, it is going to gene or introvert environment. This statement is very nice study. Western rats, the low genetic risk of diabetes, they don't develop diabetes at all, no risk. So what they've done is, when exposed to hyperglycemia media of goat rat, intro, which is very vulnerable for the diabetes, hyperglycemia, what happened? Significantly increase the risk of diabetes in the adult life. The rat is not genetically risk, but unfortunately when they transmit into the hyperglycemic uterus of the goat rat, that rat develops diabetes. So both studies, human being and animals, they have proved clearly the intrauterine programming is very important. Thus, exposure to a diabetic environment in utero associated with the increased occurrence of impaired glucose tolerance and defective insulin secretory response in adult offspring, independent of genetic predisposition to type diabetes. So we can conclude here, intrauterine milieu is more important than the both can occur, both can contribute, but intrauterine milieu is more important than the inherited destiny. So having completed this particular statement, now we go to another hypothesis. This recent Norman Frankel hypothesis as mixed nutrients. We all thought about hyperglycemia, but he is telling us another way of mixed nutrients. Influence of maternal fuels during pregnancy, that's called fuel-mediated teratogenesis, as the basis for long-range anatomic and functional changes in the fetus. So he is a little more wider than only glucose. He thinks about other maternal fuels also. It has been proved, though targeting intervention early in pregnancy beyond glucose may be critical to improve fetal growth patterns. So this is that means he said a very beautiful statement here. Pregnancy is a tissue culture experience. So the influence of maternal nutrient on phenotype fetal gene, abnormal mixture of maternal nutrients, gain access to the developing fetus and modify phenotype gene expression in newly formed cells, and thereby causing permanent short and long-term effects on the offspring. So that's what Louis Joni, another great lady who proposes is no more, made a very good statement here. So we're summing up so far, modified Frankel's and Peters hypothesis affects the maternal fuels on offspring development. What happened here? This picture shows pregnant diabetic, hyperglycemic pregnancy, insulin level is low. As a consequence, plasma glucose goes up, amino acid goes up, their lipid also going up. This is called mixed nutrient. This mixed nutrient crosses the placenta and goes to the fetal compartment, where it stimulates insulin in the fetal pancreas. Child develop macrosomia because nutrient is available, insulin available, so child develop macrosomia. The child born neonatal may go to hyperglycemia because its environment is changed. What is important here, when the child grows, if it is male, it will develop obesity and impaired glucose tolerance. And finally, it may develop diabetes. But the problem will be here, pregnant diabetes there, and this child happens to be female. Suppose she develops obesity, the next step will be she will become GDM. So again diabetes. So pregnant diabetes again leads on to diabetes, and then her own child, female child, she become diabetic. So that is why what we call here vicious cycle of diabetes begetting diabetes. So up to this chapter is over. Now I will go to another chapter, fetal placental maternity. I want to share with you. Long ago, was started in 1880 itself by Professor Samuel Moses, Professor Phillips, and myself, first of its kind in the country. This was started in the Institute of Obstetric Gynecology, or those at Department of Medical Hospital. Where the word is institute in Asia. This is where it was started. Now, why this started? Because we are aware of this problem of diabetes occurring in the pregnancy. This is a very big terminology. Those days we call feto-placental, maternal, hormonal, metabolic interaction implications. Such a big, because all these things involved in the pregnancy and child development. So, of course, now we call diabetes pregnancy services, but this is the original name was feto-placental maternal unit. Now, coming back to here, why this feto-placental utero apparatus? That is called apparatus because all three together. During intrauterine life of the fetus, the membranes, the cord, and the placenta form an organic whole, the complete apparatus, and disease of any part must react upon and affect the others. That is what that's why you call feto-placental apparatus. Anyone interlinked here. And now we'll see what could happen. Next step will be what happens pregnancy. So a new structure develops de novo during pregnancy and matures till it is expelled at the completion of the gestation period, in the intrauterine period. So the metabolic adaptations that occur during pregnancy are to, that's what our aim, natural aim is, metabolic adaptations that occur during pregnancy are to accommodate a rapidly growing tissue transplant. That's called transplant because it's going to come out. The concept test. The concept means here placenta and fetus, they call concept test. So this is what happens in the pregnancy. Now having dealt with that, though we will conclude here maternal nutrition. The goal of nutrition of pregnancy is to support maternal, placental and fetal metabolic needs. It may be first introduction, lifetime of healthy eating. So this is a nice statement from Calcutta. Dr. Bed Sudip Chatterjee. He said long ago on Rebels, his badge is endocrinologist in Calcutta. Insulin response is very accurately modulated by the calories load so that a normal human blood glucose remains stable in a narrow band in spite of wide variations of food intake. So that is what all of us go through if we are normal. Then the same thing happens in the intrauterine fetus also. Maternal glycemia and insulin response. What happens here? This is again very beautiful study here. Pregnancy induces a progressive change in maternal carbohydrate metabolism. As pregnancy advances, insulin resistance, diabetogenic stress due to placental hormones, it is natural. Everybody will go through that. The hormones necessitate compensatory increase in insulin secretion. So all these physiological phenomena will be there to raise the blood sugar level. At the same time, increase insulin secretion also will increase. This is shown in this slide here. Glucose will be 76, 88, 79, 78. All through pregnancy, the blood sugar is same almost. But whereas you will see here, insulin level from 12.3 it goes to 27. To maintain same blood sugar level, it almost goes to 2.5 times. That is what called progressively increasing insulin elaboration enables it to maintain the plasma glucose level following glucose load throughout pregnancy. That means it's all manifestation. Such a beautiful insulin secretion will be a physiological response to glucose level to maintain within normal range. So now this is called where this compensation is inadequate, probably that lady will develop gestational diabetes mellitus occurs. Now having finished with the cause pathophysiology of little bit, then goes to the this is another organ, placenta. Placenta is a temporary endocrine organ because it goes out, but it is one of the natural mechanism. It is endocrine organ, but only temporarily it is there. Placenta connects the developing fetus by the umbilical cord to the uterine wall to allow nutrient uptake, thermoregulation, waste elimination, and gas exchange by the mother's blood supply to fight against internal infection and to produce hormone which support pregnancy. So such an amount of function the placenta is doing, it's a poor thing, it develops and gets expelled after the child is born. Now this particular slide will tell you the placenta facilitates embryogenesis, growth, maturation and survival of fetus. All these functions are done by placenta. The placenta has the capacity to synthesize steroid and peptide hormones and to modulate and transport maternal fluids. That is the job of the placenta. Its job is to see that the hormones are modulates, transport maternal fluids to the fetus, then an exquisite hormone metabolic adaptation. So nature given everything such a brutal responsibility, each organ what they when they become pregnant. Now the concept is that means placenta and infant for its own normal growth and development brings about alteration in the maternal fluids metabolism and hormones. It itself modulates. Here you will see here this very important statement. These hormone regulated adaptations include increased hepatic glucose production, the fasting state. See how the nature adjusts. If suppose mother is fasting, this goes to the liver, releases the glucose. So increase hepatic glucose production, the fasting state ensure a glucose supply to all times. Whereas in case when child is fed state, child takes mother takes food, maternal peripheral insulin resistance spares glucose for the fetus. The first stage. Changes in maternal metabolism during pregnancy will be like this: decreased fasting glucose level, increased postprandial glucose level, increased fasting and postprandial insulin levels, beta cell hypertrophy and hyperplasia, decrease in sensitivity, enhanced labor. All these things are responsible for getting the fetus nutrition. Now I'll show a study here. This lady, pre-pregnancy weight 52 kg, underwent treated twice. First time she came at 16th week, absolutely normal level of glucose, the fasting 1 or 2 and A1C is normal. And again she came at 26th week, absolutely again normal. But after that, as a custom of our Indian ladies, they go to mother's place. That's all. She is out of the sight. Nobody bothered about beyond 28 weeks. Then what happened here when they followed up? Did not count for follow-up as she left to her maternal place for confinement. There, by the time she went to the mother's for 52 kg, she developed 64 kg. 12 kg weight. That's the usual paternal care. And then when delivered a female baby, there were 4 kg. And then she has to undergo the cesarean section. So anyway, child was no complicated. But here you see one cesarean section and child weight for 4 kg. You will see what happened here. Now, the reason for this I am going to explain now. Each islet cell functions as an endocrine organ. Not only placenta, but in the pancreas also each islet has an endocrine organ because it produces so many hormones. The human pancreas begins to develop 4 weeks after conception. The first insulin deposit can be found between the weeks 7 and 8, so early it comes. And what is waiting for diagnosing 24th week. And then pancreatic islet differentiates 10th and 9th week of gestation, recognizes response to maternal glycemia at 11th week of gestation. So this fetal cell, I'm going to discuss a very important point now. The fetal beta cell is going to respond to maternal glycemia at 11th week itself. Then you can imagine now itself what is going to happen if blood sugar goes up after 12th week, because this fetal cell will respond to the maternal glucose. We'll see here. Amniotic fluid insulin, which originates from loss into the fetal urine, is just detectable at 12 weeks, more easily measurable from 14th week onwards. 11th week itself secretes. And here, elevated amniotic fluid insulin concentrations beginning at 14 weeks are associated not only with the mother's risk of developing GDM, but also with the risk of the fetus having a birth weight of more than 90%. It's a terrible message here. It's a very important message to know that 14th week itself is going to be a problem for the fetus. Now, this is very important slide here, schematic representation of maternal fetal nutrient transport in humans. Here, maternal side and fetal side, glucose can transfer from mother to the fetus. That is maternal glucose. And again, amino acids, these are all very important nutrients. They'll go between mother and the intrauterine fetus. Whereas triglycerides will not cross to the fetus. And then again, insulin will not cross, glucagon will not cross. So only nutrients will cross from mother to the fetus. Now this insulin glucose will not cross. Now what is the reason? Why? What should be the mechanism or natural way of dealing with pregnancy? Here we will see here contribution to glucose gradient. This is a very important subject here. I will take a little more time here. Mother, placenta and fetus. Maternal glucose, suppose it is going to high, it will go to the glucose is going, definitely is going to go to the fetal compartment. It will go to the fetal compartment, and when it goes to fetal compartment, it definitely stimulates insulin in the fetal pancreas, as I told earlier. So poor glycemic control early in pregnancy will result in the establishment of fetal hyperinsulinemia, causing an exaggerated fetal glucose steal. Then the idea is here, because the glucose of the mother has gone to the fetus. Fetus has produced more of insulin. Its sugar of the mother. I'll show you the next point. Here you will see here, because of the insulin has gone up in the fetal compartment, as a consequence, the overactive glucose steal will increase the disposal of maternal glucose to the fetus. So mother's glucose go to the fetus, thus attenuating the levels of maternal hyperglycemia. So the beauty is the child, intrauterine male child, tries to help her mother to bring her sugar low. Unfortunately, without knowing that that child is going to get a problem. As a consequence, overactive glucose steal will increase the disposal of maternal glucose into the fetus, thus attenuating the levels of maternal hyperglycemia. That is the natural way of doing things. That child helps the mother. That as a consequence, importantly, this affect of lowering maternal glucose. This glucose goes low. Maternal glucose driven by the fetus, the greatest pregnancies, the most hyperinsulinic fetuses. So more of insulin. When you check the blood sugar in the mother, you will think mother is normal. Unfortunately, it's a different thing happening because the fetal handling of maternal glucose. That is why mother's blood sugar is normal. So now this feto-placental dialogue and disability in a different way here. Maternal insulin and glucose, they go both the way it goes. Then comes to the fetal placenta, goes to the fetal compartment. The glucose goes to fetus in the intrauterine fetus. Again, it stimulates more of insulin. As a consequence, betas like hyperplasia. All these things will produce increased fat tissue, adipose number, triglyceride deposition, hypothalamus. So child will become fat, diabetes risk. So first trimester, pregnancy, second and third one, child adulthood. That's how, unfortunately, this which we don't want could occur because of the high blood sugar level in the mother. That and unfortunately, again, fetal started take care of the mother's blood sugar. She or the child also become obese. So this is a vicious cycle. So that is why, and as Dr. Rajput was telling, maternal blood sugar should be within the absolutely the normal. Anywhere deviation, it's going to become a problem. Now, all available evidence suggests that the placenta is a passive conduit for the proportion of maternal glucose destined to reach the fetus, at least at the end of the gestation. So, thus maternal to fetal glucose flux is mostly dictated by the maternal to fetal glucose constant gradient. So, that is why maternal glucose should never go up. So, again here, there is another important message here. An exaggerated glucose steal by hyperinsulinemic fetus, it has to steal, could also attenuate the maternal glucose level during OGDT. That is what problem starts. You will be taking blood sugar normal, but it's normal because fetal has taken up the responsibility. Providing an explanation for why some mothers with fetuses, with all characteristics of the most affected fetus have normal glucose tolerance. Fetus taking all the glucose, so you see the mother having a normal glucose tolerance. Thus, there is a risk that GDM will not be diagnosed in women with the most affected fetuses. This is the message I would like to convey here, and then probably this is what happened in the Indus case, which I told you, that particular lady did not come to the hospital or did not go to any doctor for testing. Ultimately, she landed up in a produced a big baby, gained weight, and 4 kg. All complications occurred for a simple reason: she did not follow up. Then gestational weeks, again another important message I would like to share with you. Gestational weeks are ideal for screening. What time is screening? Most of us do that book. Usually recommended 24. It's very bad. Here, what you have done here, early screening for glucose intolerance and care could avoid some diabetes-related complications such as arrhythmias, fetal anomalies, and preterm birth in women with gestational diabetes mellitus. Now, I will show you a study what we have done here. It is our studies purely, we manage mostly GDM. Prevalence of GDM in different trimesters here. 16% will be in the first trimester, and the second trimester will be about 20 to 22%, and third trimester 60%. That means almost so it's almost out of 451 women, 71.9 had more than 140 milligrams and identified as GDM. So you will see here less than 24 weeks, almost 38% of women have got the GDM. The manifestation, another study shows here, in the trimesters here, if it is first trimester, 4,300 we screened, 31.5% had GDM positive. And second trimester again 42%, third trimester 20. We will see here, with textbook you follow third trimester, you will miss so almost 72% of it would have missed, 73%. So that is why we say necessitating early screening. A number of advantages will be there. We screen early week screening even before 9th week itself. Here we give one more case study here. This officer, you see, she had a fine 2.5 kg, no history of GDM, MTP done, present pregnancy, anti-woman, she had the blood sugar test around 28 weeks, she went there, and they found out fasting 102, PP 140, these values were ignored. The ultimate what happened, at just 35 weeks, now from 28, 35, and the anti-woman went for routine ultrasonogram for reveal, here important, it only revealed the fetal macrosomia, fetal weight was 3,080 grams. The anti-woman was then advised to do GDT. When they did that, was found such a high level, fasting 131, 1 over 279, and 2 around 242. Anti-level was then referred to us around 36. What we did was immediately started insulin and brought it down to 112 and 172 and achieved 7.3. Fortunately, and we could bring it down up to normal level, 88, but still, in spite of our bringing it down to normal level, blood sugar, what we had an outcome of C-section was active under C-section, newborn birth weight 4.5 kg. This message out here is, even if you try to bring down your blood sugar of the mother, third trimester, late pregnancy, his blood sugar may become normal, but she cannot avoid the child becoming big baby. Now, the hallmark of diabetic fetalopathy is fetal hyperinsulinemia, drives fetal fat accumulation, very often resulting in LGA birth. This is just showing. Now again I want to share one more important work which we have got in the area. Early detection of glucose tolerance during pregnancy, the care given results in good fetal outcome similar to that of non-diabetic pregnancy. Here, this slide shows here, again this is IS center for only for GDM, 87 women were taken here. Out of the group 1, they came less than 23 weeks, and group 2, 33, more than 24 weeks. What happened here, when outcome of birth weight on units was 3.13 in the early group and about 3.42 in the later group. The messaging here is birth weight of the infants born to GDM women in group 1 was 3.13. In group 2, 3.42, which was statistically significant. This statistically, though there was no statistically significant difference in the glycemic control of the two groups. So that shows, even though you try to control blood sugar well, the second trimester, third trimester, you cannot avoid obese child become macrosomic. Diagnostic care from early weeks is very, very important. So coming to care, diet control, diet pregnancy, reverse fetal hyperinsulinemia, fetal glucose still, no. Despite normalization of birth weight, management of GDM has not been shown to normalize the excess fetal adiposity. Thus, fetal hyperinsulinemia appears to be difficult to normalize with the usual approach to managing the mild fetal hyperglycemia. So finally, my comment here will be, we may not miss any GDM by screening around 24th week. But a substantial number of pregnant women who develop GDM in the earlier weeks of pregnancy are likely to have a delayed diagnosis and may not receive appropriate medical care. That is the message I want to convey here. And then pattern of glycemia in normal pregnancy, it's all this. I just want to share with you. Fasting blood sugar, the particular target should be 71 plus or 9. The normal value is normal pregnancy, 2 or is less than 10. Suppose you want to have real control of blood sugar, if at all, if this should be the pattern of normal pregnancy. No, whatever you follow Western book, don't go. They themselves agree now, this should be at this level. And we also done here, target what we have done here will be fasting 8 to 90, because we got reference for this work. Postprandial personal 110, 120, and mean will be 95 100. This is very, very essential, because otherwise the diabetes will become from the pandemic, now it will become universal. The goal is to obtain newborn baby's birth weight appropriate for gestation age between 2.5 and 3.5. A step to prevent offspring developing diabetes. So your aim should be, child should be only 2.3, but not less or not more. A step to prevent offspring developing diabetes mellitus. So this slide will show you, suppose a child was born so between 2.5 to 3.5 is ideal. For less than 2.5, the child, then when she grows up, she will become diabetic. Same way, more than 4.5, she will become diabetic. The message is here, better to aim for 2.5, 3.5. Here I will tell you one small message here. Potential pathways explaining the relationship between under and overnutrition. Poor malnutrition, reduced birth weight, increased appetite, early postnatal life, catch-up growth, rapid postnatal growth, altered leptin synthesis and secretion, increased visceral adiposity, peripheral resistance, diabetes. And finally, here, when they increase food intake, decrease food expenditure, neuroendocrine, pancreatic, skeletal muscle, and adiposity dysfunction, increased adiposity, insulin resistance, future adult disease. So, the message is here, whether it's undernutrition or overnutrition or small for gestation, or both can develop diabetes. So, I was very careful to bring it 2.5 to 3.5. We can do that. In fact, our diabetes awareness project we have done, National Family Health Survey, it's a small gestation was about 17%, brought it down to 10.5, 41%. Then LGA 19%, we brought it down to 63% less. So this single initiative achieving birth weight of infants appropriate for gestation age would have significant positive effect on the overall health of the family and the community. So spectrum will be here completing my talk here. While it may be consequence of maternal glycemic only, other nutrients such as amino acids and fatty acids and or hormones, cytokines could also contribute, particularly in the pregnancies of obese mothers, in whom glucose tolerance is normal, but cord blood CPET levels are shown to be elevated at birth. So what is the consequence of that here? It's a frightening paper. I'm really unhappy to see this paper, but I have to share with you. A study published in American Government College of Obstetrics and Gynecology suggests that women who are obese during pregnancy may be more likely to have infertile sons. That is what I'm really taken aback on seeing this paper. But more likely to have infertile sons. The researchers say that maternal overweight may be tied to hormone imbalance that affect the development of male offspring's reproductive system. This is very, very dangerous thing to happen, and we have to take very, very care that overweight should be avoided, as Rajput was telling here. That very careful, overweight should not occur in the during pregnancy. So this study, which included 9,000 women and women aged between 30 and 34, found that sons born to overweight mothers were 40% more likely to be infertile than those born to mothers or non-weight. So it's a very pitiable statement I made here, but you have to believe that this is published data. So we have to advise, we must advise silently without telling this is going to happen. You tell them, please maintain your weight, not to gain weight. That's what I must, my final message. Now friends, female gender, the key to NCD prevention is with healthy pregnancy, low birth weight or large gestation age, elevated risk of obesity, diabetes, hypertension, CVD, intergenerational cancer cases from one generation to another generation, because they link to the cancer epidemic. That is a matter of health. So, prevention of non-communicable diseases, preventive measures against NCD should start during interactive period and continue throughout life from early childhood. And GDM offers an important opportunity for the development, testing, and implementation of the clinical strategies for NCD prevention. So, my final message will be here. It is necessary to optimize metabolic control early in pregnancy. This will necessitate pre-pregnancy planning for women with pre-existing diabetes as well as for those at increased risk of GDM. Better means of safely normalized glycemia. So GDM, we all should remember, GDM is the mother of non-communicable diseases. That should be gone to everybody's mind. And then finally, the Norman Frankel is a great fellow. No single period in human development provides greater potential than pregnancy, or long-range payoff by a relatively short-range period of midnight metabolic impulse. A short period, if you take care, probably you can avoid the child becoming diabetes in the future. So I started with the Chanakya, compliment talk here. The womb is more important than the home. Hence, we have to focus on the fetus for the future. That is what I started with the womb. I'm going to complete the same statement of the Sankhya. And finally, it all starts in intro. Now we are thinking of accept that all starts in intro and as opined by Chanakya. Thank you very much for your passion here. Thank you very much.
Thank you, sir. Thank you for a nice presentation. We had a question hours at the end, so please wait. So, I'm Dr. Suranjit Barua from Guwahati, Senior Medical Consultant and Diabetologist, and presently Secretary in Northeastern Diabetes Society. In the beginning, I thank the team RSSDI President Dr. Bansi Sabo and the Secretary Sanjay Agarwal for inviting me to today's program. As you all know, this year insulin has completed 100 years, and during this journey of 100 years, there are newer molecules has come up of the newer different types of molecules of insulin has come into the market, and which has changed the scenario of treatment of diabetes last 15-20 years. And all the molecules come up with evidence in their support with different studies showing the benefit of that particular molecule with lesser side effects. So to speak on this landmark trials of insulin impacting clinical practice, we have amongst us today Dr. A.K. Das, who doesn't need introduction in any medical forum of this country. He is a well-known stalwart in the field of diabetes, a guide, philosopher, and a teacher of many teachers. And over and above, he is a person with amicable personality and a true gentleman par excellence. And Dr. Das sir has presently Professor of Medicine and Professor Head of the Endocrinology, Pondicherry Institute of Medical Science. He was formerly Senior Professor of Medicine and Endocrinology, Head of the Department of Endocrinology, and Dean and Medical Superintendent of Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry. Dr. Das sir has taught the medical undergraduates and postgraduates in medicine and diabetology for more than 33 years. He is a member of Physicians Research Foundation, Association of Physicians of India. He is a patron of RSSDI. And with this word, I welcome you, sir. And please go ahead with your presentation.
Thank you, Dr. Suranjit, for this very warm introduction. I remember when I met you in the NetScan and when you took over, dear friends, it's a great honor and pleasure to be here. And I must tell you that it is my great honor to speak on a topic which Chairperson has introduced fabulously. This is the year of centenary of insulin. And we are going to discuss what are the landmark trials in insulin, which has greatly impacted the clinical practice. So now, dear friends, I must tell you that I wanted to look to the what are the impacted clinical practice. I found this definition. The landmark trials impacting clinical practice are those, number one, who are an important stage in the development of a molecule or a turning point in the history. Number two, it has mid-course correction of the history and also on which the further improvement depends. And the third, these trials are noticed and looked by everyone working in various fields on insulin and diabetes, and this contribute to patients' outcome. Taking that into view, my dear friends, I have in the next 25 minutes or less to present a few things about the landmark trials. Dear friends, the landmark trials to my mind are the DCCT, the EDIC trial, the UKPDS and the UKPDS follow-up trial, the Origin trial, the Accord trial. Little less in order and importance will be Kumamoto trial, but it's a great message and impact in the clinical practice, which has been reiterated this year about 3 months back, which said that what is important in diabetes management is the insulin management in the first year of diabetes. The DEVOTE trial, the BRIGHT and the CONCLUDE trial, the ONSET trial. But what is most important is that can we reverse diabetes with insulin early on? I'll talk about that particular trial with one slide, the reversal, quote unquote, cure of type 2 diabetes mellitus with early insulin, not more than 2 to 4 weeks. And we get benefit for up to 5 years. And of course, few trials which I'll just touch upon, like BADT trial, etc., which I'll have no time to go in detail. This one is historically important, my dear friends. This is the first trial, the first RCT published in diabetes medicine. And you know, it's a very small trial, but it led to the use of synthetic insulins. It's a comparison between the pork insulin and the human insulin. And it suggested that in the absence of insulin antibody level, there is a simple pharmacokinetic difference between the human and the pork insulin. We may be in our structure closer to pork, but there's a difference, and human insulin stands out head and shoulder above any animal insulin, including pork insulin. Mind you, friends, this is the first trial where the use of the supremacy of human insulin was to be established beyond the animal insulin. I've just brought it for the point of view of history, because the first RCT, small, but it laid greatest impact, the use of synthetic insulins. And you know, from that day onwards, it is said there's a relentless advance against relentless disease. That means the insulin advances from that day have been relentless and against a disease which is equally relentless. Dear friends, we'll come to one of the most important trial of insulin, which has impacted the scenario maximum. This is the DCCT trial. Dear friends, I'll be putting the points which are not ordinary. So even if you know the trial, I like you to kindly look into it and just give it a listen with a very casual manner, because I'm just speaking to you that the diabetes control and complication trial opened the floodgates of adequate and strict glycemic control, because it showed that in the intensive arm, vis-a-vis the conventional group, we found that if you want to establish a blood sugar level between 70 and 120 in type 1 diabetics, and postprandial 180, and at about 3 a.m. once or twice in a month, about 70, and H1C 6.5 and below, one has to take about 3 injections of insulin a day or even more. One has to do almost 4 blood glucose tests daily. Patient has to be hospitalized for initiating treatment and has to undergo comprehensive education program and has to frequent dietary instructions, and after that, monthly clinic visits. Dear friends, this is contradistinction to a conventional treatment group where it was only objective was to avoid symptoms of hyper or hypoglycemia, only 1 or 2 insulin injections per day, daily self-monitoring only once, initial diet and exercise education, nothing beyond that, and one can visit once in 3 months. Dear friend, lo and behold, this necessity has clearly established before us that the intensive therapy group reduced and maintained H1C at a lower level. It was between 7 and 6.5. And it showed in both the cohort, in the primary cohort and secondary cohort, there's a great reduction of microalbuminuria, retinopathy, and neuropathy. Even though it looks simple, the message is great, the impact is great. It says 2 things. Number 1, that if you control the blood glucose intensely, and that's why we have used the word here, intensely, then you find there's a great benefit of the complications. Needless to mention, treatment of diabetes is in a great way the treatment of complications. It also shows the number of visits are important. Please look into the hidden aspects of the study. The patient who goes to doctor maximum number of times or in the appointed times, here the patient was going every month, contradistinction to people who are going every 3 months. The tenacity of purpose was very intense in the first group, vis-a-vis not so intense in the secondary group. Therefore, the impact of this trial, apart from showing that the strict control is of paramount importance, it also shows that one doctor, the physicians, and of course the people with diabetes, child with diabetes, type 1 diabetes, should have that mindset that I will control, maximal control. I will visit doctor in the appointed time. If it is 15 days, 1 month, is perfectly all right. And that has given the salutary effect. But there's a small trade-off. The trade-off between the strict glucose control and the hypoglycemia, as expected, there was severe degree of hyperglycemia, but you see the retinopathy has come down. The lower the H1C, the lower the retinopathy. This is a very beautiful slide. And it says, it said that the risk of retinopathy progression, and retinopathy is equated to diabetic complications, similar with microalbuminuria progression, is related to H1C. Now, as the H1C goes higher and higher, from 5 to 6, 6 to 7, 6 to 8, the retinopathy and microalbuminuria goes higher. It looks very simple, but put your hand on the heart and say, how many of us and how many of our patients do this practice? So very, very important message, impact for this trial, that we have to bring down the H1C as low as possible. Therefore, the impact are 3. Number 1, intensive therapy can improve glycemic control significantly. We have in the armamentarium of insulin, which can bring down the H1C to 6.5 and below. It can reduce the occurrence and the progression of the microvascular, not the macrovascular. Macrovascular is multifactorial, but microvascular complications can be controlled. And there's a continuous relationship between the glycemic control and the risk of developing retinopathy and microalbuminuria. The risk of hypoglycemia goes up. In this study, it was almost 3-fold. Nevertheless, I repeat, nevertheless, intensive therapy did not affect the quality of life, the QOL, the cognitive function, and the cardiovascular death. There was hypoglycemia, which was acceptable. I remember Robert Holman, whose father was a governor in Tamil Nadu. He used to say there was hypoglycemia, but take it or leave it. I mean, they all carried out very well with minimal therapy. But dear friends, the message I want to give is the message that is hidden in the EDIC study, Epidemiology of Diabetes and Intensive Intervention and Complication Study. Epidemiology of Diabetes Intervention and Complication Study. Dear friends, this is again about intensive insulin treatment, but in different manner. The EDIC study showed it was these city patients were followed up for 7 years. The risk factors for the long-term microvascular and macrovascular complications. Prior diabetes treatment was good. Level of glycemic control DCT was excellent. And all patients are advised to take intensive insulin therapy. But lo and behold, it was found that intensive therapy significantly reduced the HbA1c and also maintained it. But there was another group, the conventional group, encouraged to switch to intensive group, and the intensive group, after they were not asked to become conventional, but after some time they lost the tenacity of seriousness and they also became the conventional group. Now it was seen that the glycemic control throughout the trial, both in the conventional group and the intensive group, was little let loose. Instead of 6.5, it was almost up to 8 in the intensive group, and similar to conventional group, because the intensive group has also let loose and become conventional. But what is most important, that the microvascular complete reduction was ingrained again in the intensive group. You find the intensive group, in spite of H1C going up to 8.75, almost up to 9, the complication profile was much better. And you find, compared to the conventional group, the earlier intensive group, who had the early aggressive control, in spite of the blood glucose going loose and H1C becoming 8.75, 8.9, and 9, they still maintain a lower incidence of the microvascular complications. Therefore, in the microvascular complications, the AD group, at the end of 4 years, RRR, relative risk reduction, was 76%. Microalbuminuria at 8 years of conventional control follow-up was 59%. Clinical albuminuria, 85%, and neuropathy at 43%. Look at these numbers, and this shows that early aggressive control is worthwhile. It again echoes what has shown recently, that the first year, I again remind you, this is the 2021 message, the first year diabetes control. The patient sits before you. What you do for the first year is of paramount importance. There was severity risk reduction of intensive therapy in 10 years after DCCT, and you find that the risk of any CVD events here and the risk of non-fatal MI, stroke and death from CVD given here, which is very significant. Therefore, the impact are glycemic control in the intensively treated group, equivalent to that of conventional treatment group in the follow-up period. They have let loose, they become equivalent to the conventional group. However, reduction in the microvascular and also reduction in the macrovascular does continue. And in intensively treated group, it persists. That is the message. This is called the legacy effect. All of you know it. I will not carry cold to Newcastle. This is the metabolic memory. It is believed that the good metabolic control gets imprinted in the mitochondria of the patient cells, and that gives the long-term effect of early intensive glucose control, can give a long-term rates of microvascular complication, which are very low. We'll change gears and go to the type 2 diabetes. Again, I'm taking a very well-known trial, but I'll present it differently. I prepare differently. It's the UKP trial, United Kingdom Progressive Diabetes Study. And you know, this is told today as the compendium of type 2 diabetes in the world. It is so famous a study. It's a 30-year study, 30 number of year study. It started 20 years with the intervention trial from 1977 to 1997. There were 10-year follow-up beyond 97 to 2007, and further follow-up is coming. In the first, and this was the intensive control time. This was the post-trial monitoring time when there is control was not very great. But you know, the annual follow-up of the survivors was clinic based for the 5 years, and the questionnaire based was the last 5 years questionnaire based. The median follow-up was 17, but the real follow-up was almost up to 30 years. Now, what did it show? I will save time not going to the numbers, but you find that whenever they had the intensive group, in contradistinction to the conventional group, in both the arms, it was observed retinopathy, nephropathy, and possibly neuropathy are benefited by lowering blood glucose levels in type 2 diabetes in the intensive therapy. And mind you, they had urea and insulin. and sometimes they had metformin and intensive group of metformin. Those who were obese diabetic, that metformin with insulin. So insulin was the fundamental treatment in the either group, which achieved the median H1C of 7, compared with the conventional therapy, which had a median H1C of say 7.9 or 8. The overall microvascular complication reduced by 25%. This is BB Tripathy Hall, my teacher, my mentor. He used to show the hands like this. Mohan is here, Professor is here. That in the 7 and 7.9 matters. How it matters? It matters in 1/4. So, my dear friends, even little lowering of H1C gives you maximum result. There's a continuous relationship between the risk of microvascular complications and glycemia, such that every percentage decrease, 9 to 8, 8 to 7, 7 to 6, there's a 35%, more than 1/3 reduction in the risk of complications. That is the message from the study. And you know, no significant effect of lowering blood glucose on cardiovascular complications observed. Yes, but even though it was not a severity trial, did not show the 3-point, 5-point MACE, heart failure will come a little later. But there was a 16% reduction in the risk of combined fatal and non-fatal myocardial infarction. Not small, 16% reduction in the combined fatal or non-fatal MI, and the P was significant at 0.05, which is significant. Epidemiological analysis showed a continuous association between the risk of cardiovascular and glycemia. The sugar is high, the severe complications high. Therefore, for every percentage point decrease H1C from 9 to 8, again 25% reduction in the diabetes-related death, 7% reduction in the all-cause mortality, and 18% reduction in the fatal and non-fatal myocardial MI. So, dear friends, this study is great to my mind, and this is a compendium of type 2 diabetes and its complication even today in 2021. Now comes the real pudding of the study. Now look at here. UKPDS follow-up study. It was found that all surviving. There were about 3,300 patients were enrolled in the post-trial monitoring program on September 97 for 10 years, 2007. And now this is again similar to EDIC study. The control was not strong. They all came down to the conventional group, and they wanted to see whether the earlier control had a long-term effect on the macrovascular outcome and, of course, microvascular outcome. Now, you see, these are the groups I told you, the SU insulin group and the metformin group and metformin intensive group also received insulin, And, I'll make a long story short. This is published in UKPDS 80, number 80 study. You look at any diabetes endpoint. I have no time to get into it. There's a difference between the SU insulin group and the conventional group. You see the event rate is lower. Look at this. The conventional therapy and SU insulin, death from any cause is lower. Look at this myocardial infarction, it is lower. Look at the microvascular disease is lower. And if you look at the benefit of the early tight control, what I'm calling today first year control, UKPDS, and 10 years post-trial follow-up period, you take any diabetes-related endpoint, at the end of the trial was 12%, at the end of 10 years beyond strict control was 9%, comparable. The reduction in the trial end of the complication 25%. Here it was almost 24%. By microvascular disease, 25% reduction, 24% even after 10 years in the group control. The myocardial infarction 16% reduction, as I showed you little before, it was to 15%. So it summarizes to say that in type 2 diabetes, if you control early on, great. If your control early on is severe, then you get the benefits even after many, many years. So UKPDS 80 showed extended effect of improved glycemic control patient with a newly diagnosed type 2 diabetes mellitus, observed up to 30 years. Benefits of intensive control in type 2 diabetes was sustained 10 years after cessation of the randomization of intervention, that is up to 30 years. Original intervention trial conclusively demonstrated benefits of glycemic control, reducing microvascular risk. Our risk reduction of the MI and death from any cause emerged only during the post-trial follow-up, because we have to have number of years more and multifactorial, which we get this. Strengthen the relationship for achieving optimal glycemic control early and indicate emergence of long-term benefits on cardiovascular risk. Dear friends, I will just change the gear here and go to a very simple study, but highly impactful study, is the Kumamoto study. The Japanese Kumamoto study, the number of patients were much less, but there was a primary intervention cohort and the secondary intervention cohort in the Japanese. The conventional group received once or twice daily injections of intermediate acting insulin. Intensive group received short acting insulin, say human insulin or Arpidra or Actrapid, received 3 times, and intermediate acting insulin bedtime. So something like a basal bolus in the intensive group. Lo and behold, you will find in the conventional group, the patients had retinopathy much more compared to the intensive group, where it was much less. Dear friends, the development of the and progression of the diabetic micro complications in the conventional group was high, 68% vis-a-vis 20%, 74 less than 20. And the urinary albumin excretion 100% less than almost nil. So this shows both in the primary and secondary group the development of the progression in the intensive glycemic control group can delay the occurrence, the onset, and also delay the progression of the early stages of diabetic microvascular complication in Japanese patients. I will stop here, but I'll discuss 1 minute on this. This is the study I was referring to. I have not brought much material to show you because it is well in before of us in the literature. Same in the area of Kumamoto. It was shown you have a short-term intensive insulin therapy in the young diabetics and control the hypoglycemia. The beta cell function improves, insulin resistance improves, and these people can achieve a long-term drug-free glycemic remission. Drug-free glycemic remission at the end of three months, about 2/3 of the patients were drug-free. They were not getting any longer insulin, but they were in remission. At the 6 months, 60% were in remission. 12 months, 50% remission. At the end of 2 years, 42% of remission. So, dear friends, highly impactful study on insulin, that if you give to the young onset type 2 diabetics of hyperglycemia earlier insulin, for how long? Not long, 2 to 4 weeks, you can reap the benefit of the end of 4 years, up to the end of 2 years, having a control for life. Dear friends, I do understand that we have to close, so I'll be a little faster. Give me about 5 minutes extra. I'll just bring home to you 2 trials on the cardiovascular outcome. One is Origin trial, and our friend Ramchandran, my classmate, was the head of the Origin trial, and it was a study on the glargine, and it was an outcome reduction with an initial glargine intervention to Origin. Now, what was the objective of the Origin trial? To see whether the new or recently diagnosed diabetes or IFG or IGT or with additional CV risk factors, if you give them glargine, follow for 6 years, what is the effect of the insulin glargine on the CV outcome? And that time there is a fear of cancer, whether it can produce cancer. So, dear friends, Origin trial was based on the CV outcome, whether insulin making the CV outcome worse. I'll repeat again, whether glargine will make the CV outcome worse, whether they will develop cancer. Now, insulin glargine was added to nil or maximum 1 oral agent. In the standard care, there was 2 OADs, no glargine was used. You look, when the glargine was given, the blood glucose control was absolutely fabulous, 79 to 104 versus 103 to 142. And beyond anybody's imagination, glargine showed new diabetes developed in less number of cases, 24.7 versus 31.2 in the standard therapy. And there's attenuated effect noted even after second OGTT. And in people who are at risk for the future diabetes, the pre-diabetes people, 6 years of basal insulin glargine titrated to normal FPG and reduced the incidence of the diabetes. Of course, with those who are on glargine, the weight went up to 1.6 and the BMI went 0.81. And there was little bit of hypoglycemia. But what was important was the implications, what I want to bring to you, compared to standard therapy, type 2 diabetes, IGT or IFG, using once daily basal insulin to target FPG of 95 or below for 6.2 years, take 6 years, maintain near normal glycemic control. It has neutral effect on the CV outcome. It was not CV enemy. The effect was neutral and cancer was not found. There was slow progression of dysglycemia. I'll repeat twice. Progression of the dysglycemia. There was modest increase in the weight. And definitely basal insulin glargine slowed the dysglycemia production. It is again shown here that in approximately at the end of 6 years, the clinical trial designed to assess the effect of the treatment with insulin glargine versus standard care, it showed very clearly the insulin glargine, when used to target FPG for more than 6 years, has a neutral effect on the cardiovascular outcome. It is cardio safe and it is better for the dysglycemia, and it also reduces severe risk factors. The insulin glargine, when used to target FPG for more than 6 years, has a neutral effect on cancer. It has good effect on the dysglycemia, severe risk factors, and was cardiovascular friendly. Dear friends, I have no time to get in detail. The 3 take-home from origin trial: glargine has neutral effect on incidence of cancer and severe risk factor. Use of glargine with a sustained reduction both H1C and FPG, and glargine may delay the progression of type 2 diabetes, prediabetes. Dear friend, I will not spend time on this. It's a devote trial. It's not equal, trial with the equals. It is the trial between the degludec versus glargine U100, not glargine U300, and it showed it has a cardiovascular benefit, and it showed that there is severe safety of the degludec. We use it today plenty as alone or as a co-formulation, and we found the 40% lower incidence of hypoglycemia, but it has a great cardiovascular benefit. Last 2 trials I'll allude to is BRIGHT and conclude. These second generation basal insulin trials. It was between the BRIGHT, the Toujeo insulin, and the degludec insulin, the degludec versus glargine U300. Now it showed that the degludec has little age above the glargine 300, except in the titration period. In the titration period, the hypoglycemia was less in the glargine U300 Toujeo. Other time, the hypoglycemia was little more than the degludec. So degludec was little scored above than that. So this is the comparable. I will not take you details because already 8:35, and I'm acutely concerned that I should finish in time. Now about the few trials, about the trial with the bolus insulin like FIASP trial, the rapid acting insulin trial. There are many trials, but why I'm showing this, because during the time of the COVID-19, we have used FIASP very, very sincerely. Large number of patients to bring down the hyperglycemia early on. We have been benefited. And this was the onset trial, which showed that in type 1 diabetes, this fast-acting aspart can be more physiological and can replace early insulin secretion, better profile for the pump therapy. And also compared to insulin aspart, it has twice as fast onset of appearance, which is required in a case of cancer, COVID-19 diabetes, and 2-fold higher insulin exposure within the first 30 minutes. I will not go in details of it to save time. And to conclude, dear friends, over the years, various landmark trials have used. I have got about 79 trials. Bansi, I'll talk about on some other time. But I must tell you that over the years, the various landmark trials have provided. This is another trial called the intensive trial. You know what it was? It was a trial to approve that the fast-acting insulin aspart, FIASP, was beneficial in children. So I don't have to, this is not a landmark trial. I'm describing it to you. 79 other trials have got off my cuff. I will not go into details of it, but I'll just end by saying that, that over the years, various landmark trials have provided useful insights into management of diabetes. UKPDS, widely conceived as a mother of all trials, the compendium of all the trials, with regard to the insulin landmark trials like necessity edict, UKPDS follow-up, we know today that the early glycemic control with insulin matters. We know from the origin trial and other trials, they are cardiovascular friendly. They do not produce cardiovascular insulin. They're cancer friendly. There are many other smaller trials, which we'll discuss some other time. So I'm extremely happy, my dear friend, on the 100 years of insulin discovery to present to you the few landmark trials. Please remember, the take home, diabetes is bad because of complications. The faster glucose control matters, and that gives the longer life, complication-free survival, and gives you the full value of what you spend in the first year. Thank you very much, and thank you, Suranjan ji and Jishi Reddy sir, for tolerating me. Thank you, my dear audience, for staying with me. We can have few questions. Bye-bye.
Thank you, sir, for your very nice presentation. You covered the subject, and in this sort of time, you have make a run of this 100 years. And the topic is now open for discussion. Anybody has got any question or comment, you can just give it. Let me check the chat box.
I have a question for my teacher, for my mentor, Professor Sesha. Chairman sir, can I ask it?
Yes.
Sir, the question that I would like to ask you, that Chanakya has been celebrated as the Kautilya means Kautilya Marga, the most diplomatic person in the world that we have seen. Kautilya. So that is the Kautilya mark where all the diplomatic enclaves are present. Now, when Chanakya stayed, all these plants will be warm. He knew it for certainty that that the womb gives you insight to the womb, insight to the growth, insight to what are the casting things. My point, sir, that even though we diagnose the pregnancy about normally we know it by 12 weeks. People do not come for checking till 8 weeks. How can we establish early aggressive blood glucose control unless you have some way of catching them early, catching them younger than 4 weeks post gestation, 8 weeks post gestation, definitely not 24 weeks, you rightly said, sir. How can you catch them early? Bhaktarani is here. Bhaktarani
So of course, by 3 weeks, we can do serum hydroxy.
it can be only done by the pre-pregnancy clinic and fit to be mom clinics. Otherwise, we'll miss it, Bhaktarani. Somebody has conceived today. He is not
No,
going to
from
come
the
in
menstrual cycle. From the menstrual cycle, first
Yeah,
day,
that's what I'm
third
telling
week, we can find out by serum.
Yeah, but they do not come. They do not come. You have a concept fit to be mom. You have a concept that they come early, then we can possibly do it. And also, I want to tell sir, Professor Sheshar, my mentor, my teacher, sir, what it shows that Barker is Barker. I went to meet him. The Helson Barker hypothesis. I went to Southampton to see him. Sir, we should also give credit to Chanakya. We should say it is not only Barker's hypothesis, Suranjanda, it is also hypothesis of the Indian sage who said that Om is the time when everything happens. This is Edisam and Namaskaram. So it is not only the Barker, but much before Barker and Hels, we have this concept. I think this we also have to recognize.
Thank you, sir, for a nice question and comments. In the chat box,
I totally agree with Ashok. So to convince the people, and more than it was saying, now I say, I was this Rajput also was telling, this is, you must idea that the early visa screening is better. Yeah, at least by 9th week, because before all the completed, at least the woman must be screened for pregnancy. She is married the period. So 4th week or 5th week.
Yeah, I think when I heard Rajesh thoroughly for the entire talk, his talk on the how do we, I never knew that preventing GDM through diet and weight reduction was so important, and it is so beautifully. So I think, sir, this year's World Diabetes Day slogan is access to diabetes care. And sir, we have to provide access to the pregnancy care, access to the, am I correct, Suranjit, to the diabetes care, where people can have access to early diagnosis of GD. And I'm very confident about it, sir, because the entire future of the home, of the child at home depends on the early diagnosis. So we provide access to the early GDM diagnosis, and we have to make that.
I say, Ashok, I agree with you. Now, as I told about that our ideal president, from epidemic it is going to pandemic. Before it became universal, it take some measures, and government of India or all the government must act now. See that all the women who are getting must go and check, or when they register for the marriage certificate, they check, they said you must get a certificate of blood sugar or not, and then they must be all put in the report. If you ask me, the most important persons who can obstetricians, they must put in every clinic board, please check your blood sugar and before you married or after missing the period, if you come there, etc. If there's simple message, screen for glucose tolerance before marriage, or even after missing the period, please check, because that is the only way we can. Unless education is very, very important, awareness is very, very important.
And it must be delivered at the doorstep, sir. Government
Yeah,
can do it. Government can do it. The lady can just be carrying
No, the most important thing is audio visual, TV screens, but paper all won't do it. TV is the best.
That is the great. And sir, before I close, I will also tell before he's going. We had time up to 8:45, sir. Now to 8:46. 1 minute extra with Chairman Sir's permission. I must tell you that I have in front of Suranjan da, Amar Bhitore ek dono ache, ekti aadmi ache. I'm speaking in our language, Dada, that at the time of diagnosis, you don't give insulin, but you show him the vial. That this is called insulin, this life-saving. And the gentleman who gave me this concept is in front of me. And he said that you show him this. I'm not giving you this today. But Bete, my dear friend, Mr. So-and-so, please remember that you will need it sometime. And if you take it early on for a short term, that's called short-term insulin therapy. And we are discussing that in the NIS, National Institute Summit this time. I want you to join that. I'll send you the link. If you use this insulin for short term in the beginning, short term means how long? Maybe about 2 weeks. After diagnosis, your blood sugar is about say 200, about 250, then you will reap the consequence for a long time. So early short-term insulin must be given to the patient, and if it is given early, they will take it. And the second thing I want to tell you, me and Krishna Sastadri, we have written a narration, the narrative review, that first year diabetes control is very important. If this message goes, Chairman sir, Reddy sir is here and you are here. Sir, I mentioned that the next con, he called me. Last 2 years, he has not called me. I have not gone, sir. I went back. I must tell you, fabulous thing. And if this message goes across the country, that the moment diabetes diagnosed, careful for at least 1 year in the beginning, and you will reap the consequence for a long time, and the great service to the mankind. I'm extremely happy on the insulin centenary year. We're discussing about the impacting trials. And the impacting trials have shown us. It has also shown us, I think what to tell now, with the permission, it also showed us, be sensitive, use your common sense. Don't bring down for the 87-year-old man H1/6, because accord the action to control whatever the risk factors in the diabetes study group, accord study, sir, rightly, I cannot tell to my teacher. It showed that if you mindless, without giving an importance, bring down everybody 6, there was fatality, it was 3%, 21%. And they all escaped because but the issue, they immediately study was suspended. So it also, the insulin trial also had shown high impact in the accord study, that you have to customize. You have to customize your response on the age. And we know it today for a 87-year-old man who first died in the first study. Probably it was maybe about 8 or 8.5 was the customized H1C, not never 6. And sir, I remember when I was in the Minneapolis, in the Park Nicolette, sir, they will show all the dust must come down, like Professor Moses used to explain, must come down to 6, must come down to 6. They have bullet points, sir, like the pins, no, sir. They have pins on their study room. All the points, lying at 6.5, bring it down to 6, bring it down to 6. Somebody else's heart, somebody else's body, and they all die. So I think one lesson, Suranjanji and Jishi Reddy Sahab, I will tell you that one impact that you must, you cannot mindlessly, and even if you do not bring it down to 6, sir, from 9, you bring it down to 8.5, bring it down to 8, the benefits are 25%. So we should not, that is that don't do harm teaching. So the insulin trials also has impacted to say that we customize reduction, don't do it mindless reduction. It also has shown us that insulin never says no. Insulin never fails. Insulin gives a great sense of well-being. Insulin for life. And today I'll be talking, sir, in a meeting called Insulin in India, a privilege or a right. Insulin is the right of everybody who needs it. Am I correct, Chairman, sir? Insulin must be available.
Yes.
Light, water, and air
Hello.
for type 1 diabetes. It's available. We
Hello.
have the human insulin. We have the which is lower, but at the same time, it's also a privilege. We have best variety of insulin. We have got the best insulin, very affordable price, differential price compared to the Europe and US. So that's my submission. My regards to my teacher and my dear friend Suranjanda. I'm happy to meet you, Dr. Mr. and
Dr.
Jishi Reddy sir. Thank you very much.
Shashaya sir. And as there is no more question, I think we can wind up here. Can I have any word from Professor J.C. Reddy, sir? You like to add anything?
Jishi, you like to say something? Suranjanda is asking you.
Hello.
Jishi, anything like to say? Professor Reddy is the senior most
I think
in the country.
time is over, no? Dr. Sujit Barwa. Yeah.
But still, you can say one or two words, sir.
You can do it if you want. Hello. Yes, you can ask if you want to add anything.
You can speak for a minute, sir. We want to listen to you.
Dr. Sujit Barwa. Yes. Please go ahead.
As the time is up, can we wind up?
Okay.
Yeah. If you, with your permission, I can wind up now. Thank you, sir. And
thank
this
you.
will close down and we'll back to organizers.
Thank you. Sir, thank you.
Hello.
Thank you, Surajanda. Thank you. We'll be this time in.
Hello.
Yes, I think this room in charge is Balu. I think will take over. Hardik, you can take over. Channel 7 hand over to you.
Able to hear me?
Take over. We have finished. We have finished this.
Yeah, there is no more follow-up sessions. I
When
think
we
we'll close down here.
Last session of the day, sir. Last session of the day. That's why we could have little more discussion. Last session of the day. Thank you, sir. They will take up now.
Okay, then. Thank you.
Hello.
Nice meeting you.
Dr. Barwa.
Yes.
End of the session.
Yeah.
Dr. Barwa.
Yes.
Sujit Barwa. I am Dr.
Yes. Just go ahead.
Are there any questions directed to first speaker?
Yeah, we have discussed the questions, sir. Anything else has come to you, you can tell us. Otherwise, the questions and the answers we have finished.
Okay, the takeaway point from the first lecture, at the time was up, I was in a hurry. So I asked to Dr. Barwa to speak. Now the first speaker's take-home message is that good control from the early detection and tight control of metabolic events, the TDM, prevents the complications for the both mother and fetus. If not, it leads to not only lead to large baby and also there is a insulin resistance for the mother. So in that way, his point is as projection of uteroplacental unit and its impact is high, nicely alluded by Dr. Visheshaya. With this, I thank you, Bharavan.
Okay, welcome, sir.
I'm Dr. Visheshaya. Can you wind up?
Yeah, we are initiating this session. Thank you, everyone, for joining today.
Okay.
Thank you.
Wind up,
Yeah. Thank you, sir. I'm leaving.
Sir.